recognized ways. And I think I would just like to emphasize that if you look at uh, the list here, during midlife, which I'm glad to see only ends at the age of 65, there are a number of potentially modifiable risk factors, including vascular risk factors like hypertension and lifestyle issues like obesity. And as we go on into later life, there are other risk factors which are potentially modifiable. And you've heard from Mia that what her team did in view of the uh, somewhat disappointing results from previous lifestyle modification studies, which really only focused on modifying one lifestyle factor at a time, that was that if you have intensive multi-domain lifestyle intervention, as you can see here in nutrition and exercise, plus cognitive training and monitoring of and management of vascular risk factors over the 2 years of the trial, you could find that there was an impressive result. You can see here, not only in terms of the composite neuropsychological score, but also in executive functioning, processing speed, and in memory. Now, this result really knocked the socks off the audience at the AIC when Mia presented this. And in fact, it was such a tremendous result that I recall to my surprise being summoned by the CEO and chief executive of our university hospital to be asked what is going on. Is there really a way of preventing dementia? And why aren't we doing anything about it in Singapore? So I was embarrassed to say that we hadn't at that time conceived of doing a trial. And one of the problems, of course, was that we weren't sure whether these finger interventions, which worked in Finland, would be workable in Singapore. Um, I think that some of you will know that the Finns are very fond of saunas, and many of you here in Singapore would know that Singaporeans prefer to be clothed, and we also have an obsession about food. So would fussy Singaporeans who may not wish to have the same kind of interventions as the Finns, would we be able to have a similar trial in Singapore? Well, with the encouragement of the university, the first thing we did was to meet up with Mia at the Toronto AIC meeting in July 2016. And as you can see, here we are with Mia and my colleague Ed Koo, and Mia very kindly agreed that we should press on and try and work together on this. And as you know, there was the Worldwide Finger Consortium meeting in 2017, which we took part in. And importantly, I had the opportunity of visiting Finland in 2017 and 18. And here's a picture of me being introduced to new Nordic cuisine. And I was really pleased to know that in Finland, when they have new Nordic cuisine, it is not pickled herring and cold cuts, but actually we had fish curry. So my hopes were raised. And what we then proceeded to do was the finger pilot study, which took place from 2018 to 2019. On the way to Finland, I did read about what were the differences between Finland and Singapore. And as you can see, there were some interesting differences and similarities. We have the same amount of people, but Finland is much larger, of course. And it also has more universities and, curiously, more members of parliament. I think many people in Singapore already feel that 92 MPs is a lot, but Finland has 200. Finland also has a lot of saunas, and if you're here in Singapore, you know we don't really need saunas because Singapore is an open air sauna, and we have important visitors to summits. But we also share beautiful buildings and scenery, and I'm very sorry that those of you overseas are not here to join us in Singapore this year. But please do come. So We went on to do the Singer pilot study, and we based this on, of course, the finger study. And this was a randomized control study of these multiple interventions in elderly patients. And I was very, very grateful and fortunate to have colleagues such as Jay Henry, Summer Su, Effie Chu, to run the other components of this study. And we also got funding from Professor Brian Kennedy in the NUS Center for Healthy Aging. And what we were looking at was the feasibility and acceptability of finger versus Singaporean adaptations of the finger interventions. And this study wouldn't have been possible without the support of the Memory Aging Cognition Center, which I run, and for which we're very grateful that the National Medical Research Council of Singapore continues to fund. And to begin with, I really need to thank all my colleagues at the MACC, some of which I hope are on this call, because without their help, we wouldn't have been able to run the study. The study design was very simple. We screened subjects for eligibility. They had to be within a certain age. They had to be mildly to moderately frail. And we randomized them between the finger intervention and the Singer interventions. We had outcome measures at 3 months and 6 months. And the whole trial took about a year and a half. Sorry. Here you see the recruitment flow chart. We had to screen about nearly 300 subjects to get the 70 plus subjects that we randomized, and you can see the groups were randomized with very few people who dropped out. What were the differences between the different types of management? In terms of vascular management, the finger intervention relied upon the excellent primary healthcare system that you have in Finland, where the study team would simply write a polite letter to the general practitioner to say, well, there are some issues, could you sort it out? And that was it. So in Singapore, we felt that this might not be optimal, so we decided that to have the study team initiate and manage the vascular risk factors and initiate treatment as necessary. In terms of cognitive training, as you heard, the finger group relied on computer testing. In Singer, we thought that this might not be so easy in the elderly, and so we relied on paper and pencil tasks. Could you move? Oh, sorry. And in the diet portion, the Singer diet was simply an Asian adaptation of the principles of the New Nordic diet adapted for Singaporeans. This busy slide simply tells you that the groups were very equivalent in terms of vascular risk factors, lifestyle, and baseline assessments. There was a small difference in education and history of hypertension, but not really very significant. In terms of the primary outcome, I'm very glad to say that both the finger and the Singer interventions were feasible and highly acceptable to most of our subjects. The only significant difference was in cognitive training, in that those who were assigned the computerized training had difficulty doing this at home if they didn't have a computer, even though we gave subjects thumb drives to try and use it in public computers. In terms of efficacy, there really wasn't much difference between the two interventions. There was a small difference in terms of weight between the groups, again, very small and probably of no clinical significance. But otherwise, everything was equivalent, except for vascular risk factor control, especially for blood pressure. As you can see here, the Singer intervention resulted in more subjects having good blood pressure control at month 6 compared to the finger intervention. And this was particularly the case in those who had poor blood pressure control to begin with at the start of the study. in terms of cholesterol and diabetic outcomes, there really wasn't much difference. I'm very sorry, there seems to be a lag in this clicker. Okay, so at the end of the day, we decided that because they were equivalent, um, the preferred, sorry, let's go back one slide. Hmm. Okay. The preferred intervention was, much to our surprise, finger, 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 except for vascular risk factor control. So where do we go on now? Well, we were ambitious and decided to use the finger pilot study to develop a much larger study in Singaporeans. And we're very glad to report that this proposed study has been funded by the National Medical Research Council so that we will be able to recruit uh, in the next year or so 1,200 community dwelling elderly Singaporeans at risk of dementia to put them through a 2-year interventional program, either self-guided lifestyle management or structured lifestyle intervention. Plus, we are also able to investigate what Mia mentioned, the mechanisms behind these effects, in that we're going to perform MRIs and we're going to do blood tests as well as genetic tests to decide what is really underpinning the improvement in cognition in subjects on active intervention. And these are our colleagues in this large collaborative program, colleagues from all over Singapore, from many different institutions, both clinicians and basic scientists. And importantly, we also are including health economists to see how these results can change public and clinical policy development. So it's a great privilege to be working with all these wonderful colleagues in Singapore and across the world on this project. And of course, we've had COVID. COVID did have an impact on the Singer pilot study, but I'm very glad to say that we were able to overcome these challenges with the cooperation of our subjects as well as the dedication of our staff, so that we managed to collect most data. Nevertheless, we realize that the new normal is going to be difficult, in that safe distancing and social restrictions will impact on how we perform Singer in the future. So we're working very hard to develop appropriate methods to recruit, intervene, assess, and retain our subjects through more emphasis on digital recruitment and consent, web-based study materials, digitizing our assessments so as to reduce face-to-face meetings, to use podcasts and apps to try and educate and retain our subjects. And this, I think, trial is even more important now because, as Mia mentioned, we may be facing a tsunami of dementia, not just because of the social distancing and loneliness and the lack of access to physical activity and medical facilities, but also because the virus could directly damage the brain. So we are pinning our hope on a digital platform, as you can see here, which will allow us to do health monitoring, to evaluate and hopefully predict what's going to happen to our subjects. We're going to insert a lot of educational content and advice, and we're going to use these apps to better communicate with our subjects and hopefully, perhaps even do a trial better than the usual way that we've done a trial. We want to help subjects improve their health literacy, to facilitate self-management, and therefore improve health outcomes. Thank you very much for your attention.
Thank you, Chris. It was really great to see this adaptation, or how finger can be moved to different cultural context, and to see how you do this in Singapore. And also very interestingly, the impact of COVID-19, like how we now all have to adapt to and are inventive in the sense to continue our trials. We're a bit behind schedule, but I see there's still many questions coming in. So it's thank you to the audience for being so interactive. Maybe just two quick understand or follow-up questions to SINGER specifically is one question is do you plan to include any outcomes or participants like younger people with MCI, and can you talk about the makeup of the study team? Are these mainly medical doctors and nurses that can actually influence or impact people's health behaviors? And if you can be quick in with those answers, I'll try to find another quick one before we go on to Jill. Thanks.
Thank you. So quickly, we are going to try and recruit people at risk of dementia. So not patients with dementia already, or people at the more severe end of MCI. And we're also going to try and recruit the elderly. So perhaps somebody who's young and has MCI, I don't know how you define young, it may not be be included in the trial. Secondly, the personnel who are running the trial, I mean, in general, there will be, of course, doctors, but in general, there will be hopefully bright, young, personable coordinators who will engage with our subjects and not be too distant and dogmatic. We want people who are going to be able to encourage our subjects to adhere to their intervention and to work with them to achieve better health outcomes.
Thank you. And I have another good one. Do you think there are, or there might be genetic factors that might change the response or the way FINGER or SINGER works in Southeast Asia versus Finland?
Well, as Mia has said, even in patients with ApoE4, there was a beneficial effect. We have less ApoE4 frequency in Southeast Asians compared to Finns, but you're absolutely right. This is one of the research studies we're going to do. We're going to try and develop a risk factor profile, a genetic risk factor profile, to see whether we can identify who might benefit. And if I may go back to the previous question, obviously anybody in the audience who feels that they're one of these young, bright people who want to help us perform the trial, we're very, very pleased to hear from you.
Thanks. And maybe as a follow-up, Chris, another question was also around the differences that you saw in vascular risk factors for SINGER and FINGER, and now they may not be genetically, but can you elaborate on, or have you put any more thoughts on why you may have found these?
Right. Well, there's a very high prevalence of vascular risk factors in Singaporeans, especially hypertension. And what we were trying to do, which I should have mentioned, was that we were trying to implement a more rigorous blood pressure regime. We're adopting the SPRINT protocol to reach a SPRINT target. Now, some of you may have heard that there's been a wonderful new trial called SPRINT, which has established that a blood pressure target of 120 systolic is superior to conventional target of 130 or 140. So that's what we intend to do. And I think that one of the reasons why the study team was able to achieve this was that we're more attuned to this particular aim. But of course, I think with time, maybe this will become the standard, but we're trying to achieve that.
Yeah. Thank you. Very fascinating from a public health perspective, and also, nice seeing the how cardiovascular public health measures can impact on brain health. We could go on forever, but let's keep the other questions that are coming in for the discussion session afterwards. So thank you very much, Chris, once again. And I now like to introduce you to Jill Livingston, who's a professor of older people at the University College in London. She leads the Lancet International Commission on Dementia Prevention, Intervention and Care. I'm sure you all know Jill. Thank you very much for being here this morning. And Jill, the floor is yours.
Thank you very much. I'm going to move from talking about individual interventions to thinking a bit about policy, and I'm building on the Lancet Commission. I've really enjoyed the other people's, I've really enjoyed Mia and Christopher's presentation. It's made me look at my watch tracker, and I see that I have managed 148 steps this morning in the several hours since I got up, and I think that that's definitely COVID, because if I was in Singapore, it might take me a bit longer to get to the lecture room. I want to say, first of all, that the Lancet Commission is a commission of people around the world, and while I've led it, there are numerous other people whose names are on the slide who've been done lots of work in it, and it's their work as well. And in particular, I want to mention John Huntley, Andrew Summerlad and Nahid McAdam, who have worked with me in the systematic reviews and meta-analysis and the path calculations. And we've spent many, many hours in our desks at UCL when we used to go in there to work and to do this. But and we've also, we're supported in this work by UCL, by Alzheimer's Society, by the ESRC as part of our United Kingdom Research Institute, and Alzheimer's Research UK. So just to go back as to why we think that dementia is potentially preventable, or potentially it may get worse, is that while there are clearly, and as you all know, more people with dementia in the world as there is an older population, if we look at the prevalence and incidence, there's been a decreased prevalence and incidence in some countries, mainly in Western Europe and the United States, but there's been no decrease and a possible increase in East Asia, in Japan, South Korea, Hong Kong, Brazil, India, and also Brazil and India. So dementia potentially, but not inevitably, preventable, and it could increase if the risks begin to rise. And the reason why we think that, going right back to one of the reasons why we think that it's potentially preventable, there's two things that happen in dementia. First of all, there is neuropathology which causes the dementia, but it doesn't inevitably cause dementia. So if you look at this graph, and you look at the bottom one, at the bottom graph, you can see that in the bottom one, that dementia is in a group proportional to the amount of neuropathology. So people who have more neuropathology are more likely to have dementia, and people who have less are less likely, and the more neuropathology makes more severe dementia. But if you look at the individual graphs, which consider people who have look at people individually, then there's a huge overlap between the people in the top left-hand corner who have no dementia death and those people who have severe dementia. So on an individual basis, it's possible to have considerable amount of neuropathology without having any dementia. And we think that that is due to brain reserve. So any policies suggest that we would have then anything to change dementia could do two things. They could increase brain reserve, and it could decrease the deposition of any neuropathology in the brain. So people have shown you our diagram twice already today, so we didn't see each other's slides first. But basically what we did is in 2017, we decided to consider this life course approach to dementia. And we thought that was very important to consider it throughout the lifespan, because if we look at something like high blood pressure in middle age is a risk for dementia, and so is obesity in middle age. But in late age, people as they develop dementia lose weight and their blood pressure drops. So in late age, having high blood pressure and obesity probably means you're not developing dementia, whereas you've been at higher risk at a younger age. So we thought it's very important to look at it at different stages in the life course because there's different risks. And we started off by saying, well, let's think of our what's already established, and we decided we would define that by using the National Institute of Health risk factors and the National Institute of Clinical Excellence in Britain risk factors, and we found 9. We then met again after the first commission and discussed the evidence, and we added 3 risk factors which we thought there was enough evidence to establish that they definitely were risk factors. That was traumatic brain injury, pollution and alcohol, getting to 12. And we did not add others, and the particular ones that we spent a lot of time talking about were sleep and diet. So we decided that because increased sleep seems to be a risk for dementia, and decreased sleep also seemed to be a risk, but that's not biologically plausible, and that some of it was reverse causation. So people, as they are developing dementia, have disturbed sleep, and some of it might be due to underlying risk factors. So, for example, people who are developing physical illnesses may have problems with sleep, or people who are depressed. With diet, equally, we felt diet had something to do with dementia, but couldn't really establish any particular element from the literature, and found that the literature was inconsistent. So when we said there are 12 risk factors, we know that there are 12 established risk factors, but there are several other risk factors which probably relate to dementia, and we're waiting for more definitive evidence. And there are many, many risk factors which have been mentioned in 1 or 2 studies, but the weight of evidence is not enough. So these are the risk factors. I'm not going to dwell on them very much because mainly because people have already talked about them, but just to say that I think that some of them are more established. There's been a lot of work on social isolation since 2017, and it's consistent around the world that social isolation is related, and social isolation at age 40, 50 and 60, having less social contact, is related to the development of dementia. So I think there is some more evidence about them. And indicates that it really does make a difference. The evidence in a recent meta-analysis is that loneliness was not a risk factor, and I think that that's probably related to the heterogeneity of what loneliness is, rather than the fact that it is, of course, bad for your mental state in many ways to be lonely. We considered these risk factors, and and we considered it in the whole population, because this talk is really about population that I'm considering. And so we worked out the population attributable fraction, which is a fraction theoretically prevented by eliminating a risk factor. And it is worked out by the relative risk, which we established from meta-analyses, and the prevalence of a risk factor. And it's a worldwide figure that we give. So just as Chris talked about how interventions have to be tailored, the figures we are giving are worldwide, and they vary between different populations. So if there's more hypertension, then it's likely to have more of a population attributable fraction. So in our worldwide, if you look at the path, the relative risk makes a difference, but so does the prevalence of the risk factor. So something with a high prevalence and a relatively low relative risk can make a huge difference, and a high relative risk with a low prevalence makes less. The one that comes out in both times as the highest is hearing, which both have which is a high relative risk and a high prevalence. We also consider, and I think it's really important, is communality. People are not like lab rats or mice, and lab rats and mice keep getting cured of Alzheimer's all the time, every year. And so far, unfortunately, these things that have cured mice and rats haven't done much in humans, and that's probably because humans are a bit more complex. And if you just look at one individual risk factor and don't put into consideration that they tend to cluster, then you get it suggests that that one is is causing a lot of the dementias in the world. So, for example, hypertension, obesity, lack of physical exercise, and diabetes tend to cluster in the one person. And you have to look at all of these together. And this is the way that you calculate it. I'm not going to go through the actual equation, but any of you can look it up in the Lancet and try it yourself. And we now have it in spreadsheets to help us. So here is a diagram you've already seen twice. I'm not going to keep showing it, but what it's taught me, and I hope it's other people will agree with me, is that putting things in a pictorial form really, really makes a difference. In the both Lancet reviews, we talk, oh my God, it says the client has disconnected. That's really worrying. Sorry, but in both Lancet reviews, we talk about the risk, and we put them and we go into great detail how we calculate it. But what the message everyone takes away from it is the picture. What am I supposed to do about the slides? It says client has disconnected. Can you help me, please? Fantastic. So the risk factors, are they the same for everyone? No, they're not. All the evidence over the world is taken from cohort studies, and despite the fact that over 60% of people with dementia now live in low and middle income countries, about 80% of the studies are from high income countries, and even within the high income countries are mainly from white participants. So the risk varies between countries, and our overall message will vary. And the risk varies within countries, and they cluster around inequality. So, for example, in high-income countries, in Black, South Asian, and minority ethnic groups are more liable to develop dementia. Vulnerable populations are more likely to develop dementia, and low and middle-income countries. People in low and middle-income countries tend to have now higher risk, for example, more cigarette smoking and more diabetes, and therefore are more likely to develop dementia. Can you give me the next slide, please? Thank you. So in 2019, the group of us looked at the 1066 data from Martin Prince, and we published in Lancet Global Health using the 9 risk factors, the risks in lower and middle income countries. And we found that the risks, that these 9 factors accounted for even higher numbers of cases of dementia in low and middle income countries than they did in a worldwide estimate. That's really important to know, because it suggests in low and middle income countries that dementia is even more preventable. And the sorts of work that is done in finger it would make even more difference in, say, in Latin America. And I'm busy trying to think about whether there could be an acronym which is as good as SINGER, but I don't think it would fit in any of these countries. Can I have the next slide, please? So when we look at all of these risk factors, we can think about individuals, but it's difficult for individuals to change, and it usually requires both an economic and an educational capacity. And when we think about what governments can do, that can make a great deal of difference. So these are our recommendations in policy. We'd like to keep thinking about how policy could make much more difference than in individuals. So in education, all children should be provided with primary and secondary education. And currently, about 40% of children in the world do not have education past the age of 13. Since we did the original work in the Lancet in 2017, several groups have looked at provision of hearing aids and found that people who use hearing aids, these are not randomized controlled trials, but cohort studies, but people who use hearing aids do not have an increased rate of dementia and have the same as the population who do not have hearing impairment. And that seems to be very important because it suggests that when we first published it, a lot of people said hearing had nothing to do with it, that losing your hearing is just a prodromal sign of dementia. But if it were so, just using hearing aids wouldn't be expected to decrease your risk. However, since it's not randomized controlled trials, it may be that the sorts of people who use hearing aids are just a different sort of people, but it's a very, very hopeful sign. So one of the things that we should consider about is policy to prevent hearing impairment, to prevent loud noise. We should have campaigns and about the stigma of hearing impairment. So now it's still very stigmatizing to wear hearing aids, and yet I don't know what percentage in the world, but I'm going to suggest that 50% of people in the world are walking around wearing earphones to listen to music or listen to podcasts at all times. And just as glasses used to be 50 years ago a big stigma and no longer are, we ought to be thinking about the stigma of hearing aids. Also about the availability of hearing aids, which can be afforded, and how they are provided, so they're much easier to use. In cigarette smoking, policy makes a huge difference in the high-income countries who've reduced dementia. In most of them, cigarette adverts are now illegal. There's certainly been a reduction in it. And not smoking inside in public as a health policy makes a vast difference, and availability of smoking cessation. I'm going to link obesity, hypertension, diabetes, and physical activity together because they are, and local availability of healthy foods at affordable prices makes a huge difference to what individuals eat. Walking in cycle-friendly environments, places where they have pavements, places where it's easier to walk and it's easier than it is to drive, and places where people think that they will survive if they walk or cycle make a huge difference. So the environment and policy makes a difference. Traumatic brain injury has been very much in the news as football and rugby players around the world are talking about epidemics of dementia. And traumatic brain injury can, a lot of stopping of that is using policy, seatbelts, cycling helmets, sports protection. In the States at the moment, there's a campaign refusing to allow children to head balls in practice or to not use helmets. And as the leader of the campaign said to me, if you're a professional football player, then you as an adult, you both have capacity to make a decision and you have helmets and you're paid a lot of money. If you're a child, you're just heading a ball. Now, we don't know that heading a ball as a child causes dementia, but it's not likely to do your head much good, and campaigns to consider sports protection can make a difference. And in terms of air pollution, legislation to help clean air can make all the difference. And there's one study out and another study that is currently in with the referees showing that policies which have reduced air pollution have made a difference to the cognitive profile of the whole population. So I've got a really important message. Individuals can take control and can do a huge amount, but governments can do even more. And it's much easier to change behaviour. Next slide, please. So in the, I want to say that not only is it not just about individual intervention, but it's also about the way society is structured. And we've seen that a lot with COVID, where the most vulnerable are older people in care homes throughout much of the world, but not in all countries, have died disproportionately. It's been more than a third of the people who died in the UK of COVID have lived in care homes, despite less than 1% of the less than 0.5% of the population living in them. There's been more deaths throughout the world in people in minority ethnic groups. So culture, poverty and inequality are obstacles to change, but they're also the drivers of the need for change. One of the things I think about randomized controlled trials is they tend to recruit people who understand the concept, who have the availability, and who are very well motivated. And over again, for example, in the finger trial, we find that the non-intervention group does a lot better than expected, because these are people who take up policies. Those are most deprived need the change most, and that was shown in the Hatties trial, where the most deprived people did much the best in reduction, and they're likely to derive the highest benefit. As societies, we need to think beyond promoting individual health, blaming people for not being able to be healthy, and begin to improve the circumstances in which people live. Thank you. Next slide. Thank you. Recently, we published in a couple of months ago in Lancet Healthy Longevity a cost study of individual, moving from policy, but individual interventions which were but which were state-led, and we costed it in England because you can only do costing in an individual place, how much it costs for a doctor or a nurse in these places. And we found that if everybody was offered free and available screening middle-aged people or young, old, for hearing aids, anti-hypertension, smoking cessation and prevention of diabetes rather than treating diabetes, then the hearing aids, antihypertensives and smoking cessation would lead to an 8.5% reduction in dementia prevalence in England, because some people already have these interventions, and a 2.4 billion year saving in care, in health, social and unpaid care. So these interventions are not only morally right, not only important, as dementia is the most feared disease for people, individuals and families, but should actually save money. And Health Economists did the sums, not me, but they've now developed a methodology in the UK, and we could help and provide that so that people could do that in their own countries. Preventing diabetes was too expensive and not worth it in terms of QALYs, just for prevention of dementia. I'm sure that it would be worth it for prevention of other things. And it's interesting, as Mia points out, these healthy lifestyles don't just make a difference to dementia, they make a difference to other illnesses and to hospital admissions. But it's not just ethically right, it's not just right for people as individuals in the way that we all want is to have more years of healthy living, but it saves countries money. And I think it's a really important message that we should all be bringing back to our governments. The World Health Organization should be talking about ADI as an international organization, which is the ear of so many governments should talk about. And it really is a time that we can make a difference and there can be a revolution. Next slide, please. Within the UK, Public Health England have already implemented some of our findings, and the middle-age check now includes an individualized assessment of cardiovascular risk for dementia, so that people are told you are more likely to develop dementia because you have this, this, and this is what you should change. And their indications are that people do begin to change their behavior on a more individual basis. Next slide, please. Overall, I think it's really important to be ambitious about prevention. Trials are short with relatively small numbers of people, and therefore it's difficult to show that they prevent dementia. I mean, Mia's going for the 10-year follow-up, and it's a very long-term basis to try and see what happens. However, results of cognitive reserve modification for whole populations or high-risk populations are much more hopeful. We must keep in mind that over the last 20 years, there's been a 25% reduction in the incidence and prevalence of dementia in these high-income countries, which have particularly made differences in cigarettes and in hypertension. and more of the population are educated. So policy changes are very likely to be the most powerful changes. And I'm going to leave you by talking about ways that these have changed in earlier times. We can talk about John Snow in Britain. And none of these things that I've shown pictures of had randomized controlled trials, but our earliest epidemiologist, John Snow, at the time of cholera, mapped where the cases were in the maps. So this was before anyone had seen the organisms that called cholera, or even knew that they caused cholera, or even knew they existed. He found that there was only one family that were not in a particular area, and he went to see them. He was much more interventionist than any of us. He went round and they said, well, they used to live at Broad Street, which is where all the other cases were. They'd moved away, but they thought that the water tasted so good that they went back and collected their water from the Broad Street pump. He talked to his colleagues and said that this is what's causing the cholera, and people didn't believe him. So he broke off the handle of the Broad Street water pump, and since then there's never been an outbreak of cholera again. Next slide, please. So I'm saying that we must get over we must work with people saying, do not wait for definitive proof from randomized controlled trials that policy can make a difference. The evidence now is overwhelming, and this is the time to act. Thank you for your attention. I'm leaving you with a picture of the campus in UCL, and just to help us all think about the broader world. I'm sorry that I'm not in Singapore, though I'm pleased I'm not jet lagged, and look forward to talking to all of you, and particularly with Chris and Mia, about the work that we are all doing together to try and make a difference to dementia.
Thank you.
Thank you very much, Jill. This was fascinating and very comprehensive overview, and kind of ties up that whole session from, starting with what do we know, what's the current evidence for the risk factors, how might we research them some more or adapt interventions for different cultural settings, to then the big question and the elephant in the room is what are the policy changes that are required so that we can really bring those benefits to the general population. We're a bit behind schedule, and we have so many brain questions coming. So it will be really a challenge to select a few. So please, dear panelists, be as brief as you can as I shoot questions your way. The one that comes from earlier in the session was actually on. It seemed that the finger intervention trial is very similar to what you would do in diabetes. In diabetes trials, you then also add metformin to the mix in some of the trials. Mia, can you maybe comment on the similarities between diabetes prevention and dementia prevention? And then Chris, the question was also, will metformin trial be added to Singapore? And Jill, feel free to add any cost considerations to that question, please.
Thank you. It's a good question, and indeed, we know that behind many chronic diseases are partly shared risk factors. So diabetes and dementia are sharing risk factors. Actually, the finger model comes partly from the diabetes prevention study, with some of the addition of the more brain focus, like cognitive activity and so on. So we are also talking about integrated interventions. We could, like as I showed, partly, of course, have the same package and try to use the infrastructures what are there for dementia risk reduction as well. About metformin, yes, I don't think that is needed for all. So the idea is, as I said, more precision prevention. Some individuals may need some more pharmacological means. It can be, like Chris mentioned, more intensive treatment for blood pressure, or metformin for those who have insulin resistance or pre-diabetes. So this is the idea in the metformin, that we add metformin for those who have this kind of phenotype, not for all. This is how I see the future. The lifestyle is always the basis, and then it can be even more individualized, and then we add medications when needed. Final point, what I think was really important, what you mentioned, Jill, individual choices are important, but the policy, the society, making the healthy choices, the easy ones, is so important. So I really hope that this growing evidence can facilitate the policy making so that we can make dementia prevention-friendly societies.
Thanks, Mia.
Thank you. Yeah.
Metformin in Singapore, in Singa, that would be wonderful. So, metformin has been touted as being a very multi-potent drug. So there are studies or planned studies to see whether it's anti-aging, and that there's a potential that it could be anti-dementia. So we have discussed this with Mia and Left, and certainly we would like to consider doing such a trial. But if anybody from the NMRC or funding agencies in Singapore is listening to this call, please look favorably on any further application. We'd love to do it.
Okay.
Can I say something?
Jill, was there? Yes, please.
Yeah. So if we go back to our life course diagram, just in your head, I'm not suggesting put a slide up, then of that 40%, 20% are caused by 3 risk factors in order of importance, and they are hearing, education, and smoking. So vascular risk factors are really important, and what happens with diabetes is really important. But dementia is not diabetes. It's more complicated and even more difficult. So preventing all the things that prevent diabetes are really important, but we must be thinking about things that help keep us cognitively active, as well as cigarette smoking, which also I think poisons in addition. So it's very much, diabetes is a bit of it, but the majority of it are other things which are considered in Finger and Singer as well.
And if I just may quickly add, I think this is the important, the multi-domain concept and life course perspective, the complexity of dementia. So keeping this in mind is not one thing that will solve the whole thing.
I want to get at least 2 questions in before we have to wrap up for the next part, and that is a question for Jill on air pollution. So this is a new risk factor that was added, and from a policy perspective, potentially a powerful one. Can you tell the audience in a minute or so a bit more about what type of air pollution and what kind of policy changes you see?
Sure. The literature in air pollution is quite heterogeneous, but it seems that it doesn't really matter what you pollute the air with, it all has the same effect in the end. If you look at them all, it's just the particles in the air that matter. And obviously, people who live in areas of high pollution tend to be people who have less choices. But if we go back to the animal models, if you have high air pollution for a rodent who has no other risk factors, then they begin to get tau changes in their brain. So it does look very convincing that it is the air pollution. So policy changes have probably got to do a lot to do with the differences that can be made that will make our future more likely in terms of clean energy within that. And probably one of the only better effects of, maybe the only a better effect of COVID has been a reduction in air pollution. So it's the wood fires, in some areas, traffic, aeroplanes, all the things that cause air pollution. We can think about less of it, so policies which reduce car driving, which also increases physical activity, decreases obesity, and decreases hypertension. So it affects many of the areas in it, and areas which and policies which decrease the use of polluting fuels in terms of burning coal, but also using petrol, diesel, and lead-based lead-based fuels. So it depends on individual areas, but a huge amount can be done to reduce air pollution, and that's something that we have not much control of as individuals, but we have huge control of society.
Thanks, Jill. And the other question that I wanted to get in, it's just the elephant in the room, and you'd mentioned it all in your presentations or in your comments. COVID-19, it may be a blessing in disguise for air pollution. It will reduce our social interaction, and I recall Mia saying in the beginning, the social component was one of the most powerful recipe or ingredient in it all. What is your overall take-home message or take on COVID? What do we need to be aware of, and what might it help us with in taking the agenda forward?
I could just start quickly that yes, we can see that it is not only the direct effect of the infection, but the indirect effects, the long-term effects that may really have big effect for the brain health, because it's affecting our lifestyle, may affect the management of the risk factors and so on. So how can we adapt the interventions in this new normal situation? I think it's very important. What we could see, as I showed in the finger, that the social component was so important. I believe we can use the technical tools, remote control, but we need to take into account the importance of the social component. I don't think the technical thing can totally replace the face-to-face connection. So I think we need to be creative, and especially I'm thinking some older, more frail or cognitively frail person. How can we guarantee that they also get access to these interventions, so that is not only for some selected groups where these digital tools are available? So I think that diversity is important. Finally, I believe that our efforts are needed more than ever, given this new situation and the lockdowns. We need to adapt the interventions and care to this new normal. So here I again think that the global and joint efforts are really needed.
So from our experience, whilst face-to-face meetings are important, once you have the face-to-face meeting, and I think it's important to emphasize that the finger and stinger interventions are not individualized. They actually take part in groups. So the groups actually get on with each other. I was really quite astonished that in the groups that we had, they all exchanged WhatsApp numbers, and they got on with interacting themselves. So I think that our elderly, if they are motivated, can actually overcome many of these obstacles. But we just have to get them started.
Yeah. I think that, as we'd all agree, that most of COVID has been a disaster for people who have dementia, and I think it has shown the difference between countries which protect older people with dementia, where there hasn't been an excess risk of death, and most countries who have not. And it's really important to keep with the vulnerable people, are not people that can be sacrificed. Sending people into care homes with COVID is completely unacceptable, and lots of excess death. And we really have to, every time that there is a threat like this, now we have to start thinking about the older people to begin with, who tend to be more vulnerable. So I think it's a really important message about that. Other than that, we don't know if there is a long-term threat to brain health from COVID, but we suspect there might be, and there might be an epidemic. It's really important we keep finding out and going through with this. And it's also important we try to have the positive effects of COVID, there's very few positive effects, but we try to think about reducing pollution, reducing unnecessary travel, and neighbourhood kindness, which has been one of the effects of COVID. So let's point up the negative and try and tackle it. Keep an eye on everything and keep the positive.
Yes, thanks, Jill. You mentioned it, or you pointed out the vulnerability of the older population in the pandemic. And we've spoken about vulnerable or at-risk populations for dementia risk reduction. And that links to another question on whether in the UK there were any particular policies focusing on low income or vulnerable populations, and how that focus might help in reducing risk overall if we focus on vulnerable and populations and at risk.
I don't think there has been a massive focus in the UK on vulnerable and at-risk populations. And if we look at the studies, it's been the reduction in people with more education and who are high income. And I think that the more education is both because it increases cognitive reserve, but it also increases your opportunity and to make good choices, both because you have more resources and also because you're much more able to pick out from the mass of information, much of which is misleading, what's correct and what's misleading. So I don't think it has been in the past. I think the UK has many examples for this, except for our wonderful NHS, which has meant that anybody, that's true. It's true in some other countries. It's also not true in many others. That it means that the policy, such as a midlife check, is on illness, is there for everybody. Hearing aids are there for everybody. Blood pressure medication are there for everybody. However, having said that, it's made a huge, these things made a huge difference, but still people who are socioeconomically disadvantaged and people of minority ethnic groups get less of these. And that's, there's a variety of reasons for that. It can include less ability to access them and less ability and less belief and trust that in some of the minority ethnic groups, that the doctors either care about dementia or that they're there to help you and things will be kept confidential and private. These are things that we can really begin to make a difference to in the future.
Okay, thank you. It's really hard. I did not expect this to be such a difficult task to, in short period of time, to select the last few questions that we can still address. And I'm mindful to hand over or introduce our next the next segment or the last segment for this. So I just wanted to wrap up, give each and every one of our panel members this morning a chance to say famous last words, any take-home messages that you want to give the audience. And we can maybe address some of the other outstanding questions in the chat in writing throughout the rest of the conference. So any take-home messages on how we can all reduce our risk if you can make a wish for the population, what would you say?
Ladies first.
Anyone, ladies?
I thought you could start, Chris. You are in Singapore, so please go ahead.
Okay. Well, I'll give an unashamed plug for Singa, because I know we all know what we need to do, but the problem is getting people to do it. So if there are any colleagues out there, any organizations in Singapore which want to help us show that this particular structured intervention, which is safe, affordable, is actually effective, we welcome you to join us, so that the sooner we finish this, the sooner we can benefit Singaporeans, and by through that, all of Asia. Thank you.
If I may
5 seconds
continue.
left.
Oh my God.
Yes,
so
please,
2
quickly.
points. I think prevention is treatment. That is the way what we can do to really manage the dementia epidemic. We know already what we can do. Now I think it's more the how, and it's more, I think, the worldwide thing is we are trying to find the ways to implement and then influence the policy. So making the healthy choices the easy ones. All hands, fingers. It's a joint effort that is needed.
Okay, so my final message is that the audience here are powerful people. They are health professionals, they are policy people, they're people whose voices count. We need all of you. We need all of you to be talking about prevention, talking about the hope for dementia and how we can really, really make a difference now. And talking to your voluntary groups, to your government groups, to your health settings and social care workers that you work with, to really begin to make a difference. You are powerful and know powerful people. And everyone here goes out and tries to do 2 or 3 things, to talk to people, to make a difference. This will make a global difference. So we need you. That's what I'm saying. We all need you. I think Mia and I walk around the world trying to tell people, or sit in our own living rooms and try and tell people there's things we can do. We need everyone to be ambassadors and to do it for themselves and get their organizations and their countries to do it. And thank you for giving us this opportunity.
No, thank you for being here, for fascinating talks. It was great being here with you. I'm now handing over to the fascinating Amalia, who will introduce the Poco Poco dance. Thanks, audience, for listening, and please stay on and do the Poco Poco dance. Bye.
Yes. Thank you, Catherine, for the introduction. That's really interesting. Many people say it's Poco Poco, but that's okay. The name is Pocho Pocho. I know it's a little bit challenging for some people, but okay. Thank you, Catherine, for the introductions. And again, thank you, ADI and ADA, for this great opportunity. Hello, everyone. I am here on behalf of my lovely colleague, Alzheimer Indonesia, across Indonesia and across the world. Now it's watching. It's really nice that they are supporting you endlessly. So I'm really excited to tell you guys more about Pocho Pocho. Yes. Pocho Pocho dance, known as Senam Ceria. Senam Ceria Senam is exercise and Ceria is fun and happy. So it's like happy and fun exercise. It's a popular traditional dance originated from Eastern Indonesia. And dancing Pocho Pocho is an easy, inexpensive, and practical method in the community, especially in Indonesia, to preserve and improve the methods, practical method in the community to preserve and to improve the executive functions in order to maintain the independency and quality of life for the pre-elderlies and elderlies. Pocho Pocho Ceria, we call it in Alzheimer Indonesia. So Ceria is happy, fun. So it's happy, fun Pocho Pocho dance. So, Poco Poco Ceria Move, created by Alzheimer Indonesia Risk Reduction Team. And they are all here, watch us from Indonesia and around the world. So it's supporting Indonesian from around the world. And we have research from Dr. Ria Maria Teresa, Scientific Committee of Alzheimer Indonesia, that shows that by doing this Poco Poco dance, 30 minutes, 2 times a week, will can improve your brain plasticity and executive functions of type 2 diabetes mellitus patients with mild cognitive impairment by 37.5%. This Poco Poco Ceria dance is also shows at ADI conference in Kyoto, Alzheimer Europe conference in The Hague, and also some conference and meetup in New Zealand, Brunei, Malaysia, and many more. So most probably, some of you is familiar with it already. And at that time, maybe you were a little bit shy to dance with us on the stage or on the floor. But now, you have your own virtual stage at your home in front of your computer. And yesterday, I read the ADI newsletter of the day one of the conference, that during this pandemic and all this time, you have a lot of virtual meetings. And in this conference, it's not always sitting and listening and discussing. So now we would like to invite you to stand up. I will stand up, and I hope you guys also stand up. Come on, stand up, stand up. Yes, this. And I heard also from the previous sessions that Catherine make a polling that we have really less physical activity. So this is the special about the conference, like we're not always sitting, now we are standing up. I'm really looking forward. Now we give you time to take your mobile, your smartphone, and make a pictures of yourself preparing doing Poco Poco or video and share with us. I also look the pictures of ADI's staff yesterday doing the brain gym. It's really amazing. So you guys can adapt her and show us. We will watch 2 videos after this. The first one is the Poco Poco tutorial. So we will show you the step-by-step tutorial, the move of the Poco Poco, then you can follow. After that, we will show you the guide, the video guide, the dance guide, so you can dance together with us. And we hope, don't forget, you can turn on your video now. I will turn on my video now too. So I will send that I dance Poco Poco too, and share with us in the social media and tag ADI 2020, Alzheimer Indonesia, and Alzheimer Disease International social media. So let's do it together and show our move with us. Let's watch the video 1 and the video 2, tutorial and dance move.
tidak fokus, marah-marah curiga yang berlebihan. Pikun jangan pikun, pikun jangan malu pikun, pikun jangan pikun, pikun jangan malu dengan pikun.
Hi, so how's it? My breath is a little bit, yes. So it's really short introductions. If you wanna hear more, if you wanna see more about the long versions of the dance, you can go to Alzheimer Indonesia YouTube and you can find the whole introductions and the whole move. I know, sorry, my breath is catching up my breath because I'm really, really doing it. And if you see, and the move, some of the move is also inspired by Indonesian traditional dance. So it's traditional dance. It's from West Sumatra, tari piring. So it's inspired by many things. And also if you see that you can do it together as like line dance. Yeah, the line dance, people have it everywhere. This is the line dance of Indonesia. So you have the movement, you have to repeat the movement, and then you do it together with your friends. Of course, at this time, maybe it's not possible, but like this, we can do it online together and we still have fun. So thank you very much. Don't forget to show us your move. I'm really looking forward, especially the ADI staff in London. Is also, I believe you guys are doing that, and all of you. So thank you very much for joining us. We look forward to see your move in social media later, or send us the private message if you don't want to post in social media. And thank you very much. Regards from all Indonesian Alzheimer Indonesia team, and enjoy the rest of the conference. Thank you.
Well, good morning, everybody. My name is Sharon Thomas from ITM Productions. Thank you so much for joining us today. It's Friday. It's the end of a week. I hope you've all had a good week. It's December. It's nearly Christmas. So things are looking up already, aren't they? Good morning, Paola. Good morning, everybody. Thank you all for being here.
Good morning, Sharon. Lovely to see you.
And you, and you. So, Paola, thank you so much for joining us, of course. Paola is the CEO of Alzheimer's Disease International. Of course, it's been, a turbulent year for all of us. I mean, we didn't necessarily know what we had in store for us all at the beginning of this year and when we sort of talked about making this programme. Just sort of tell us, first of all, just outline for us what sort of thing you were hoping to achieve with this programme.
Well, initially, one of the great opportunities afforded to us by this partnership was that, as I explained in my plenary introductory speech, it is very important for Alzheimer and dementia people that are interested in the issue all around the world to unite and to collaborate and to work together in order to raise global awareness. So it's quite difficult for us to do that, as of course ADI works on many, many fronts. And it's usually people that are in the know that know about ourselves better. So it was a massive opportunity to bring our cause to a larger audience. And in particular, to bring our cause to people that may have never heard about the fact that they needed to make their voices heard. So it's been a fantastic opportunity for us.
Why would you say now that this content is more important than ever? I mean, you talked there about, obviously we haven't been able to see each other physically this year, but why now then, when you say you are reaching a different audience, a wider audience, why is this content more important than it's ever been?
Bizarrely, during COVID-19, we've been brought together by the realization, and we'll talk about that earlier, that the most vulnerable and frail people have often been forgotten or they have been non-considered by governments. So right now, the dementia movement has got a much stronger awareness of just the level of human rights trampling that has been all over the world of our constituency. So it has been amazingly important. Just to also refer the plenary session that just closed on risk reduction, this year there have been some really important breakthrough on risk reduction, for example, and we have been able to add some important advice to the advice that we usually give to people regarding that. It's also an important year for the possibility of disease-modifying therapies. I mean, this is a huge opportunity for us. So, the world has had a moment of arrest, but the momentum on dementia was going on. And you can see that in the array of things that have happened. Now, it's important in this context, in particular, because we do not really know what are we going to face next year. There could be a complete arrest of any kind of activity. There could be cutting of budgets. So our community needs to gear up with great tenacity and great strength to possibly fight an even bigger battle that we've been able to fight. Now, this conference is about hope, and I have the very strong hope that it will be even bigger, our movement this year and next year. But there's no resting on laurels here. We have had a tough year, and we need to continue to fight for what we want to happen to people with dementia and their families.
And you talked about strength there. I mean, we've all had to draw on all our strength this year, haven't we, really? Every fibre of our bodies. How confident are you that we can all collectively draw on that strength and do what needs to be done and address the issues we're talking about here?
Well, I think this raising of consciousness collectively has given us great strength, has given us much more concrete points, because it was very easy for a government before to say, but it's not true that we are not looking after people that may have dementia. It's not true that we are not looking after people that may have need for long-term care. So in a way, what happened this year has given us an opportunity to say, no, it is absolutely true. We know this is happening. We know this has happened. So you cannot ignore us any longer. Nevertheless, this is going to be a tough thing going forward. But it's also been heartening to see how many organizations and companies, industry have been behind what you've tried to do. And so many are working. One of the important things for us is to continue to also promote a message that we want investment in dementia to happen. So our World Alzheimer report in 2018 was very clear about that. The investment needs to happen, more people need to come on board, more people also with new ideas. People were talking yesterday in one of the showcases about new entrepreneurial ideas. We want that to happen. We want this sector to be vibrant, because that will attract more interest and more investment and more governmental funding and more governmental support, which ultimately I keep thinking is the only way we have to really get out of this at the level and scale that we need. 50 million people living with dementia, possibly well over 250 million people affected to it worldwide. We need big level investment and solutions if we're going to get out of this, in one piece.
Okay, somebody needs to have deep pockets. Okay, that's a good message to start off with. Okay, let's take a look at our first film about the National Dementia Plans. Thank you.
Over 50 million people are living with dementia. By the end of this decade, that figure is likely to rise to 82 million, placing an unprecedented strain on health systems globally. 3 years after the World Health Organization approved a global action plan on dementia, much remains to be done. But there are positive developments being championed by Alzheimer's Disease International, finding hope in the age of dementia. Understanding each country's cultural, political and economic situation is key to strengthening those responses. The WHO wants 146 of their 194 member countries to have a national dementia plan by 2025. As yet, only 33 such plans are in place.
National dementia plans can be transformative. First of all, a government has to be aware, has to take conscience of the fact that dementia is in their country and it's a problem. There are certain countries that are still in denial about dementia. This is so important because there are such big societal changes all over the world that it is about people, it's about citizens that have a right to vote. They have to demand for more to happen or it won't happen.
If we in Jamaica did not have the strength, the power of a global organization like Alzheimer's Disease International behind us, we would have never gotten that meeting with the minister. It was really only that we had this global, recognizable voice, this powerful voice, powerful presence saying, this is something that we need to take care of, this is something that we need to address, that we were able to have very shortly after a one-on-one meeting with the minister.
Paola, you obviously do have, great strength there collectively, but it's been a very turbulent year for all of us, as we know. How far have your dementia plans for this year really been impacted by COVID?
So interestingly, there was a lot of momentum, and we saw that momentum translate in 4 completely new plan and strategy. Germany, the speaker from Germany spoke at the first plenary yesterday, Iceland, the Dominican Republic, crucially China. So you're looking at 1 billion people impacted by a dementia plan. And later in the year, for example, the country I hail from, Italy, finally ring-fenced the budget for a dementia plan they've had for many, many years, budgetless. So we have seen a lot of positive things happen, which heartened us because it was almost like there was an acceleration, which meant our movement has worked very hard in the last few years to get acceleration on the dementia action plans. However, clearly, this momentum will possibly come to an end. We do know that there are governments that continue to show great commitment to get something out by next year. For example, the government of countries like Kenya. And if Kenya did a national dementia plan, that would be the first one in Africa. And so we are all waiting with bated breath for that to happen. So I have hope, really, that things will continue to happen. But I'm also pragmatic, as I was saying earlier. It's an easy thing not to have anymore.
Well, 1 billion people impacted, that's incredible. I mean, that's what, a seventh of the world's population. What else can we do now to really move things forward?
So there's quite a lot that we can still do. Our members, there is now 102 nations in our membership. We've got over 15 in our membership development plan, most of them in Africa. Our members have drawn now a much stronger sense of their collective power. I think when at the beginning of the year we started seeing what was happening with COVID, and we pulled together, we started creating opportunity for our members to interact both amongst each other, with us, and then eventually with the general public. And that started to give people a lot more confidence, that there was a lot more interest than they thought in what they were doing. And that in itself has attracted more policymakers. These years we have had connections with policymakers around the world that we hadn't had before. And that has been in part as a consequence of this enormous amount of activities that we put together, which in turn was afforded to us as an opportunity by the fact that our members had been so immediately proactive in helping each other. So we found ourselves with a repository of extremely learned spokespeople. There's going to be a plenary tomorrow around COVID-19, and you will see the breadth of innovativeness and inventiveness, but also quite a lot of policy interventions. The governments of Taiwan and of France did early policy interventions with their governments to prevent them from fining people living with dementia that were not social distancing or self-isolating and were incurring into fine. There have been other policy interventions that also have been very interesting. The UK Alzheimer's Society, for example, has published a wonderful report. A new one has also been published by Dementia Australia, which essentially drew on the figures that the government published in order to get positioning which was beneficial to people living with dementia and their family, especially in long-term care during this period.
Okay, Paola, that's great. Many thanks for now. We'll come back to you shortly, obviously. I'd like now to introduce Roche, the world's largest biotech company. Let's take a look at their film first of all.
I think one of the hardest things for me was when I got married and she knew my husband and then she couldn't recognize him the next time we went to visit, and she was just wondering who is this man in the living room.
Anna Maria's grandma was diagnosed with Alzheimer's when the disease was already in its advanced stages.
When everything changed, it was like not knowing who she was anymore, and the heartbreak of knowing that she didn't know who we were sometimes, and all those memories, where do they go?
Roche, the world's largest biotech company, is dedicated to finding complete solutions for Alzheimer's disease. To achieve this, they're combining their unique expertise across their diagnostics and pharmaceuticals divisions. So what does the ideal treatment pathway for Alzheimer's disease look like?
What it looks like is giving people the ability to detect if they think something's going wrong, giving their doctors tools in which to evaluate patients' symptoms, bringing in people who are at risk for Alzheimer's disease or in the early stages, and designing new treatments specifically for them and their stage of disease. Also, tools to monitor how they're doing over time, and decision tools to help clinicians decide when they need a change of any kind in the therapy. So ultimately, our vision is complete solutions for patients to either prevent or treat Alzheimer's disease, no matter what stage of disease they have.
We've seen research come through recently that suggests that we may be able to develop simple blood tests to detect Alzheimer's disease. And because this is such a big challenge, it's really important to work collaboratively across the field, including industry partners, philanthropy partners, and our very strong academic partners, to work together to really advance and accelerate the availability of simple blood tests so that people around the world can have reassurance that what's going on is something that they need to take further.
Okay, thank you. Well, I'm delighted to say now, as you can see, we're joined by Martin Traber, who's the global head for Alzheimer's, the medical director for Roche. Thank you so much, Martin, for joining us today. Tell us a little bit more about that film and its contents. Just talk it through us to a little bit more detail for us.
Sure. Thank you for including us here. It's a great pleasure to join you on this session, and to join you also with like-minded public and private organizations, because it's all about this togetherness in our effort, in our path to transform Alzheimer's disease. I would like also to acknowledge the tremendous effort and this great conference of ADI and ADA to join together, which is in a truly inclusive effort to highlight what are the challenges, but also the opportunities on our journey to transform the lives of so many people. So it's great to be here. I guess with regard to the film, we at Roche are really committed to change the lives of the people globally with our footprint and with our capabilities that span across diagnostics and also pharmaceuticals to bring solutions to patients.
And what's happened since we filmed? I mean, obviously COVID has impacted us all hugely this year. What sort of impact has it had on you? Has it had on your organisation at Roche?
Yeah, I guess we recognize that COVID is a big challenge for everyone, especially also for people living with Alzheimer's disease. And actually, the challenge of living with Alzheimer's disease is already a huge one, and COVID comes on top. I think what is important here to acknowledge is that as for COVID, the cause of the disease can only be challenged by a breakthrough. So similarly, that we're looking to see vaccines coming through for COVID, we're looking forward to disease-modifying treatments to come through to change the course of Alzheimer's disease. And I personally believe, we as an organization also believe, that we are closer than ever to see such a breakthrough come through.
Wow, that's really positive news to hear. Beg your pardon, Paula. Nice to hear you talking so positively, Martin. That's fantastic. So what does 2021 look like for you? How hopeful are you?
I think 2021 is a continuation of our journey. We are pressing on. It's very important that we continue the efforts steady on investigating the disease-modifying treatments. We are also developing at our company, making sure that diagnostic solutions reach patients worldwide. And we already have diagnostic solutions in place that help aid earlier diagnosis. So I think it's this opportunity to double down on the efforts and also bringing the learnings from COVID into the space of Alzheimer's disease also. I guess we've heard also in this conference a number of such opportunities, which is making sure that we get more flexible in the care settings also. We believe it's hugely important that we deliver solutions going forward that help aid people living with Alzheimer's disease and their carers, their families, to be taken care of at home also. So this aspect is a hugely important one for us too.
Paola, it's great to hear Martin speaking so positively there, isn't it? That must give you a lot of hope.
Yes, massively. And for us, it's been fantastic to see companies like Roche, who have an incredible vision, which is going to be consolidated also, as far as I understand, next year, and have shown unwavering support of dementia, even when things didn't look so good, and continue to fight on a number of fronts. And the one around diagnostics, biomarkers is particularly exciting, that also have a good ethical practice around sharing data, which is another of the themes of the conference, and also in working in different locations, which is another issue. You know, we are interested in companies that show an interest of bringing their breakthroughs all over, not just in particular areas too. And in general, in the Alzheimer and dementia community, there are people like Martin that are so committed that it's a joy to work with them anyway.
We like commitment, thank you. Okay, Paola, we must leave it there for now. Martin, thank you so much for joining us. Thank you. Right, welcome to Tara. Let's have a look at your film first of all, and then we'll have a chat about it afterwards. Thank you.
Clinical drug trials are imperative in the fight to find new solutions and interventions to terrible diseases such as Alzheimer's disease. People volunteer to test the treatments, people like Rachel.
Well, I just began to forget people's names, family names or friends down the road, and it gradually got worse.
As treatment began, Rachel realised that available medication was limited. After hearing about clinical drugs trials for people living with Alzheimer's disease, she wanted to contribute to the trials and says, above all, it's given her hope.
I suppose I feel comfort because I feel people are doing something and trying. I just hope in some way it stops me getting worse rather than achieving a miracle cure, you know.
Well, the clinical trials are really critical to take science from the lab bench to a point where we can impact meaningfully on people's lives. This is a team business, you know. The patients are the bedrock of everything that we do. It is for them, it is with them that all of this work is conducted.
And do you know which day of the week it is today?
Tuesday.
Okay.
Susan Fennick has been part of the Alzheimer's clinical trial for several years and continues to benefit from access to the experimental treatment.
Well, I just felt more settled, didn't I? After after a little while, I just really sort of calmed and just accepted things, and I just really seemed to cope easily.
Her progress is monitored by Dr. Emma McSweeney, who oversees medical trials at her clinic in London.
It provides somebody the opportunity to get early access to usually a new generation medication, which has been specifically designed to improve the level of treatment for a given condition.
Well, Dr. Sonia Miller joins us now. Thank you so much for coming along today. We saw in there, obviously a couple of patients who've taken part in trials. In fact, your co-founder was saying there that, patients are the absolute bedrock of everything we do. How crucial are they and their involvement in terms of what you're trying to achieve here?
Hello, Sharon. Thank you very much. It's amazing. I think the film shows the dedication of everyone involved. It just shines through across the world, across all of our studies. It's just amazing. And the people attending the conference also over these few days, the dedication there and the hope to make people's lives better. All of the people who are affected, the patients themselves, the families, everyone care, trying to make their lives easier to live with dementia. TowerX, since the film, it's very, very exciting. What we hope to be our final phase 3 study is now closed to screening. We are fully recruited, and we are really hopeful that we'll be able to present some top-line results by mid-2022. So this is a real milestone. This is incredibly exciting information. Our CEO that you saw in the film clip will be presenting a session this afternoon to describe the science. So if people are interested, they can then look into that either at the time or later to help understand what the tau pathology is and its relationship to Alzheimer's disease.
Well, congratulations on what you've achieved so far. Congratulations on what you've achieved so far. How far has COVID really impacted the work that you are trying to do? It was really important work.
Everyone has been touching on that, and particularly with the demographic we're dealing with, these are vulnerable people who would normally be self-isolating or more concerned or anxious about coming out. But what we found is that people were incredibly engaged. I think the fact of isolation or being at home more maybe brought home to people and family more so that people might be affected or struggling with certain aspects of life and normal function. People have been very engaged. very engaged indeed. We have sites from across the world, all countries, and we've had actually very little problem with patient engagement in wanting to be in the trial, wanting to attend for screening, wanting to do the processes, and everyone has come on board. At Tarex, we've had to be very flexible and proactive, obviously, make a protocol amendment to allow for managing in COVID-19 situations with new ideas of how to deliver the testing that's required, how to make provision for direct patient shipments of IP, for example, and remote administrations of psychometric scales. So everything we took for granted before has had to be rethought now in the light of COVID-19. And of course, the sites themselves, how they manage patients, and even the scanning facilities have been amazing. They all have, particularly for the dementia patients, they've allowed them, for instance, to stay in their car until just a few minutes before their appointment and then come in with their carers, which is incredibly flexible and human. It's been a huge effort by everybody and hugely exciting to be able to still progress the trial and this study, which is so important at the moment.
Incredibly flexible and human. I think that's great. Thank you so much, and thanks for everything that you're doing so far. Thank you, Sonia, for joining us. Thank you. Okay, moving on to Biogen now. Thank you so much. A lovely colleague of mine, Sue Saville, went to make a swim about Biogen, so take a look.
With Alzheimer's disease, what's going wrong in the brain starts long before the person becomes aware of it. Changes may begin 15 to 20 years earlier, with the buildup of two proteins, amyloid beta and tau. Understanding how this happens opens the way for early diagnosis and possible intervention.
Amyloid beta is a small protein that is constantly produced in our brains. And it usually has a very short half-life. In less than 20 minutes, it is degraded again before it can become harmful. Now, in contrast, in Alzheimer's disease, beta amyloid accumulates over time and becomes harmful. Nerve cells then react to that toxicity by trying to fight it in a very long process that involves additional cellular reactions, including neuroinflammation and the assembly of tau into neurofibrillary tangles. And in patients with Alzheimer's disease, the brain cells ultimately lose that battle and start to degenerate, which then results in the disruption of synaptic connections. False information is transmitted in the brain, and ultimately the nerve cells die.
Samantha Bart-Haberlein, who heads the Neurodegeneration Development Unit at Biogen, says identifying early signs of brain dysfunction is key for diagnosis and possible treatment.
There's a couple of reasons why we think it's really important for patients to consider getting their diagnosis early. One is really for the family themselves to start to understand what is the basis of their disease. That's always an incredibly important aspect of a diagnosis. For Alzheimer's disease, it may also mean being prepared as a family for what might come, getting things in order, understanding what can be done to help the individual or the family at different phases of disease.
Identifying early, I think, was the key message that we heard there. So I've been rehearsing this name all morning, so I'm hoping that I'm going to pronounce it right. So Dr. Antonella Santaccione-Chada, many thank yous indeed for joining us this morning from Biogen. Just tell us a little bit more about that film. Just flesh out the importance for us, as we were hearing, of really identifying early the key symptoms.
So good morning, and it is indeed an opportunity for me to be here today with you as a guest. And I'm also glad to meet Paola. There is a long-lasting collaboration with Alzheimer's Disease International, and we are really pleased to have this opportunity to comment on this movie that it is showing, as you said, the importance of diagnosing early the patients. And we heard also during the previous panel at Alzheimer's Disease International the importance of identifying risk that might induce the development of the disease and act on those risks to mitigate the starting. So the movie itself, it is something where we contributed recently. And I have to say that what has not changed is the willingness to contribute to bring a clinical development further and possibly disease-modifying treatment to the patients in the future.
And what's been the impact of COVID on you and what you're trying to achieve here?
Well, we heard it also from the colleagues earlier. I mean, COVID and this pandemic has put a big threat on patients above all. We know that social isolation, for example, it is detrimental for our cognitive functioning. This is what it is emphasized also in the guidelines developed by the WHO last year. So certainly when we have the vision of the patient at the center, we have to say that COVID has put things in a difficult position, I would say. And I think that Paola might agree on this. So while we acknowledge that this is a fact that impacted also the clinical development worldwide, but on the other end, we have the opportunity to transform into something positive, into something new, and eventually bring digital solutions, digital development further, such as that we will not be impacted with delay or with uncertainties in case things will not get better soon.
Paola, what are your thoughts there on what Antonella has just said?
Just as much as with the previous speaker from Taurex, one of the things that has been the most wonderful for us was that back in April, we were really worrying about the introduction to clinical trials. Now, in the case of Biogen, that would have been critical because this is a possible year for a possible disease-modifying therapy. All of our eyes are on the companies. There are a few that are coming up with new ideas, compounds, and therapies. So we didn't want that to happen, but also because we've been working with industry now for years to try and improve the standards of clinical trials. Industry has been extremely receptive to the difficulty that people with dementia have in enrolling in such trial and following them. So this has been fabulous, and this work and collaboration, we just didn't want it to end. And it's heartening to see the efforts that industry has done to continue on this path.
Okay. That's great. Thank you so much, Paola, for now. And Dr. Antonella, many thanks for joining us. Thank you. Thank you.
Thank you.
Right, we're moving on to New Zealand now, 12,000 miles away to New Zealand's gorgeous North Island, or 12,000 miles away from us here in London anyway. Let's take a look at the film for the University of Auckland.
Oh, I really like that. I shall dance too.
Artificial intelligence is just one way the University of Auckland is demonstrating its multifaceted approach to improving the lives of those living with Alzheimer's and finding a cure for the disease. Its Centre for Brain Research was established over a decade ago, and hundreds of its specialists in neuroscience are working hard to understand the physiology and function of the brain.
So we need to get in with any treatment, any way to slow the disease down. We need to get in early to stop the disease progressing. You can't replace the brain cells now, but early on, right in the very earliest stage of the disease, if we could slow the brain pathology down, the cell loss down, then we would be a winner. Then we would be able to help people. Slowing a disease down can be as good as almost as curing the disease.
Kia ora. My name is Irobi. I am your healthcare robot. It's nice to meet you.
The university's interdisciplinary approach has taken it out of the laboratory and into people's homes through assisted technology that can help the elderly, especially those with brain disease.
I was very sceptical when I came into this collaboration with the engineers that it would work, but I've just seen how the robot turns and looks at you. It says spontaneously, good morning, spontaneously, would you like to do some exercises now? And we think it's going to be a good mode of health promotion for older people.
I think it could be really useful in saving people from like falling over and forgetting things, which one does rather a lot. It's very appealing. I think I might take one home with me.
We're developing the robot specifically for people with dementia to give more companionship, to give more stimulation, that it may be quite a good match to get people exercising more interactions, more contact. It's going to be a lot of fun.
I love her positivity there, Paola, about it's going to be a lot of fun. We heard Sir Richard Fowle there talking really about, slowing the disease down, and we'd be a winner if we were able to do that. How important, Paola, is this sort of research?
Well, it's enormously important. I mean, anything that can help us understand, for a start, how these processes work. There is so much still that we don't know about cognitive deterioration. Even the current hypotheses, the tau and amyloid hypothesis, are hypotheses. So there is still a great amount and a great deal that we need to discover. And when those thoughts then are translated into practical ways, as you've seen in the video, for people to do things that can help them improve, that is also a cause of great joy. I mean, there is amazing stuff out there. One of the great, fantastic things of doing a conference like that is to bring some of these ideas to a wider public and to a global public, because some of these ideas are developed in specific countries. For example, South Korea is one of those that is most prolific, but not so good at exporting.
Why do films like this make such a difference?
Sorry, I didn't capture that.
Why do films like this make such a difference in terms of heightening everybody's awareness?
It's, I think, it's a bit like I said at the beginning, our biggest challenge here is that all of this could remain limited to the few people around the world that take an active interest in dementia and Alzheimer. And we do need to break that barrier. And that is why it's so heartening to see so many members of the public also attending this conference. We need people to be more aware of what is out there. And we do that, of course, primarily through our members, but we also need to do it through exercises like this, where everybody comes together with what is the best that their country has to offer. We also have to consider that not all achievements and not all progressions is relevant within certain cultural context. So opportunities to have films like that jots ideas that lodge into people's brain, but we also need the exchange for people to understand what works in their own cultural context.
Okay, Paola, thank you very much for now. We're moving on now to the National University of Ireland in Galway. We'll be speaking to Dr. Fiona Keogh in a moment. First of all, let's take a look at their film.
Helen is an advocate for people with dementia. In 2012, she was diagnosed with the disease when she was just 57 years old. This very interview is testament to her determination to not give up.
Niamh is here to support me with my promise, because I am not going to remember everything that I want to say to you, but those small promises took me 5 hours to write.
Helen's work takes her all over the world. It involves a lot of planning and a lot of help. It's a far cry from when she was first diagnosed. She gave up her job and quickly became depressed.
There was nothing more difficult in my life than to have to tell my child, to have to tell my only son, my only child, as he was just embarking on his career, that his mother had Alzheimer's.
It was her involvement in research that brought her hope. Helen works with the Centre for Economic and Social Research on Dementia, CESRD, based at the National University of Ireland in Galway. The vision for the centre is to provide transformative research and policy frameworks that will support people with dementia to carry on living their life in their community. The biggest change in research in the last 10 years has been the involvement of people with dementia. Their voices are supporting policies that influence change. The Irish government is reviewing support in the home.
We did do a research study with people who had very high levels of need, and we found that when this very kind of tailored care was offered and provided, that it was still cost effective for a long period of time. So it really is possible to support people to remain living well at home.
Importantly for Ireland, there's new legislation about to happen, which is to do with rights for home care. The challenge over the next number of years is to find the funding, find the resources in order to ensure that the rights that we're about to bestow can be realised in a real way for people with dementia.
Dr. Fiona Keogh joins us now, the same person you saw in the film there, looking equally lovely. Not in red today though, Fiona. But we did see there a real sort of human interest element about, a mother having to tell her only child, I've got dementia. We can't imagine how incredibly hard that must have been, can we, and what the repercussions of that are.
Yes, I suppose we're really focused on trying to highlight that very human impact. What does it really mean for the person who has dementia and for their family? And a lot of our research is focused on that. So I suppose, some of the work we've been doing has been talking to carers of people with dementia, but also importantly involving people with dementia very directly in the work that we do. So that means not just answering questionnaires or taking part in interviews, but actually being involved in how we design our studies. And they're on the committees that, oversee how the study is conducted, and they input on the materials and give us advice all along the way. And I think that really increases the relevance of the research that we do and increases the impact and gives us a more direct link, if you like, into policy and policymakers.
And what's changed since we filmed with you? I mean, clearly everything has changed in terms of our COVID impact this year, but what's specifically changed for you and how you go about your work and your research?
So, well, as you can see, I'm not in the university. I'm in the spare bedroom at home, as everybody around the world, I think. But facilities like Zoom and online has helped us to stay very directly in contact with the people that we've been working with, and we've been continuing our work. I mean, one of the first things that we did, we were concerned, as Paola referenced earlier, with the invisibility of people with dementia as COVID started to strike and really affect all of our society. So one of the first things we did was myself and Helen were in regular phone contact, and we wrote a piece on the impact of COVID-19 directly on a person with dementia, and we published that on an online platform, very in the very early stages. And we wanted to have a contemporaneous account of what it was like as a person with dementia to live through this pandemic, and other colleagues have been doing similar work. So Professor O'Shea, who you saw on the film, wrote a piece kind of directed at policymakers, again, to kind of make the people with dementia visible and the impact on people with dementia more visible, so that the plans around cocooning and around the impact on people in long-term care, for example, that dementia was much more to the fore.
Okay, Dr. Fiona Keogh, there we must leave it. Thank you so much, and good luck when you do return to the university. But the spare room is looking lovely.
Thanks very much.
Moving on now to, thank you so much, thank you. Moving on now to Geras Solutions. Now, earlier in the year, we interviewed Hazim Newman and also Victor Bloniecki, and in a moment we'll be speaking to Richard Forsman, who's the CEO of Geras Solutions. But first of all, let's take a look at the film we made for them.
Tell us a little bit more about what it is that you do and how it really helps so many of those as yet undiagnosed.
Exactly. So we really have two perspectives here. The first is foremost the patient naturally and their family members. We need to give them the ability to obtain early stage diagnosis in order to improve outcomes for them and their family members. But secondarily, we want to improve the ability for specialists to actually diagnose and evaluate patients. Instead of focusing on manually collecting data, we aim to streamline, automate, and standardize this procedure in order to lower administration bias and improve diagnostic outcomes for the patient.
Accessibility is a major problem, and one of the main reasons is that currently the way to diagnose dementia is that the cognitive screening is a paper and pen test which need to be administered by healthcare providers. So this obviously takes a lot of time. What we have created is a clinically validated cognitive test which is done on a tablet and can be used from the comfort of your own home, whether you're in Arizona or Singapore, and directly uploaded to the doctor to see the results.
And tell us a little bit about how this technology works.
So essentially, the main part of the medical device is aimed at patients to be able to answer several different parameters. The first is a cognitive test. The second is an anamnesis, as well as a symptom survey that allows us to actually understand, are they cognitive impaired, or is there something further to look into?
Additionally, a big part of our app is based on the Finger study, which is an intervention study focusing on lifestyle changes in order to decrease the risk for dementia. So, for example, if you focus on nutritional changes, physical therapy, and cardiovascular risk factors, it has been shown that you can increase your cognitive ability and also, compared to the control group in this study, then increase processing speed, executive function, and also complex memory tasks.
So, Haza, moving forward, what are your aspirations now for people living with dementia?
So our aspirations are essentially to provide access directly to patients and family members through remote means, naturally, in hopes that we lower the stigma, in hopes that we lower the threshold for them to get a diagnosis, and in hopes that they eventually will be able to take on these measures to improve outcomes for themselves and their family members when coming to brain health and cognitive ability.
Richard Forsman, good morning, and thank you so much for joining us. Thank you. We saw there in that film your colleagues talking about the importance of, learning from your own home, adapting things from your own home, something that we can all, that resonates with all of us certainly this year. How crucial is that for people and for their families in terms of dealing with what is, for a lot of people, a new diagnosis?
Absolutely. So, I think it's clear to all of us now, given the latest developments and the situation that we're in now, that the ability to actually get help from home at an early stage is more important now than ever. And we're really happy that we actually have a solution that can help individuals to do this in a lot easier way, because we know that a big challenge here is, of course, that it takes too long time for people to reach out to healthcare and to get in contact. And the early symptoms, they show up earlier and sometimes years before you actually reach out to healthcare. And we will be there, and we want to be there for these individuals when the first signs are seen, to be able to speed up the diagnostic procedure and to get help earlier.
And what sort of impact has COVID had on you this year in the work that you're doing?
So, of course, it has changed a lot. So, for one thing, of course, we are running now with clinics in Sweden, and the tool is used in clinical practice. But of course, what we've seen is the shutdown of many clinics. So, because resources are needed elsewhere, and also these patients are typically in risk group that you don't want to take in. So, what we've seen there is more or less a stop in operations from memory clinics, which is, of course, has impacted us in a negative way short term. The important thing is, however, that the knowledge and understanding that digital tools are the future, and they are really needed to actually help out there. And we're starting now to see a few cases where our platform is actually leveraged to continue to provide good care for patients in situation where that would not be possible with regular means.
And you talked about the future there, so going forward for 2021, how hopeful are you of things while returning to some semblance of normality, or for you to be able to do what it is that you need to do and to adapt and survive?
So what we're doing now is we're not waiting for COVID to pass, but we're actually taking action now and launching already in January the first online memory clinic to allow people to get support and get in contact with a doctor online specialized in dementia and cognitive disease. So we're really excited about this actually, to be able to provide that. And we're, of course, not saying that we will be able to diagnose dementia with the help of digital tools, because much more is, of course, needed. But we will be able to start the process, and we will be able to identify those mild cognitive impairment cases that can then be channeled further to a clinic. And we're also implementing, as mentioned, by Victor and Haza in the video as well, the risk reduction methods based on the Finger study, so we can provide coaching to help lower the risk and support there.
Okay, Richard, very interesting, and many thanks for joining us. Thank you so much. Okay, and finally, Bore da Cymru, Good Morning Wales. Moving on to the Welsh Ambulance Service. We'll be talking to Alison in just a couple of minutes, but first of all, let's take a look at the film of the Welsh Ambulance Service.
For people living with dementia, using an ambulance, whether it's for an emergency or a planned trip, can often be a stressful experience. And for paramedics like Lee, knowing how to recognise the condition and respond appropriately can make all the difference to a patient's support, care and treatment.
I can think of one particular patient where she was non-verbal, she was very advanced in her dementia, but she had a pain in her leg, and it was reported that she had a pain in her leg, but she couldn't tell me that. And she was just crying and shouting the whole journey into the hospital. And one of the techniques that I've been taught is something called a hand pump, where you actually hold someone's hand and just gently squeeze it. And by doing that, I managed to get her to calm right down. And by the time we got to the hospital, we were singing songs together and she was nice and calm.
It's training like this that the Welsh Ambulance Service's NHS Trust is rolling out to all its staff to raise awareness of dementia and ensure the needs of people living with the condition are met.
We're really trying to understand the needs of people living with dementia as they use and access our services. So we're building up that continuous training programme at the moment to make sure everybody has the right skill mix and knowledge around dementia. And what's wonderful about that is that people living with dementia are involved in that work. They are influencing the content of that programme, and they're actually up front and centre delivering the training with us and for us.
For Linda, playing a key role in the project has made her feel valued and listened to.
It's given me such a boost, such a confident boost. I can't praise the ambulance service enough. They actually listen to what people with dementia want from the service, what they need from the service, and they've delivered it, and that means so much.
Wow, Alison Johnson from the Welsh Ambulance Services. I can really see the impact that your work there and your training is having on people. I mean, you know, we saw your colleague there talking about holding hands, just something as simple as squeezing the hand, and in the end she was singing songs, you know, and I thought, wow, how lovely is that? I mean, how essential is that sort of training in terms of what you're trying to achieve here for people with dementia?
Well, Bore da Siamai from Wales. Thank you so much for this opportunity to be involved in this Hope in the Age of Dementia programme. So yes, you know, first of all, I will say that we're really proud of our continuous engagement model, where people affected by dementia are very much involved in driving our work programme and guiding our projects. So through that, you would have seen there how people, you know, living with dementia are front and centre in developing and delivering training content to our workforce, a very broad workforce across Wales, and to some of our other emergency service partners, which has been great also. And we can see the impact that people affected by dementia are having on the skill mix and the knowledge base of our workforce as we really ramp up the training that we're delivering to our staff now.
And clearly, you know, all NHS staff have had an amazingly busy year. I mean, unprecedented, obviously, and thank you. How has the work that you're doing specifically with dementia patients really been impacted by the pandemic?
So we know that COVID has had an impact on the people that we serve. There's more difficulty and maybe stress and anxiety now for people particularly affected by dementia as they access and move through our services. So, you know, COVID has meant that we've had to change our workforce and our operational policies and procedures, and some of that has had a detrimental impact on people affected by dementia. For example, things like our PPE equipment. We know that even just wearing a face mask is having an impact on how we communicate and engage with people living with dementia, and communication channels can sometimes be broken down then. Another area that is really worrying for us at the moment is that we often have to leave the carer at home, maybe if we're transporting the person affected living with dementia to a hospital or another place for care, that the carer is no longer able to travel with the person living with dementia, or vice versa, where we might be taking the carer into hospital and we're having to think about the support and care that's provided for the person affected by dementia, who we may or may not leave at home then.
Okay, Alison Johnston, reluctantly there, we must leave it. It sounds incredibly interesting, and well done, and congratulations on the work that you're doing. Diolch yn fawr iawn, thank you. So, Paola, if we can turn to you for some final thoughts, and we've heard so much just in the last hour about what people are doing to adapt and survive, and how they're really trying to push forward all the research and the crucial work that's being done here. What do you think of everything we've heard today? I mean, it's incredible, isn't it, how fast people have been able to adapt in every area of their life, but particularly with this research.
It's been, heartbreaking in a way to hear Alison just speaking about this terrible anguish, of families having to be left out as a person is being carried away. And we've heard this so much, especially at the beginning of the pandemic, of people being separated in hospitals. I mean, at some point, ADI had to publish some really heartbreaking guidelines to tell families that perhaps bringing a loved one to hospital may not have been the best solution in the height of the pandemic, because they would have been deprioritized for treatment at the hospital. And some of these stories that have come in have been very, very sad. Having said that, I think what has been so wonderful to see, and what gives me so much hope, is the amount of pulling together of everybody in finding practical solutions to these issues. I was mentioning in my plenary about, Brazil inventing the hang curtain. So it's a plastic curtains where you essentially put your arms in and you can hang a loved one through the curtain, just so that you cannot just see them, you can hang them. To have these sometimes very low-tech solutions, at times very high-tech. I mean, the Alzheimer's Association in America came up with some lovely ideas on how to enable families to be in touch with people away from the home through technology, for example. So there's been so much, and hearing, Gera Solutions speaking about how they're going about it, the wonderful interview with NUI Galway, the way that they have looked at testimony, like the powerful testimony of Helen Rochford-Brennan, it's been to alert awareness, to arise awareness. It's been a fantastic way of how the communities come together. Again, I can't thank ITN enough for making a film of this caliber that allows really at this level of synthesis to get into people's brain about what is happening and why it is important.
Okay, thank you so much, Paola. Thank you. And I think we could all do with a cuddle curtain, couldn't we? Just briefly, Paola, how can ADI help now? What kind of ideas has this given you for going forward? What sort of food for thought are you going to leave us with?
Well, it's very interesting because our strategy for next year, as I said yesterday, is to do more of this global awareness raising, to get people together to shout a bit louder. But also from a practical viewpoint, I think we have now set up a series of quite hard-hitting webinars already for the first half of the year, in which we're going to take some of these big ideas that clearly are also generating a lot of questions and try and explore them further. We are already working on 2 or 3 important ideas, of which what's his space, between January and April. Some of them are about making people aware in greater detail of what is available in their areas, or if not, how can they make it available. So this is hopefully going to be a source of inspiration now for months to come.
Paola, you're always working on ideas and you're always a source of inspiration, so thank you. Thank you so much, Paola, to you, and thank you so much to all our guests for coming along today. Have a good Christmas all, good luck with next year, and see you again soon, maybe in person next time. Thank you so much.
Thank you, Sharon.
Thank you.
Live? Yes. Okay. Well, hello everyone. Welcome to plenary number 4. I'm not even going to wish you good morning, good afternoon, or good evening, because I'm sure there will be so many of you dialing in from different parts of the world and different time zones, different times of the day. So welcome anyway to plenary 4. And the title of today's plenary is The Journey, Diagnostics, Treatment, Care, and Support. Today's plenary, or before I do that, maybe let me introduce myself. I'm so sorry. My name is Jason Fu. I'm the CEO or Chief Executive Officer of the Alzheimer's Disease Association in Singapore. I've been with ADA for short for 30 years. I've been involved in ADA for 30 years, 22 years as a board member, and the last 8 years as Chief Executive Officer. So my involvement with dementia, with the Alzheimer's Disease Association it's been a long one, but it's been really meaningful and been really fruitful as well. So coming back to today's plenary actually covers 3 broad areas. One is early diagnosis, which is a topic which is constantly being discussed because we know how important it is for early diagnosis. The second area is architecture and environment. Again, another huge impact it has on persons living with dementia. And the third area which today's plenary will cover is how different countries deal with dementia and how the dementia is perceived in each country. Surprisingly, this is shaped and influenced quite a lot by the country's customs, beliefs, and religion. Something very interesting, and we will get to hear more of it when the speakers share today. For those of you who are familiar with dementia and work with dementia, you will know how important these 3 areas are as they affect the well-being of persons living with dementia. So we're very fortunate today to have 4 experts who have taken time off from their busy schedules to share their knowledge and experience with us. So without further ado, let me introduce the first speaker for today's plenary. He's Dr. John Morris from the US. Dr. Morris is not with us live because of the time difference. And so his session is recorded. Dr. Morris will be with us live when we come to the Q&A session. So Dr. Morris is so well known. It's really quite difficult to introduce him. He's the Harvey A. and Doris May Hacker Friedman Distinguished Professor of Neurology, Professor of Pathology and Immunology, Professor of Physical Therapy, Professor of Occupational Therapy, and Director of the Charles F. and Joanne Knight Alzheimer's Disease Research Center at Washington University School of Medicine. Dr. Morris's research include healthy aging and Alzheimer's, dementia, antecedent biomarkers for Alzheimer's disease, and trials of investigational drugs for the treatment of Alzheimer's dementia. Dr. Morris has authored 4 books, published more than 600 articles, is a member of several professional societies, serves on numerous scientific and community advisory boards, has received many honors and awards, and is currently ranked in the top 1% of investigators in the field of neuroscience and behavior. So let us sit back and then really be inspired by Dr. Morris's presentation.
Hello, this is John Morris from Washington University in St. Louis. Delighted to be a part of the Alzheimer's Disease International Virtual Conference 2020. And I'm going to present on making sense of detection of cognitive disorders. How early is early enough? First, here are my disclosures. The research that I direct at the Knight Alzheimer's Disease Research Center here at Washington University is largely supported by grants from the National Institute on Aging, part of the National Institutes of Health of the United States. We do receive foundation support, but I have no other conflicts. Why early detection? Those of you who are clinicians appreciate that often it is useful to make the diagnosis early in the symptomatic course so that the impaired individual still has sufficient cognitive ability to contribute to decisions that will come in the future regarding his or her care. For example, who should be the legally authorized representative to make medical decisions, financial decisions when the patient no longer has sufficient capacity to do so. This would, early in the course, would be the time to make any updates to one's last will or testament. And then the person should be able to give his or her wishes regarding end-of-life considerations. Early detection also will be important if there were to become truly effective mechanism-based therapies for Alzheimer's disease. They likely will be most effective in individuals who have the very mildest symptoms. As of November 23rd, 2020, there are no mechanism-based therapies that have been approved for the treatment of Alzheimer's. And indeed, there has been a legacy that all such therapies have failed, but it is possible that the reason for the failure, or a reason for the failure, is that they are administered to individuals with symptomatic Alzheimer's disease, which may be too late in the overall course of the illness, because even at the earliest symptomatic stage of Alzheimer's disease, already there is irreversible synaptic and neuronal damage. So it may be that we have to detect the pathology of Alzheimer's disease prior to substantial neurodegeneration and prior to symptomatic onset. That is, we have to identify preclinical, pre-symptomatic Alzheimer's disease and initiate therapies at that point. Symptomatic Alzheimer's disease begins with very minimal symptomatology and progresses to the end stage of the illness and death. At the time the symptoms occur in certain vulnerable areas of the brain, including the entorhinal cortex, already 50% of neurons have been lost. Most of the mechanism-based therapies that have been tried in symptomatic Alzheimer's disease target amyloid beta, but any monotherapy in this symptomatic phase may not be sufficient because there are many co-pathologies besides amyloid or tau or whatever. So it may be that ultimately we will need combination therapy for this symptomatic stage of Alzheimer's disease. However, it is also important to now consider preclinical Alzheimer's disease, which is the major duration of the illness when the pathologic changes are building, first initiated by disruption of amyloid beta homeostasis, but then adding factors such as elevations of cerebral spinal fluid tau and deposition of tau throughout the brain, and many other pathologies that ultimately disrupt synaptic and neuronal integrity. When that occurs, the person is on the path to symptomatic Alzheimer's. Prior to that, however, may be an opportunity to initiate therapies that might delay or even prevent the onset of symptomatic Alzheimer's disease. How can we detect Alzheimer's disease in its earliest symptomatic phase and in its asymptomatic phase? First, we recognize that Alzheimer's disease is a global disorder and that the greatest increase in prevalence in coming years will be in developing countries. 2/3 of the world's older adults already live in developing regions, and the numbers in these developing countries will increase faster than will occur in developed regions. This is important because, of course, the major risk factor for Alzheimer's disease is age. As we see here, the vast majority of individuals with symptomatic Alzheimer's disease are 70 years and older. And as the world increases its aging population, you can see the marked increase in the number of individuals who are projected up to 2050. So how will we detect symptomatic Alzheimer's disease? Well, ideally, there will be screening instruments that help identify individuals who need a more elaborate evaluation to be certain of the diagnosis. These detection tools should be brief, easy to administer, inexpensive, sensitive, and accurate. We have challenges, particularly when we try to apply tools developed in developed countries to individuals in developing countries where education may not be the norm. Older adults may live with families who conduct the cognitively demanding tasks for them, so they're not challenged. And ideas and concepts about dementia, Alzheimer's disease, and other disorders may differ very widely from the countries in which the screening instruments were developed. Proxy-based cognitive assessments, that is, the observations of someone who knows the individual well, typically a family member, can often identify cognitive decline using the individual as his or her own control. This will capture intra-individual cognitive decline. A person is no longer performing at the level he or she once did because of cognitive loss. These proxy-based assessments are face valid because they assess cognitive and functional ability as demonstrated in that person's everyday life, and they avoid ceiling and floor effects that are common to cognitive tests, as well as avoiding other issues, including practice effects and linguistic and cultural differences. But there are disadvantages to proxy-based cognitive assessments. First, it requires an observant proxy study partner, and the instruments that have been developed to date using proxy-based assessments largely have been done to assess Alzheimer's disease dementia, and we don't know how well they will work or whether they'll be valid in non-Alzheimer's dementias. A brief dementia screen administered or self-administered by an individual who knows the person well, a proxy, is the AD8. It's developed at Washington University from a larger instrument called the Clinical Dementia Rating, and it assesses change over time due to cognitive loss only. So it assesses that intra-individual decline and how it affects everyday function. There are 8 questions that the proxy answers. You can see them here. If 2 or more of the 8 questions have a yes answer, then the positive predictive value for dementia is 87%. More information about the AD8 is available at the Knight Alzheimer's Disease Research Center website, which is shown here at the bottom of the slide. We evaluated a number of screening instruments for dementia in 230 individuals who were participating in the Knight Alzheimer's Disease Research Center programs. All were cognitively normal at baseline, and all later came to neuropathologic evaluation. We examined the subjective memory complaint of the participant, Are you having problems with your memory or thinking? We examined a cognitive exam, a brief cognitive exam, the mini mental state examination. And we also examined independently the AD8. You can see that the subjective memory complaint and the AD8 required 2 minutes or less to complete and could be self-administered, whereas the mini mental state examination requires an examiner and takes 5 to 10 minutes. All of these instruments predicted later neuropathologic Alzheimer's disease, but the sensitivity differed widely, and the AD8 was most sensitive at 87%. In the future, we will also incorporate molecular biomarkers for Alzheimer's disease to detect the process in its earliest phases. The 1990s, cerebral spinal fluid levels of amyloid beta 42 and tau were introduced in the 2000s. Radioligands to identify amyloid accumulation in the cerebral cortex, and more recently to identify tauopathy in the cerebral cortex have been identified. And these molecular biomarkers will identify the pathology of Alzheimer's disease regardless of whether the person is symptomatic or not. In symptomatic individuals, these biomarker findings can be used to support a clinical diagnosis of Alzheimer's disease. And in fact, already biomarkers are being incorporated in clinical trials to assure that the individuals who are randomized in the trials actually have the pathology that the experimental agents are targeting. In asymptomatic individuals, it can identify preclinical Alzheimer's disease. Preclinical Alzheimer's disease lends itself to prevention trials, wherein cognitively normal persons who have positive AD biomarkers denoting early Alzheimer's neuropathology can be administered therapeutic agents prior to extensive neurodegeneration. Here, the goal is to delay or even prevent the onset of symptomatic Alzheimer's disease. Prevention trials have been underway since 2012, and more are coming. We hope to find beneficial results, but these studies understandably require many years to demonstrate efficacy. So how early is early enough in Alzheimer's disease and dementia detection? Early detection of dementia empowers the patient to plan for his or her future. The earliest symptomatic stages of dementia, particularly Alzheimer's dementia, may be the optimal time to initiate any future approved therapies. And note that if they are to be administered to symptomatic individuals, it may be a combination of therapies attacking different pathologies. Identifying the preclinical stage of Alzheimer's disease is possible with molecular biomarkers, and now with blood-based biomarkers, which are much less expensive, require much fewer specialized facilities, and this will accelerate prevention trials. I think we will look back on this year, 2020, despite all of the tremendous upheaval caused by the COVID-19 pandemic, as a watershed year in Alzheimer's disease, where we can envision both truly effective mechanism-based therapies and the ready detection of persons who will benefit from them. Thank you very much.
Thank you very much, John. That was definitely very inspiring, and we hope to see him at the Q&A session later on. I've been reminded that there is welcome remarks from our ADI Global Ambassador, Queen Sofia from Spain. She should have come on before John Morris, but I forgot. So let's welcome Queen Sofia and listen to her welcome remarks before we go to our second speaker for this plenary.
Welcome, and thank you all for joining us at the 34th Virtual Conference of Alzheimer's Disease International, of which I am proud to be a global ambassador, and therefore it is with great pleasure that I am able to address different Spanish-speaking countries. This year I am especially passionate about the global dementia cause. We are experiencing unexpected challenges that affect everybody in every country around the world, with people suffering dementia and are amongst the worst affected by COVID-19. Now more than ever, we need to work together to share our experiences during this difficult year, but also to remember that there are wonderful things happening across the world, like the developing of vaccines for COVID-19, which gives us cause for hope. Therefore, we hope to eradicate the COVID-19 disease and find the cure for dementia, or at least the slowdown of its development. Last year in Spain, we proudly approved a national dementia plan, which we are now trying to implement despite the problems caused by the pandemic. Nevertheless, this support will be essential for the Spanish population affected by dementia now and in the future. The national level, that of which responses to this disease will be crucial in tackling the problem. I would also like to share with you that the Queen Sofia Foundation, which I preside, has been fighting these neurodegenerative diseases for more than 18 years, and next year we shall double our efforts on research for an early diagnosis. This conference will be an important moment to provide hope with our efforts towards a better world for all affected. I wish you a very successful conference.
Thank you, Queen Sofia, for your welcome address to this plenary. So now that brings me to our second speaker, Dr. Hamid Al-Sinawi. Dr. Hamid Al-Sinawi will speak on social customs, expectations, and religion in shaping dementia care. Dr. Al-Sinawi is a senior consultant old-age psychiatrist at Sultan Qaboos University in Muscat and the chairman and founder of Oman's Alzheimer's Society. He completed his residency and higher psychiatry training in London and established a memory clinic in Oman in 2011. Dr. Al-Sinawi is a trainer for residents and medical students. His research are in the area of geriatric psychiatry, mental health stigma, and medical education. Without further ado, let me welcome Dr. Sinawi, and over to you, Dr. Sinawi.
Thank you, Mr. Chairman, and I'm delighted to be speaking to all of you. Good evening, good afternoon, wherever you are, and it's my pleasure to talk to you about social customs, expectation, and how cultural beliefs and religion shape our understanding and our dealing with people with dementia. Next slide, please. No conflict of interest. Next slide, please. The outline of my discuss. We go back to the previous slide. We talk about dementia as a medical model. We'll talk about component that both as well from the social point of view, people see when they are dealing with a person with dementia. We will also talk about the way of caring for people with dementia all around the world. What are the different behaviors? What are the attitudes? And how can that shape the person's experience? We will also touch upon their role, beliefs, religion, and societal expectation on acting with the person and providing care. And finally, I will go through summaries of different cultural beliefs from countries around the world. Next slide. Next. So when we talk about dementia, the model, the medical dementia who are experiencing symptoms of dementia come with memory problems. They come with different symptoms that are so get to be seen by dissociation, behavioral difficulties that can cause tremendous stress for the caregiver. They also have pain, which is a very untapped on when it comes to dementia care providers, because sadly people they the illness progress, they find it difficult to express themselves in language. Pain sometimes get exhibited as a form of agitation or aggressive. At the end of stays bedridden, the patient experiences swallowing difficulty, needing more care and from caregiver. What are the models of care for people around the world? It varies from the medical model, usually predominant in the Western or the developed world, whereas other models are experienced elsewhere. There are lots of social background that shape the experience of the person, the expectation of the family members, and the way the caregiving journey has been experienced by the family and the person experiencing dementia. And there is also religion. The religion makes it very important for the person to make understanding, make meanings for their symptoms. Sometimes religion also influences the way caregiver does their job and perceiving the very hard duties they do with their person with dementia. Next, please. Yes. So why should we talk about social costumes and expectation? First of all, it helps us understand the different challenges associated with dementia, the different experiences caregivers get to see. It also, to some degree, determine how help is seeking family members. How do they ask for either from the different health social care services? Cultural expectation also have a huge impact on how caregivers perceive their role. It will also prevent them from experiencing stress and burnout, which is a very well concept when it comes to caring for a person with dementia. And it also has a huge impact in helping us develop education, caregiver care, background, and religion help us to provide that kind of quality of care. Next, please. Next slide. So when we look at who cares for people with dementia, we usually find family members and who are known as non-direct or caregivers or non-providers. It could be a son or daughter or wife. In most of the countries, it's expectation of females to be the main caregivers. So there is a huge stress for ladies or females to care.
Hello. Hi. We have some technical problems from Oman. Dr. Hamid Al-Zinawi is from Oman. I understand that he has dropped off. So what we'll do is we will move to the third speaker. And our third speaker is from Switzerland. It's Mr. Michael Schneider. I hope I have pronounced his name correctly. And Michael, for 30 years, has led the Sonwit. I hope again I've correctly pronounced the name of the home that Michael has managed for 30 years. And he developed models of caring for people with dementia. At the end of 2015, he handed over the management of Sonwit. And since then, he has been working as a consultant and speaker. And in the same year, he published a book. Again, unfortunately, I'm not able to pronounce the name of Michael's book, but I'm sure Michael can share with us the name of his book during his presentation. So over to you, Michael.
Hello. I speak about architecture and dementia, or how to build a human-friendly environment. I'm very proud to talk about architecture and dementia, not as an architect, but as a founder and former director of one of the best-known care units for people with dementia in Europe. The nursing home Sonnweit started in 1986 with a new concept. Today, 157 people are living there, 10 persons are staying in a short-time care unit, and the staff consists of around 300 persons, most of them working part-time. Sonnweit was founded as a private company with 2 owners in 1986. It was always our goal to create an environment which takes care of the different stages of Alzheimer's disease. Today, I will mostly speak about architectural concepts for nursing homes and their special needs. I will not talk about the time when the patients still live at home. Now, we know how it works, and we know why it works, and we know the reasons for things that don't work. It has nothing to do with magic. It is all about closely observing people in their environment, their nearest surroundings. Some thoughts about certain topics. Never alone. Most people with dementia don't want to be alone. While the illness progresses, the need to withdraw becomes less important. They want to be where everybody else is. Being alone makes them feel lonely. They don't like it. On the contrary, they are looking for community. Mankind has been living in communities for thousands of years. It provides a feeling of security, of not being alone, of being part of the social system. These are important goals in the course of different stages of the illness. The architectural concept of the Sonnweit and the Marvida Park in Velten in Austria are based on these thoughts. In my speech, I will show you pictures from Sonnweit and the Marvida Park. The public areas are the most important places. Living rooms, kitchens, corridors, gardens. And we have 3 different concepts. A care unit is necessary as soon as stress and burden for husband, wife or other caregivers become unbearable. Sonnweit and Marvida Park has 3 different concepts for living and care in the advanced stage of the illness. First are the living groups. 20% of the people in the medium stage of the illness can still do things together. They can interact and be part of the daily household system. Kitchen, table and living room are all in one room. Residents are not expected to do anything, but they must accept some social rules. The second are the care groups. 70% of the people living in Sonnweit are in the severe stage of the illness. They walk around aimlessly and have little contact with others, but they still need to be part of the system. Fewer social rules, but a lot of cumbersome care is necessary in all their activities of daily living. We offer only 2 bedrooms because we have experienced that people don't want to be alone. It makes them feel secure not to be alone. Food is provided by the main kitchen. The third are the care oases. 10% of the residents are in the very severe stage of the illness and they need meticulous care in all things of daily life. We have developed this oasis concept for more than 20 years. Most people are spending their time in bed. Most of them cannot walk alone for more than a few seconds. Verbal communication is almost impossible. 8 to 11 people live together in one big room, day and night. Everything happens in this room: care, eating, sleeping, nursing. Thousands of years ago, all people used to live in communities, in caves, in big families. Nobody used to live alone. This experience is rooted deep in the human brain. It helps us to live together without fear. I'm not alone. Somebody is here with me. That makes me feel safe. All 3 concepts of living together give the patient security. They are getting all the care they need. This includes the possibility to change the unit when the best care cannot be granted any longer. Main criteria for such a decision are social and mental abuse or overload or disruptive behavior by a singular member of the group that cannot longer be tolerated. Because stress means trouble, unnecessary trouble. Miliotherapeutic interventions will reduce such issues in 70% of all cases. Medical interventions succeed only 30% of the time. Having said this, we are all beginning to realize that architecture is a key issue in caring for people with dementia. In and out. Special care units or nursing homes must allow their residents to be able to leave the building whenever they like during the day. When the weather is nice, everybody wants to go outside. Suffering from dementia or not, it is simply normal. It is important that the outdoor area is spacious, giving enough room to wander around without getting lost or endangered. Relatives and friends are also enjoying being outside once in a while. Going for a walk together means doing something together, being around each other, taking the same path. And for a precious few moments, the illness loses its horrors. The patient should be able to go there on his own. He should not have to wait until a nurse has time for him. He has no insight into his situation. He doesn't know anymore that he is suffering from dementia. He feels healthy. He doesn't want to be cared for all the time. All his needs must be satisfied instantly, not later. The art, here as an example, the crystal tree, goes along with the people in and out. Architecture must incorporate the surroundings. A balcony is not enough. People who have plenty of space don't want to leave because they don't feel any barriers. They notice when they are restricted and won't leave. The elements: water, air, fire and earth. People suffering from dementia need primarily safety and security. To provide this, there are many possibilities, for example, the confrontation with the elements. Since before birth, every human being has been in contact with water. Deep inside, we recognize the feel, the noise, the vibes of water. The body does not forget this. It is imprinted in us. The air to breathe, the fire that gives warmth, the earth that feeds. The natural elements provide security. This is what architecture must convey: contact with the elements, rivers, waterfalls, the sounds of water. A waterfall in a building provides a noise floor. People recognize it, it reassures them, not on a cognitive level, but deep down on an emotional level. Similar with fire. It can mean danger as well as warmth, security, community. People have always gathered around fireplaces. This is also something which is deeply embedded in human history. Different special care units. A nursing home should not look like a care unit. On first sight, it should rather remind us of a hotel. Nobody wants to live in a care unit. If it has a look and feel of a nice place where one would like to stay, we are approaching the aesthetic concepts of a wellness hotel. This is also important for relatives, friends, visitors, and for the people working there. This concept is founded on the idea that it should be possible for everybody to live his or her personal model at Sonnweit. This can work if the architect provides the ground for it and if he has internalized this principle himself. The people with dementia must be able to understand the world around him or her intuitively. This means, with reference to the aforementioned 3 special forms of co-living in Sonnweit, that a patient in a care group should not be hindered in his urge to move around. Cozy corridors, sofas, armchairs, a bed in the living room. This should all be possible. The rooms are bright or brightly lit, with a clear structure and function. It is mostly quiet. The sound reduction works. Noise is one of the main reasons for restlessness and nervous patients. Often are hard materials such as a metal the cause for noise. Sometimes it's a radio or a television. Mostly it's the people working there, creating stressful situations through recklessness, or they take among each other and the patient does not understand. He is getting confused. Public spaces in the Sonnweit and the Mawida Park. You are welcome is a message we want to convey, not only to the residents, but all people in Sonnweit. You are welcome is a motto for the root of our care unit, and the applied architecture should do everything possible to support this welcoming culture. Spending time in a precious, well-cared-for environment gives you something back. It makes you feel better, more valuable. Like when you are on holiday. Nice surroundings lift you up, an ugly environment can spoil your week. Why should this be different for people suffering from Alzheimer's? Again, people in precious, beautiful surroundings perceive themselves as more valuable. This is exactly the point we want to make here. There's a direct link between a beneficial environment and self-perception. Many visitors ask me why it is always so quiet and peaceful in Sonnweit. And the same thing is happening in the new Mawida Park Care Unit in Velten, Austria, which has a similar concept. The answer is obvious. There are no reasons to shout. Nobody must hurry through the building. Everything is quiet and calm. People can do many things by themselves. They don't need help. Most of the time they go their own way. This is probably one of the main reasons for not having many residents suffering from a disrupted day and night cycle. Public space has to be designed and developed in such a manner that it makes the people within feel valuable and accepted. This includes the possibility to walk around freely from one floor to the next. There are no steps, there are only ramps to walk inside as well as outside the buildings. Wellness. People feel better in a well-designed environment. This includes the use of variety wellness services, similar to a good hotel, massage, bathing, beauty treatments. You don't have to suffer from dementia to enjoy such treatments. Friendliness as a concept. Be friendly to everybody and all the time. Architecture must create an environment where being friendly with each other is easy and natural. Architecture must create rooms that give little reason for mishaps and misfortunes, because everything can be cleaned, nothing gets broken so easily. It is our experience that beautiful things don't get broken preciously for that reason. They are treated with care because they are beautiful and precious and appeal to our sense of aesthetics. Architecture must support employees in their hard work. Working with people with dementia is one of the heaviest and most demanding jobs you can imagine. No plan works. You have to be very open and flexible, ready for change at any given moment. You work very close to the people, always aware of intimate moments and situations, giving emotional security in doing so. Employees are constantly very, very close to their patients. Architecture has a responsibility to create an environment that helps to make this hard and sophisticated work a little bit easier. Conclusion. Architects often seem to know what people suffering from dementia need. This is not correct. Nobody knows it really, but after many years of working with such people, we have a clear idea of how the world around people with dementia should be planned. They like simple and well-designed rooms. They need an environment where they can realize their own idea of living. Architecture, on the other hand, must create environmental concepts and surroundings where it is possible for residents to live easily and secure. People with dementia are also people without dementia. They have the same desires as all the others, regardless of any diagnosis. To make the world a friendly place, that must be our main goal. Thank you very much.
Thank you, Michael. That's a really beautiful home, Michael. I hope some of us will have a chance to visit it one day. And so I'm really very, very impressed. So I've been told that our technical problem from Oman has been resolved. So we would like to welcome back Dr. Hamid Al-Sinawi to carry on with his presentation. Over to you.
Thank you, sir. Thank you. Thank you, and sorry for the interruption. We will carry on from the current slide. We're talking about caregivers for people with dementia, and all over the world, informal caregivers that are family members, sons or daughters, wives and husbands, take over the role of looking after a person with dementia, unpaid and sometimes sadly unappreciated, to the degree that such job can bring on lots of complication and stress and burnout has been reported to be common among people with dementia. In one study, more than 70% of caregivers experienced health issue. So their their own physical health has deteriorated, and more than 60% experienced mental health problems like depression and anxiety. And also a huge number tend to miss hospital appointment because they're so overwhelmed with the care they provide. Next slide, please. Next slide, please. Hello, can I have the next slide, please? Yes, we move on to talk about Alzheimer's global ADI global surveys that shows the attitude about dementia all over the world, and it's really interesting. This was a study that involved over 70,000 people worldwide from over 155 countries, and if we look at things about common beliefs, attitude toward people of dementia, some shocking figures. 2 out of 3 people think dementia is a normal part of aging. So in that situation, they stop seeking help because they think it's a normal process of aging. And 1 out of 4 people believe that dementia is that nothing can be done about it. So if a person develops it, then he need to be looked after at home. No way they can benefit from any medical interventions. Next slide, please. This attitude is also affecting healthcare providers, and in this particular studies, over 60% believe that dementia is normal. Of doctors and nurses believe that dementia is a normal part of aging, and more than 40% believe that when they seek help from a professional, they get neglected and ignored, and this is a very kind of negative attitude that hinder people from seeking help. Next slide, please. So when we talk about dementia as a cultural component, we talked about culture and how the cultural beliefs affect one perceives the symptoms of dementia, how they make meaning of the experience a person is experiencing during that time, how the knowledge of cultural heritage and social impact and religion can be very useful in understanding the help-seeking behavior that the person will do. Most studies on dementia are made from the Western countries, so very little is known about experiences elsewhere. And dementia is not just a syndrome of signs and symptoms, but it also, there is a meaningful part of it. How do people cope with the different symptoms? How do they see their role after they got the diagnosis? What does it mean to be diagnosed with dementia? So in some community, it's considered to be a taboo. So a person gets shielded out, they are stopped from social contact, which makes it even worse for their cognitive impairment because they get more withdrawn and there is no brain stimulation. Next slide, please. So the West, the cultural norms is that a person is an individual. So when somebody is an adult, they are autonomous, they make their own decisions. It's more like a one-person kind of system, whereas in the other cultures, the role of society is very important. So when a person is diagnosed with any condition, the whole family get to contribute. Everybody have a say in what kind of person, kind of management they perceive, how would they access care. So it's interesting that we get to know how do people from different culture perceive dementia. We will, next slide, please. We'll just go quickly about different cultural experiences worldwide. Next slide, please. We start from Japan. So in Japan, for example, the elder is made. They have this is one. It's one of the countries that have a huge number of elderly. So dementia is believed to be caused by inactivity or insufficient involvement in social setting. So it's interesting that the society there identified some potential preventative measures that possibly leads to developing dementia. So people who are not being active, they are not using their brain, they get to be believed to be more at risk. So the person with dementia is sometimes believed to be failed to make sufficient effort through activities like hobbies or keeping an interest in activities. So in a sense, they are to blame. So this is common in the Japanese country. So the person who's unable to reciprocate favors to other people, and as a result, the person is physically alive. This is in Japanese country, but they're considered to be socially dead. Next slide, please. Whereas in China, the belief is more around repudiation of the sin. So a person is believed to have developed dementia because of several sins he did in the past, or because they've been possessed by supernatural powers. This means that when a family seek advice for a person with dementia, they would often consult the herbalist or a traditional Chinese medicine doctor instead of going to a hospital or a healthcare center. So this is important when we understand what are the people understanding of the concept of dementia. There's also in the culture, Chinese culture, especially when it comes to Confucianism, there is a belief of hierarchy organized. So first party, father, husband, and brother, elder brother, are assumed to be superior and have more say in how business is run, how a decision made in the family. So when they are affected with dementia, they still retain some of their position. The next slide, please. This particular belief means that a person is not so much stigmatized. They are taken from the blame. There is a different expectation. So the family get to assist the person and they provide care for them. There is this concept of normalizing dementia as part of aging instead of a medical illness. Let's move to the next slide, please. Next slide. So whereas in indigenous Australia, the belief among some of the Aboriginal tribe is that after life there is a out of balance. The person with dementia is having an out of balance in their life. They've lost connection with their ancestors, and because of that, there's a sick spirit that contributed to the development of the illness. So cognitive decline is seen as tiredness of childlike behavior. So this is, in a sense, the person when they develop the symptoms that are treated in that manner. We'll then come to the Arab world. The Arab world is approximately 280 million people they have the common cultural beliefs, common majority Islamic beliefs and culture, and the family, the elderly are considered as a very precious part of the community. They are the source of blessing and a source of wisdom. So most elderly stay within the family. They are looked after by the loved one, by the family members, son and daughter, and extended family members. The term currently used for dementia in Arabic is called kharaf, which is kind of stigmatizing because it means that the person who has lost his mind. So the part of our health education program is to introduce the new kind of modified, probably not as fashionable name, which is called Dharabat Idrakiya, which translates to cognitive impairment. So in a sense, stigma is still an issue about when it comes to dementia in the Arab world. Most of people think it's a normal part of aging. They don't seek help. They only come to hospitals and health center when there is predominantly behavioral problems that sometimes becomes difficult to manage. The issue of having nursing care is still frowned upon in most Arab countries. It's considered to be a shame for someone to place their loved one at a nursing home, regardless if they are having any unmanageable behavioral problems. So lots of work needs to be done in highlighting the issue, providing health education, and improving expectations. So we'll move to the conclusion, please. Next 3-4 slides ahead. Next slide. conclusions. So we talked about dementia experience in different countries. We talked about the cultural differences among the Chinese, Japanese, some of the most prominent cultures. We talked about the role of stigma and how it affects the way of help-seeking behavior. And also we highlighted how important the understanding of cultural phenomena in developing a more culture-based health education program. Thank you very much.
Thank you, Dr. Hamid Al-Sinawi. I'm glad we got you back. I hope we will not lose you again due to technical problems. So let me welcome our last speaker for this plenary, and that's Dr. Violet Okish Hilu, all the way from Kenya. And Dr. Violet is going to speak to us today about getting a dementia diagnosis in Africa. Violet is a consultant psychiatrist, counselor with more than 15 years of experience in the field of mental health. She chairs adult psychiatry and coordinates mental health research at the Department of Mental Health, KNH, Nairobi, Kenya. She's an honorary lecturer in the Department of Psychiatry, University of Nairobi. She plays a key role in mental health services development in Kenya and East Africa, and is the founding president of the Eastern Africa Young Psychiatrists and Trainees Association, and was the first female to be the national vice chairperson of the Kenya Psychiatric Association. Dr. Okish is an expert in gender, HIV care, and public mental health and policy. She's also the Kenya Psychiatric Association ambassador to ADI. Dr. Okish is passionate about women's mental health, mood disorders, dementia care, and promoting quality and dignified care for the elderly. Over to you, Dr. Violet Okish.
Thank you very much for your kind introduction and welcome. It's indeed an honor to be a part of ADI 2020. Let's go on to the first slide, please. So today I stand here, or I'm so used to these face-to-face conferences, but I'm presenting today on several fronts, both as a mental health advocate, as a caregiver for my mom who went to be with Jesus 2 years ago, and as a daughter of somebody who's a dementia warrior who herself cared for my grandmother. So I'm going to take you through a few of our caregiving stories as I've talked to different members of ADOC and even other people that I have treated as a medical doctor. So my introduction to dementia came when I first met my grandmom. This was a mother to my father, a beautiful, focused, hardworking, and resourceful woman who had who had worked very hard when she was younger to buy paraffin from many kilometers, and through the proceeds of bringing that paraffin back home to her community and selling it, sent my father to school, and in that way enabling me eventually as my father's daughter to go to school and become a medical doctor. By the time I met her, Grandma Nora was around 80, and she had forgotten everyone, all her children. The only person she could remember was her daughter-in-law, who is my mom, Trufena. Indeed, in Africa, many times the diagnosis of dementia is a family and community diagnosis, and the people closest to the person with the dementia, who's developing dementia, are the people who notice changes in habit and personality. And I've heard statements from my friends and also from patients such as this. Oh, mom is no longer as tidy as she used to be. We noticed the other week that the last 2, 3, 4 months, mom is forgetting that she has eaten lunch. Indeed, when my sister calls, she says that we are starving her. And indeed, others have wondered whether the change, for example, in demanding for meals and other things, and the increased irritability is underlying conditions such as diabetes mellitus, or is it the dementia which is setting in? For ourselves as a family, we noticed that our mom, who was, I would call a warrior mom. This is the person, the strong person who would, take charge of situations, guide us through situations, suddenly, increasingly became anxious in new situations and started being afraid to sleep alone in her room. And at times, and eventually began even afraid to fear the dark. We also noticed that some topics which had been taboo earlier suddenly could be discussed, such as, oh, what did you used to do when you're a girl? And how did you get to choose which man to get married to? In her generation of people born between in the 1920s and 30s, those were taboo topics to be discussed with children. That's just a part of our caregiving stories. Next slide, please. Next slide, please. The other things that, the previous slide, please. Earlier signs. When you look at the caregiving stories, not only of our family, but other families, we have had that some of the early signs were loss of interest in things that people used to enjoy before. Dad is not interested in reading the newspaper, or watching the news, or reading books. And also mood changes in terms of, Dad was a very reserved man. Many African men are not quite very forthcoming when it comes to talking to their children, especially those aged, the generation that was aged 80, that would be 80 to 100 at this particular time. And suddenly your dad or your uncle has become more expansive, and you can sit with them and they keep on telling you these stories that keep on being repeated again and again. I remember a patient who had been a high-ranking officer in a T zone, wandering away from home and being brought back by the neighbors, which is something wonderful about living in a close community, because everyone knows everyone else and people can tell when actually something is wrong, and having to be persuaded to eat and sleep. As one of the things that we have noticed as I said from our end, it had been more of a family diagnosis first, where people notice changes in the way somebody thinks, behaves, and the way they take care of themselves and interact with their surroundings. And things like repeating clothes, wearing, somebody who used to be very particular about their appearance, repeating the same clothes because they have forgotten that they wore that dress yesterday, or they wore the shirt and the trousers yesterday, having to be persuaded to eat and sleep, developing food preferences, and then certain things that really do affect one's dignity, such as suddenly finding that one is incontinent, which is many times associated with comorbidity with other medical disorders, and the need for diplomacy and patience as we attend to our loved ones who are living with dementia. Indeed, I know one of the challenges that many times has affected people living with dementia and their caregivers is when dad or mom gets so offended that you would even think of putting them in diapers. They are not a child, but you're also trying to help them to be comfortable and to remain dry. Indeed, I noticed something very interesting that when I was talking, the presentation from Dr. Ahmed from Oman is that in our setting too, majority of caregivers are often women. The caregiving burden often falls on women, often unpaid, and many times you would find that sisters, daughters, or aunties have to put their life on hold to take care of the person living with dementia. Let's go on to the next slide. The other signs and symptoms that we have seen in terms of diagnosis coming from the family front is when they come to hospital, usually the first trip to the doctor would be precipitated only when the person living with dementia does something distressing, such as wandering off and gets lost, or not being able to sleep, or becoming excessively irritable, or becoming aggressive. Some of the issues that that the families would bring to our attention would be that people have forgotten how to take their medicines, have forgotten whether or not they've taken their medicine, refusing to eat certain foods, and increased sensitivity to noise. A common statement that we find in my practice is that people say that, oh, my mom gets so irritated when the children are playing around us. You play with them for a short while, but after a while, she just wants them to go away. That is a pointer that something is going on in their brain. Or changes in sleeping habits, sleeping a lot even during the day. And in our situation, we would find, for example, in hindsight, I noticed that, for example, there were certain changes that went on in our mom's life in terms of just even her spirituality. She's a person who really loved God and respected God. And when she would wake up in the morning, she would make sure that she sits up to pray. As time went on and she was both being affected by hypertension and diabetes, she no longer sat up to pray, would lie down, would wake up and pray sleeping. In a lying down position, which is not quite like her. And in hindsight, I noticed that those are things that were different in our situation and in her personality. The other things that people in our setting we talk about is people forgetting their children, the birth order of their children, forgetting the birthdays, if it's a family that has been celebrating birthdays. And as caregivers, many of us have experienced feelings of loss and grief as you look at the person who used to be so strong before, and yet you're wondering, oh, is this the same mother or the same father who used to be directing everything that we do and who was our leader? Indeed, it is a time of changing roles. Let's continue on to the next slide. Indeed, as dementia progresses, even in our setting, we noticed that we are aware that as dementia progresses from moderate to severe, they're decreasing independence and increasing dependence on both walking aids and mobility, the need perhaps to even restructure one's home so that a person who is living with dementia is comfortable and is not subject to falling, and encouragement and having to, even at times, have to redesign the home or even bring in walking aids such as wheelchairs. I remember also that we had different opinions, and I've had this also from other families, on whether mom needs a wheelchair or not in order to move around. But the idea was to try and keep her as independent until the very last stages of her life. Now, one of the things that you find that would be important for people in transport and mobility industries would be to understand that people with dementia might not even remember how to climb stairs. Indeed, when I talk about the airline saga, I remember there's a time that we were flying home to our rural home, and when we started, which was just like 5-6 steps to enter the airplane, at some point my mom, I think, got both tired and confused, and she sat down on the stairs, and people were waiting to board the plane. Indeed, I was so thankful to a lady who was on the plane quickly mobilized some men to help us take mom into the plane. And just the issue of having a chairlift or having people to be able to, having the facility to be able to put somebody into an aeroplane or into a transport vehicle with dignity is very, very important for somebody living with dementia. One of the things that we're thankful for as people caring with dementia is the preservation of our mom's personality and also the ability to take care of her in a familiar environment among her loved ones. I know that indeed some of the other presenters have talked about how community is very important. Indeed, as human beings, we are wired for community. And I know one of the last wishes of our loved one was to wish to go back to her rural home and to just spend time with her sister and with the people that she was used to and the people in the village. And it is very, very important for us to continue to keep community and to hold the hands of our loved ones even as we take care of them in this progression. Let's continue, please. What are some of the challenges in caregiving that different people have experienced in our settings? And especially because Kenya is classified as a low to middle income country, the high cost of medicine, of medical aids, such as walking frames, diapers, the need perhaps to even to remodel one's home, the need to cooperate as families in scheduling doctor appointments. And is the hospital really user-friendly for somebody living with dementia and their caregiver when they come for hospital? The need for cooperation and understanding between siblings, which brings us to the need for family therapy and getting suitably qualified elder care assistants that would gel well with your loved one. Indeed, ADOC has done. I would like to give a special thank you and mention to Elizabeth Mutunga and Alzheimer's Dementia Society Organization of Kenya ADOC members for training family and caregivers on how to handle people living with dementia and how to navigate the various obstacles that we go through in giving care for our loved ones with dementia. Indeed, the other thing is that, which is a challenge, is on the financial front, is non-insurance insurance policies for people who are age 70 and over. But I believe that even as we continue in this journey, that is going to be managed and is going to be overcome. Even as government work together, there is increased awareness of that about in the next couple of years, up to 60% of people living with dementia are going to be living in low to middle income countries. And therefore, those of us who are taking care of loved ones or have taken care of loved ones are joining our voices together with others. Like, let's go on to the next slide, please. We're together with organizations such as Stride Africa Mental Health Foundation to be able to make a difference in the lives of these people and to bring the government on board to provide both policy and funding that will be able to take care of needs of people living with dementia with dignity. Now, dementia care is not just a labor of love, but there are also joys in caregiving as we take care of our loved ones with dignity. The chance to spend quality time with our loved ones, greater bonding time between family members as we realize that the person with the dementia might not be with you for a very long time, especially if it is advanced and they have comorbidity. And the opportunity in spending time with them, coming from an oral culture, to be told about our legacy and where we came from, and wise counsel on personal and social issues. And also the opportunity to give back for all the years of toil and labor as we help our loved one to age with dignity. Last but not least, indeed, for dementia caregiving, I noticed that as we went through as we even went for the support groups set up by ADOC, this week or the other, you'd find that somebody has had to send off their loved one because suddenly they have left us. And indeed, processing loss and grief has been a common part of the dementia journey. The other thing is that one of the things as we continue to take care of our loved ones is that we are able to see them and be able to model loving care to them and hopefully pass on that role modeling of a godly legacy to be emulated by our children behind us. Let's go on to the next slide. Next slides, please. I've mentioned about how ADOC, the advocacy and hope brought by ADOC, has been a silver lining in our journey of caregiving. ADOC has many activities in Kenya, including Walk the Mind, which has brought dementia awareness to everybody in the society, where you come in and you walk and you participate in a walk, you are there's cognitive testing, among many others. In fact, if you look at their website and the things that they do in support group and the caregiver tips and all the advocacy they have done in working with people with dementia, indeed, it is a beacon of hope in a situation which sometimes can be very, very dark. For us as a family, Elizabeth Mutunga coming into our lives and meeting with other people, other caregivers in ADOC, was a bright light in which we actually met with people who under other caregivers were able to understand puzzling behaviors, people who were able to listen, empathize, advocate together and fight stigma. Bravo indeed. Let's continue. Next slide, please. Before I go on, let's go to the previous slide about the advantages of aging in Africa. I come from a culture, not that one, the next one, please. I come from a culture where old people are valued and cherished. The elders are held in high esteem and are seen as custodians of our heritage. Indeed, our culture and heritage have been passed on through oral stories, and I look forward to myself and other people who have been caregivers putting down on paper the stories of our loved ones, who they have been, how we have taken care of them, and what we have learned. Indeed, it is an opportunity in this day and age to document our culture and heritage as we continue to build on the memories and work with the working memories and draw on our own memories of our loved ones to be able to talk about how we can age with dignity. We live in a pleasant land that is beautiful with warm weather, and therefore asking your loved one to go out for a walk or taking her for a walk is something to be looked forward to. Another groundbreaking thing that has happened in the recent past in Kenya is that we had there have been good spiritual support from the church and other spiritual organizations. And I want to especially point out to the Catholic Church for pioneering integrated healthcare for elders, and also Nairobi Baptist Church for setting up a program called Shoulder Trust, where they actually visit people who are taking care of their loved ones at home, and they interact with them and they actually give fellowship. Social care and daycare for daycare situations for seniors is a very super concept that we also need to incorporate and avail in our setting. Let's go to the next slide as I'm coming to the end of my presentation. Continue, please. What are some of the areas of growth that we need to look at? No, not that, please. Let's go back to the areas of growth. Some of the areas of growth that we need to pass on to is that even as we let's go back. Sorry, one more slide to the. You've talked about the advantages of aging in Africa, and let's look at the slide that talks about the partnership between ADOC and Stride. I just want to congratulate the people from the UK, ADI and Stride, in partnering with ADOC Kenya and working with our Director of Mental Health to be able to actually come up with a national dementia plan, and that is a first for our country of Kenya. This is a previous slide that I'm talking about. And indeed, you cannot handle something unless you know what it is that you're dealing with. It's important for us to know the numbers of people who have dementia, what kind of care they have, what kind of support they are getting, and what gaps that we need to fill. Indeed, as we look at the areas of growth, let us look at the slide about areas of growth. The next slide, please. It is indeed our privilege and our joy in this particular season of our lives that we are able to promote healthy aging across the lifespan as we collaborate with different families, as we collaborate with different members and organizations. Indeed, some of our dreams is that as we roll out the National Dementia Healthcare Plan, is that there'll be advocacy, there'll be policies on how to train families, how to train caregivers, elder care assistants, and healthcare workers on appropriate care and support for people living with dementia and their families. Indeed, in the hospital where I work, one of our dreams for the coming year is to continue to train even the young doctors and nurses on how best to attend to people who are living with dementia and talk to them and manage them in ways and partner with them in their care in ways that improves their end-of-life care. Something that is a bit of a foreign concept to us as Africans is the issue of actually talking with somebody about what happens when you will leave us. Many people would see it as if it is you're asking for them to die, but yet that is not really where you're coming from. You're basically saying that we are all of us on a journey and we need to plan our estates. That is so much more important in people who are living with dementia and for their families, especially in the earlier stages where somebody is still able to make decisions about their lives. We are thankful, Lord, that we are thankful too that even in this area of COVID-19, despite the many social restrictions, the mask wearing, social distancing, and diminished access to care for comorbidities, I believe that the dementia community in my country and in other countries are continuing to work together and to talk to governments that indeed we do not want to forget these are our loved ones who are living with dementia, and we need to continue to advocate for them and see that they continue to access the services and the care and the emotional support that they need. I'm so excited to see the presentation from our brother where he was talking about dementia-friendly building and green spaces. I'm hoping that we will continue, we'd also borrow a leaf from you and incorporate that in our own setting. And also that the government would actually roll out financial support for caregivers and respite care and tax rebates for those families who are taking care of their loved ones. Let's continue on to the next slide. Indeed, in Kiswahili, they say that we are coining as a phrase that say, wazee dhahabu yetu, that our seniors are our gold. Gold is something that is revered and that is considered very valuable the world over. And in our culture, I'm praying that we will continue to pass on this legacy to our children and our grandchildren, that even as we ourselves age and as we take care of our older parents, our aunties, our uncles, our spouses, our children, because not everybody who has dementia is old, that indeed we shall continue to treat them as gold. I'd like to go on to the next slide, which I believe is my last one. We honor and cherish the memories of our loved dementia warriors. This is a picture of my mom. It was a privilege for us to take care of her for 15 years. 2 years ago, she left us. Suddenly, she suffered a stroke and she died. But she managed to speak in September 2017 at the first ADI conference that was held in Kenya. Indeed, Mama Trufena Okech, we celebrate you. We celebrate all the people living with dementia and their caregivers as we work together towards a dementia-friendly world. Oh, ADI, you have made such a big difference in our lives, and it's such an honor to be part of this conference. Indeed, because someone we love is in heaven, we have a piece of heaven in our home. And this is actually the sentiment of a number of our dementia warriors and our soldiers who have lost their loved ones. But we have a hope that even when we die, and we believe in the Lord, that even though we die, we will one day live. But above all, we are privileged and honored to be part of dementia soldiers the world over. Indeed, let us continue working together to make this world a better place and dementia friendly by thought, word, and action. Thank you.
Thank you, Violet. So we have only a couple of less than 10 minutes for questions and answers. I've just looked at it, there were a lot of questions coming through, but I know John Morris has woke up very early this morning to join us. John, I don't know whether you've seen some questions coming up to you. Is there anyone in particular that you would like to answer, or do you want me to pick one for you?
Please pick one because I do not see the questions.
Okay. John, there's a question that if 202 is a turning point in diagnosis and treatment, when can we expect this to be translated into practice?
So 2020, improved diagnosis and potentially improved treatment. I think that this audience may know that in the United States and in Europe, the drug sponsored by Biogen, aducanumab, is being considered for approval for mechanism-based therapy of Alzheimer's disease. I think that in the European Medical Association, it has been given a conditional approval, and the Food and Drug Administration in the United States is considering this as well. Whether the drug actually is approved for treatment or not, it's the first, I think, of several drugs coming along that may provide effective therapy for the pathology of Alzheimer's disease and give clinical benefit for patients. And as I tried to indicate in my presentation, I think the advent of blood-based testing for Alzheimer's disease will improve the detection of that as well and indicate who may be most likely to benefit from these new therapies that hopefully will demonstrate benefit. So I think 2020 will look back on as a signal year in the fight against Alzheimer's disease.
Thank you, John. Thank you very much. Dr. Hamid Al-Zeinawi, there's a question from you that says, how have foreign workers affected and altered the culture of dementia care in Oman? I thought that
Well,
was
yeah, it's a very interesting question. I didn't have time to mention that in most families in our setup tend to employ a paid live-in caregiver. So somebody with a basic experiences and skills that they will look after, they will do the caring part, the feeding, the bathing. And some of them come from obviously non-Omani or non-Arabic speaking community. So sometimes it's a challenge to get them to understand and communicate properly with the family, with the person with dementia. So with time, most families tend to train the paid caregiver, and they will they will help in looking after and providing the daily care to care. And gradually, it also helped in reducing the stress and burnout experienced by the immediate family. However, we have to be very careful, because in some situations, those employed caregivers tend to be under stress themselves, because they could be away from their family for 2 years in average, and sometimes they are having their own kids, they have their own family problems that they have left with someone else's. So because of their job, they had to be, someone else does their job to look after their kids while they support the person with dementia elsewhere. So we always tell the family that we have to keep an eye on the caregiver, give them enough break. They could be a potential care, when it comes to issue of abuse and neglect, because it's easy to blame put the blame on the caregiver when the family have not done their part. So in short, they are in a sense quite helpful for people to, families to have a paid caregiver that stays in, but you need to educate them. You need to be careful about potential abuse. You need to be fair to them as well, because at the end of the day, this is a job they are doing. It's a practical solution, but it has other challenges.
Thank you, Dr. Hamid. Thank you very much. Michael, as what I mentioned, everyone's very impressed with your home. There's a waiting list, I'm sure, to come in. The questions I've got for you is, how much does it cost to stay at Sonwat? Is it just for people with early stage dementia? And is there a long waiting list to get into your home?
No, today actually it's not a long waiting list, because we have a lot of problems with COVID-19. We are a hotspot, because you cannot separate the people. That's very difficult at the moment. But normally we have a long waiting list. The Sonwat is not for rich people, it's for normal people, because community pays if you have not enough money. But we have our goal was a very good architecture environment, and I think so it looks friendly and it looks expensive, but it's not more expensive as other care units here in Switzerland.
Okay, all right, thank you. Dr. Violet, I've been looking, I think because yours was the last presentation, there's I think hardly any questions yet. But Dr. Hamid, Dr. Hamid, there was another question for you, yes, which is, how do you respect family traditions and culture when providing dementia care?
I think it's very important to understand the family's culture and attitude, because as explained in the Arab world, for example, the person is highly respected, they are considered the head of the family, and sometimes it's difficult to strike a balance when being respectful and providing duty of care. For example, sometimes if the person is unable to manage their own finances. They can go around giving money to distant family members or anybody who stops them outside. So in a sense, the children who are worried about capacity assessment, they will think this person is doing good deed by giving money to the poor. But where do you draw a line when he's spending his money that he would need for his own healthcare, for example? So it's about, we spend lots of time explaining to the family that actually you are not being unkind to the father or mother, you're just looking after their interest. The same thing when it comes to capacity assessment, people find I don't want to be labeled as being a horrible person who would stop my father from accessing his money. I don't want to be the person that do this and, stopping my father from wandering outside. Even when we discussed an issue of providing a GPS operated tracking system, some family felt it's like imprisoning the elderly person. They believed he has or she has the right to walk around. So it's about explaining to the family caregivers. They do mean well, but you have to draw the line between the person's right and doing what's best for them and being caring and respectful at the same time.
Okay. Thank you, Dr. Amir. Unfortunately, we have run out of time. There's so many questions that I would have liked to ask all of you, but I've been told it's time's up. And so thank you very much to all four of you for your time and your excellent sharing.
Thank you.
Thank you
all
very
of
much.
it.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.
Bye.
In the near future, a new generation will be leading and making an impact in our societies. The HEAD Foundation believes that providing quality education and development opportunities to this new generation of young people will empower Asia's development. The HEAD Foundation is a Singapore-based think tank. It focuses on issues around education, human capital, leadership, and sustainability. It was set up as a charitable organization in 2013 to contribute to the development of Asia. The Foundation provides a collaborative and inclusive platform for a multidisciplinary approach to scholarship, policy reform, and delivery of social impact. It investigates issues through the researches and projects it supports, works with experts and academics to propose solutions by organizing workshops and forums, and shares the resulting new knowledge through training, public lectures, and its publications. The HEAD Foundation helps to create awareness, generate ideas, facilitate dialogues, and support actions. By bringing determined people, creative ideas, and resourceful institutions together onto a dynamic platform, the HEAD Foundation is set on empowering Asia's development.
Well, hello and welcome. My name is Dale Goldhawk. I'm the Vice Chair of ADI, speaking to you from Canada. We're going to lead off this program and product showcase with a session that's curated by Danone. Professor Mia Kiva-Pelto and Dr. Kaiser Mamoun will discuss management of young onset Alzheimer's disease and mild cognitive impairment.
Hello, my name is Mia Kivi-Pelto. I'm professor in clinical geriatrics at Karolinska Institute, Stockholm, Sweden, and the director for research and development, Theme Aging, Karolinska University Hospital. I work also part-time at the University of Eastern Finland and Imperial College London. And it's my great pleasure to welcome you to this short session, combining a Singapore perspective on managing mild cognitive impairment together with exciting new results from a clinical trial, the Lipid Diet study after 3 years in people with prodromal AD or mild cognitive impairment, MCI, as it's often referred to. These just published clinical trial results show broad beneficial effects of a nutrition-based intervention in MCI due to Alzheimer's disease. As one of the investigators and authors, I'm really pleased with the results, and it has been really a huge study and huge effort lasting 12 years to complete with these extensions. Later on, you can watch a short video available from journal Alzheimer's and Dementia explaining these results. But first, we are joined by Dr. Kaiser from Singapore to give a local Singapore perspective on patient management in the earlier stages of Alzheimer's disease and his own clinical experience with this once-a-day multi-nutrient drink. Dr. Kaiser works as a senior consultant in geriatrics, Singapore General Hospital. Dr. Kaiser, the screen is yours.
Good evening, ladies and gentlemen. Today I'm going to talk about management of early Alzheimer's disease and MCI, and will share with you a local experience that I have. My name is Kaiser Mamoun. I am from Department of Geriatric Medicine at Singapore General Hospital. Singapore is a small country with a population of about 5 million plus, but that population is rapidly aging, and the number of dementia patients that we have right now is about 32,000 cases in Singapore, and in 10 years' time, in 2030, the number will go up to 48,000. And there will be a very big social burden to care for these dementia patients. Now I'll talk about pre-dementia, early dementia, MCI, and all these things. As I mentioned earlier, that the population in Singapore is aging very rapidly. So say about 20 years ago, in my memory clinic, dementia care clinics in geriatric medicine, we used to see patients who already have mild to moderate dementia, even advanced dementia, and with a lot of behavioral problems. And when the behavior problems started, that's when family members would bring the patient to our clinic for management of the behavior issues. But there are a lot of changes happened in the last 20 years. There are a lot of NGOs, VWOs, and Ministry of Health had worked on awareness about dementia in Singapore. So people are more aware about this problem, and that awareness about dementia has gone up significantly. And that brings new set of issues for us, which is a lot of self-referrals and walk-ins we tend to see lately. These are highly educated elderly who are mostly retired, but they're still socially active. And with the first hint of memory issues, they take action. I mean, they come and see a specialist. for consultation. I will discuss few cases now with my own observations that I have seen in last year or so. Nothing very scientific, just my observations only. So the first case, it's a 78-year-old Mr. T, a retired school teacher. He made a self-referral to my clinic for memory problems. When I asked him how he is doing, he told me that his basic activities of daily living and instrumental activities of daily living all are independent. He still drives. He had no road accidents in last few years, and he never got lost. He can manage well by himself. He has background of diabetes and hypertension, which are well controlled with medications. And he is socially active. He meets his friends once a week. But his chief complaint was forgetfulness. And it was mainly names of those people who he don't see very frequently, see them after a long gap, or have seen long time ago. And he expressed some frustration on several occasions during the history taking that I'm getting old and age is catching up. He claims that his mood was okay, no sleep issues, appetite was good as well, and he had no impairment in other cognitive domains. He occasionally misplaced things, mainly car keys, but not important things like his checkbook or wallet or his passport, identity cards, and things like that. I talked to his wife, got a corroborative history from her, and according to the wife, the patient is a perfectionist all through his life, extremely well disciplined, but lately he felt a bit embarrassed when he met people after a gap of many years and could not recall their names. But there was no other issues, no changes in the personality or anything. His abbreviated mental test score was 10 out of 10, and his MMSE was 29 out of 30. I can't remember the point he missed because I myself is getting a bit of memory problem lately, I guess. So the diagnosis, you don't have to be Sherlock Holmes to say that he doesn't have dementia. So I gave him a lot of reassurance that he's doing fine for his age. And then he asked me if there is anything he can take to improve his memory. He was not keen on medications, but he was open to supplements. So I offered him Sovenit, and he gladly agreed to try. And I told him to see me back in about 8-9 months' time. So 8 months later, he came back and he told me that his memory has significantly improved. His AMT was still 10 out of 10 and MMSE was not changed, but his misplacement of keys are much better. He still struggles with the names once in a while, but he claims that it is much better than before. So that is with our retired teacher. And let's go to the second case. This is an 82-year-old Mr. M, a retired accountant. He came with his wife with the memory complaints of 2 years. He tells me that it's mainly short-term memory loss. He forgets things, mainly the day-to-day things, but his other domains are quite intact. His function is very good. Basic activities of daily living and instrumental activities all are independent. He is also driving despite his age. His mood is stable, and his AMT was 9 out of 10. He missed 1 out of 3 in the recall, okay? And his AMT was 24 out of 30. Blood tests were done for the reversible factors. Everything was normal except just borderline B12, okay? And CT brain showed mild involutional changes of the cerebrum, but the rest of the things were quite unremarkable. I referred this gentleman to neuropsychological assessment, and the diagnosis was amnestic MCI. And I offered him a standard therapy. I usually give a small dose of cholinesterase inhibitors in amnestic MCI cases, but he was telling me that I already take many medications for other reasons. I am not very keen to take another medication for these minor memory issues. So since he declined medications, I offered him nutrition supplements, and he was keen for that. So I offered him some Sovinets. So he took the Sovinet, and he came back to see my clinic in about 8 months' time. And he told me that there was subjective improvement of his short-term memory loss with the taking of Sovinet. And his AMT was 10 out of 10 at this time. Last time he missed 1 point in his 3-item recall, which has improved. And his MMSE was 24 before, now it was 26. And he was still driving and doing fine. So I tried Sovinit about 30 to 40 patients in the last 2 years. I'm just giving 2 examples here of those patients. And in summary, my Sovinit experience, well, it's not a drug, rather a supplement. And it came to Singapore about 2 years ago. And whenever I give it to the patients, I need some explaining to them that it is not a drug, it's more of a supplement, and what it contains, and all these things. And most importantly, I tell them about the test, that there is a fish oil after test when you drink it. So, and once they know what it contains and everything, they become quite interested to take Sovinit. The cost in Singapore is, well, I was told that it is similar cost to a Starbucks coffee. But people who needs it usually don't buy Starbucks. They prefer the local coffee, which is shown here. But it's about $4 to $5 per bottle. It's 1 bottle every day. But the company is Nutrica was quite helpful for my needy patients by providing them with free samples. So, final verdict on Sovinit. It offers alternative to those who declines medication, and it works well in my experience for MCI, especially amnestic variety and early Alzheimer's disease cases. It improves symptomatic memory complaints quite reasonably well, and I didn't see any side effects in my patients so far. The only thing they always complain is the fish oil after test. When they drink it, it is more prominent in the vanilla flavor. That's why cappuccino flavor is more popular in Singapore. That's all I have for today. Thank you for listening. Thank you. Bye.
Thank you so much, Dr. Keisar, for this very nice lecture. I would now like to introduce the last part of this session, which is a video animation summarizing the recently published results of the Lipid Diet trial. Lipid Diet is really the longest randomized clinical trial in prodromal AD with a positive outcome conducted so far. And I really think it's a positive finding, especially given how difficult it has been to find effective treatment for Alzheimer's disease. And it was also encouraging to see the broad and long-lasting effects on cognition, functional level, and brain atrophy, all these 3 outcomes after 3 years. So please enjoy this short 3 minutes video, which can be found on the Alzheimer's and Dementia website together with the full publication. Stay safe and healthy, and hope to see you soon.
Previously, a commercially available specific multi-nutrient formulation called Fortisyn Connect has shown promising results with respect to memory in preclinical and clinical studies involving patients with mild Alzheimer's dementia. To examine the effects of Fortisyn Connect further, a European consortium of 46 academic scientists conducted the Lipid-D diet clinical trial. In this trial, 311 patients with prodromal Alzheimer's, also referred to as mild cognitive impairment due to Alzheimer's, were either consistently given 125 milliliters of the multi-nutrient drink or an isocaloric, same-tasting placebo drink once a day. At 2 years, significant differences between groups were already observed on a number of parameters. The experts hypothesized that the benefits would increase with longer-term intervention. At 3 years, a neuropsychological test battery measured a 60% reduction in cognitive decline and 76% reduction in memory decline in the multi-nutrient group compared to the control. The clinical worsening of disease overall, measured on the clinical dementia rating, was also reduced by 45%. Exploratory analysis of the spectrum of these results showed that those with greater cognitive performance at baseline benefited more. In other words, the earlier in the course of the disease that the intervention is begun, the better. MRI scans to measure the shrinking of the brain, a hallmark of Alzheimer's, showed that the rates of deterioration of the hippocampal, ventricular, and whole brain were 33%, 22%, and 20% less, respectively, in the multi-nutrient group than in the control group. The incidence of adverse events and serious adverse events over the entire 3-year period were similar between groups. Overall, the Lipid-D diet trial results highlight that the daily multi-nutrient intervention is safe, provides sustainable benefits, and over the long term, benefit increases, especially for those in the early stages of the disease.
Okay, Dr. Kivipelto and Dr. Mamoon, thank you very much for that presentation. Let's move on to our next presentation. Prompt and total action by the New Zealand government meant that the 5 million people who live there suffered only 2,000 cases and 25 deaths due to COVID-19. Catherine Hall, the chief executive for Alzheimer's New Zealand, still needed to make major alterations to her organization to protect the people she serves all the time. She joined us a little earlier, and here is her presentation.
All right, thank you, Dale, and thank you for this opportunity to showcase a little bit about what Alzheimer's New Zealand does. So just bear with me for a moment while I share my screen so you can see my slides. Wonderful. All right, we're there. So, look, I am going to talk about Alzheimer's New Zealand and what we do. And as I'm sure you will all know, it's very hard to do that at the moment without talking about COVID. So I'll be weaving that in a little bit to the story today. First, though, I thought I would start by just reminding you who we are. So we're New Zealand. We're that tiny spot in the middle of the Pacific Ocean there. Our nearest neighbour is about a 3.5-hour flight, and that is, of course, Australia. There are about 5 million of us, and in just a few years, a quarter of us will be over 65. And we're famous for a few things. You might know that we're famous for our beautiful landscapes. We play a pretty good game of rugby, at least we used to. This year's been a little bit harder to say that with. We are, of course, famous for The Hobbit, and we've become well known this year for our response to COVID, and over the past 3 years for the leadership shown by our Prime Minister Jacinda Ardern. So that's just a little snapshot of who New Zealand is. Who is Alzheimer's New Zealand? Well, we're an organisation that is about 35 years old. And our focus at the moment is on building a dementia-friendly New Zealand. That's our 10-year strategy. We're about halfway through that strategy at the moment. And we are doing that by focusing on strengthening the voice of people who are living with dementia, supporting them to live well, lifting the quality of care and support, and building resilience and readiness in the community. And at the core of our work is the people that we exist for. So people who are living with dementia, and they have shaped and driven the work that we do. And last year we asked them what they wanted and what they needed, and they told us. So I'm going to show you a very short video, which is our advisory group talking about the Dementia Declaration that they developed.
We all want to be seen, valued, appreciated, and loved for who we are. As New Zealanders living with dementia, we are citizens whose lives matter. We have the same rights, privileges, and obligations as everyone else. Our declaration sets out what we need to live well. We live our best possible lives. We have control over our lives. We have support to make decisions that are important to us. We have consistent quality, support, care and information, which is timely and appropriate to us. It is provided with kindness by compassionate people who have the right skills and knowledge, our interests as a focus, and with whom we are comfortable. A circle of support protects our well-being, allowing us to maintain strong mutual relationships with our families, partner, friends, colleagues, and those who are important to us. We live in knowledgeable communities that include, accept, and understand us. We continue to be actively engaged in roles and activities which are meaningful and important to us. We have the things we need to live well, such as housing, privacy, an adequate standard of living, and ways of getting where we need to go. We are loved. Our presence matters. I am still living. Please support and share our declaration to help improve life for us.
So that's Dementia Declaration is a really powerful agent for change for us, and something that underpins everything that we do. Of course, we do a wide range of things as the National Alzheimer's Organisation. We run conferences. We run awareness type activities, and on the top right there is a brain health campaign that we ran earlier this year in March, which is Brain Awareness Month in New Zealand. And we run some dementia-friendly programs, Dementia Friends and the Dementia Friendly Recognition Program. And we're just edging up to having 10,000 Dementia Friends, which after 2 years launching the program is really exciting for us here in New Zealand. So just looking a little bit at what happened here with COVID, and our story is a really positive one. You know, we haven't had a lot of cases here in New Zealand, and nor have we had a lot of deaths. A portion of those, around about 16, are in people in the older age group who were resident in residential care, but the numbers remain very small. All, of course, are tragic. So we had our first case in late February. By late March, our border was closed, and a few days after that, we went into what we call Alert Level 4, which is a full lockdown. So we all stayed at home unless we were an essential service, and there was a very tight control over what were essential services. We stayed in at that kind of level of lockdown for about a month. We then stepped down a little bit, but was still very tight controls for another few weeks. But since then, with one exception of some community transmission in kind of August, early September, we've been at what we call Alert Level 1, which is, you know, mostly life as normal here in New Zealand. And we know that we're very privileged in that sense, and that has a lot to do with the management of the pandemic and the political leadership here in New Zealand. But even though, you know, that's a relatively positive story compared to many of you, we have had to think hard about what it looks like providing services in a post-COVID world, because even though things are very much back to normal for many of us, there are some who are still being cautious. We still have to be cautious about travel, and many of us are still wearing masks. And travel, we still have to make sure we've got our contact tracing. We're still washing our hands and being very careful. And during lockdown, of course, we had to think about the services and make some radical changes. And we, like the rest of the world, moved a lot of services online, and some of those are still being delivered online. And I guess one of the things that was interesting about that was we weren't sure how acceptable that would be for people, or how much pick-up or take-up there would be of those online services such as support groups. But what we found is that in many parts of the country, around about 60% of our clients were connected in some way, although they might not be big users of their connections pre-lockdown. But for some, they really found a home in online services in a way that they had not anticipated, and that then opened up a world of contact for them, and including with their family, which was very exciting. And of course, Anne, who's quoted on the screen here, is one of those people. We also had to pivot our national services. So we had a conference planned for just the week before last, which of course we had to postpone till next year, and we ran a series of webinars on human rights instead. We had to rethink our World Alzheimer's Month program, and we shifted a whole lot of those activities online as well. And that was really exciting for us, a bit scary to be doing things in a slightly different way, but quite exciting. And one of the things we did in that new Move for Dementia digital campaign was we thought about, well, what about those people who might have come on a memory walk with us, who might have done that with their loved one with dementia, and what can we offer that might be useful for them? So we had a go at creating a virtual memory walk, and I just want to show you a short video of that.
Kia ora. So good to see you again. Let's go for a little walk. familiar, this place. Birds sing their tune, feet amble and voices hum. The day beats along. The sunlight falls dappled through the trees onto our smiling faces. Brings back memories of walks just like this. Fingertips tickled by Toy Toy, our hands joined, 2 by 2. Nothing in the world but time, and each other to spend it with. Not quite knowing our destination, but not really minding at all. Because wherever we're going there together. Kakite Norm, my friend. I'll see you again soon.
So that the idea of that virtual memory walk was very much about invoking that sense of calm, of enjoying an experience together. And the words that you just heard and saw on the screen were written by somebody who has a family connection with dementia, and she was really talking about her own experience and what was important to her. So so that's been exciting and a new thing for us to do. So also, we're trying to do some other things as well, obviously. So we're very much, sorry, let me just, I just need to let this finish, and then hopefully I will be able to, right. Okay, so, but of course we are also trying to progress some other things as well. And the most important of those, I think, is the Dementia Action Plan. So New Zealand does not have a Dementia Action Plan. We don't have any particular focus in government or in our health services around dementia. There's been no new funding for dementia services in New Zealand for a very long time. And look, as a sector, we got tired of waiting for someone, for government to take the lead in this, so we decided to do that ourselves. And we worked with some of our other colleagues in the sector, the Dementia New Zealand and the New Zealand Dementia Foundation. The Dementia Cooperative has since changed its name, to develop this Dementia Action Plan. And look, you know, it's based on the Global Action Plan. It's based on the findings from the Lancet Commission. It's based on best practice and research, and it has 4 goals in it: to reduce the incidence of dementia, to better support those living with dementia now, to build dementia-friendly communities, and to strengthen leadership and capability in the sector. We're very encouraged that our new government, elected in September, included reference to this plan in their health policy pre-election, and we're hopeful that that means that we might make some progress in this next term of government. But of course, they will be dealing with COVID and vaccines, and there's a major restructuring of the health system planned over the next few years as well. So we are going to have to keep our foot on the accelerator for that. But our other big initiative is our new Dementia Learning Centre, which we launched last week. And we're very excited about this. This is a hub for excellence in dementia learning here in New Zealand. There hasn't been one before, and it has been a while coming for us. It's going to provide a combination of online and in-person education for people living with dementia and for people working in the sector. And it will be starting to deliver services in early 2021. So very exciting that we've been able to get that set up during everything else that's been going on this year. So that really brings me to the end of the session today. I really want to finish with this quote. This quote comes from one of our almost 10,000 dementia friends. And I think it really resonates with us here at Alzheimer's New Zealand. And I think, you know, we've all appreciated this year how important kindness is for us all, and none more so than for people who are living with dementia. So that's it from us. Thank you again for this opportunity to showcase our services in ka kite anō.
I don't know, there's intermittent interruptions.
Well, thank you very much, Catherine Hall, for that reasonably good news from New Zealand and all the work your organization is doing there. And now we're going to hear more about an event called Virtual Ideathon. It's a project of Forget Me Not Alzheimer's Organization. That's ADI's member in the United Arab Emirates. Desiree Vlecken joins us from Dubai. Desiree, welcome, and please go ahead with your presentation.
Great. Okay. Thank you. So, good afternoon, good morning, or good evening, whatever time zone you are. Greetings from the United Arab Emirates. My name is Desiree Vlecken. I'm founder of Forget Me Not Alzheimer's. We're an NGO and social enterprise raising awareness on Alzheimer's disease and promoting quality of life for seniors and caregivers since 2013. Thank you, ADI, for inviting us today to speak about our unique journey with Ideathon 2020. Let's start first with the first slide. Oh, yeah. Yeah. Okay, there's some intermittent interruptions, but we have to go to the first slide. Yeah, so that's who we are. And then the next slide. What do we actually do? Every year we have to change our vision statement. For this time, I think we hit we actually found the proper vision that we would like to pursue, and that is empowering seniors to age gracefully while remaining resilient and protected from Alzheimer's. And our mission is creating a favorable environment for seniors to feel happy by preserving their memories and creating opportunities for meaningful engagement. So you might ask, how do we do that? Well, we organize a lot of events across the Emirates. We have organized also outbound tours, which started last year. We actually took 10 seniors from the UAE to have a familiarization tour in the Philippines for 7 days, 6 nights. So we've been doing that a lot. Actually, in 2017, that's when we started making more events. Usually, we only had like one event every 2 months, and then it went to one event per month. And last year, we actually did 4 events per month. So we were quite actually busy. But unfortunately, with COVID-19, next slide, please. Our operations had to scale down by 80%. We did a lot of webinars, and that was okay. But as you know, webinars here has a certain saturation point. Seniors would still prefer to meet in a face-to-face and meet other people. So we were a little bit distraught with our activities because we didn't feel very effective. So we constantly have to reinvent ourselves, and that's what we did. So there was a point, I think it happened last October, we were updating our social media feeds. Next slide, please. We were just checking out our Instagram, and we saw an announcement inviting organizations and NGOs to participate for the virtual Ideathon. We never participated in any grants or any competition because we were so busy here. So we had the time to actually look into it and said, there's nothing to lose, but probably there's something to gain. So we followed that announcement and said that we can probably register and let's see, maybe we can qualify. So the next slide, please. We saw that this announcement came from volunteers.ae. It's a collaboration between the federal government, the Emirates Foundation, and the Ministry of Community Development. And they have a partnership with IAVE. It's the International Association for Volunteer Effort. So this was a global announcement, and we were not even aware that, that it had a good PR outside the UAE. So we thought it was just here internally. So we said, okay, we need to try this out, virtual Ideathon. It actually piqued our curiosity because it looked like battle of the brains of some sort. And maybe we could test the waters and see what it can bring to the organization. So next slide, please. We found out that Ideathon had 282 applications in 81 countries. So they have a country representative in each continent, actually. And so we said, maybe we're not going to make it, but we have to try and see what it can bring to us. So next slide. In the UAE, we found that there were 111 NGOs. And among those 111, we were actually surprised to receive an email that Forget Me Not actually made it. So we were shortlisted. And Ideathon was just looking for 24 participants. And among those 24, one of them was us. And we were the only Alzheimer's organization to participate in this virtual Ideathon. So then and there, we were actually very honored to participate. And we were also quite nervous because we didn't know what to expect. I'm sure the other participants were veterans in applying for a grant, but for us, this was our very first time. So next slide. You might ask, how did we do it? No trade secrets here. We just complied with the requirements, and one of them is actually we have to prove that we are legitimate. That's for one. So there were a lot of validation documents required, and we have to prove that we have demonstrated a lot of community service, not only with a particular group, but actually on the entire spectrum, meaning not only the expatriates, but we have to demonstrate that we've been reaching out to the Emiratis as well. Next slide. We submitted like mountain loads of documents, not just any other documents. We're talking about availability of documents. It has to be authenticated, stamped, proved. We have to submit like dozens of essays. And on top of that, we only saw the announcement 3 days before the deadline. So it was like a whirlwind submission, but we managed to pull everything together and forwarded it to the organizer. So next slide, please. So when we found out that we made it, we had 3 weeks, or actually less than 3 weeks to prepare. One of which is I had to prepare for the dream team. We need to have 5 members to participate. And it was a very tedious selection process for me because no matter how good the team member is, but if they don't have the commitment, then it's not going to work out. So instead of using, top CEOs at whom I know around the Emirates, I've actually settled down in selecting a lot of professors. And I think professors or teachers make the best team because they are very resilient in terms of stress. They can do a lot of research, and they know how to meet deadlines. So that's very good. So that's what actually I found a team of professors in different universities, and who has contributed in the cause of Forget-Me-Not for a couple of years. Then we had to gather information. So within those 3 weeks, we had to do a lot of boot camp reading. We have to understand what are the latest or what are the best practices of Alzheimer's awareness. We have to research about the competition and who are the other participants who, by the way, we knew about them at the last minute. And we had weekly meetings. We had created a Google file drive where we share each other's research notes. And we did a simulation exercise as well. And, you know, it's funny, we had some conspiracy theories also on what to expect and what not to expect during the competition. Next slide. Everything was going well until, you know, this is what we learned to have plan B. One of our members, who is actually a marketing strategist, had to back out like 2 days before the competition. And this person was she had a very key role in delivering the competition for us. But unfortunately, COVID-19 happened, so automatically she had to back out. So from our 5-member team, we were down 1 man down, so we were 4. And none of us knew much about marketing. And I think that's a lesson for us, you know, not to rely on one person to do one thing, but we have to ensure that we're also good in other aspects as well. So we decided to proceed with the competition, even though we're just 4 of us. And we knew that, you know, the chances of, you know, of being on the final top 3 is very remote. So yes, that's what happened to us. So next slide. You might ask what happened during the competition on the next slide. There was a challenge that was revealed to us on the day itself. And in each challenge, there was 3 subsectors, one from the medical sector, one from the mental health, and one is for the vulnerable, where we competed. And once the challenge was given, we were given like 48 hours to come up with a business proposal, to have a pitch deck and make a presentation within 48 hours, yes. So we actually didn't sleep those 2 nights. So the next slide, please. You can see on this photo that we were camped in some sort of a hotel where we did a lot of brainstorming. And one of our team members is actually 92 years old. You might wonder why we included him on this journey, because though he is retired and he's, you know, he has a lot of value to put in the competition, because he did a lot of business proposals himself when he was younger. So we thought that it was a good idea for him to have the exposure as well. That was Mr. Puji. And on the next slide, so on the pitching day, we assigned the best of our team member to make the presentation. He actually did pretty well, and we thought that the judges were so engaged with the presentation. They asked the correct questions, and we were able to answer properly. And yes, it was a very memorable moment for us, because we really put Forget-Me-Not on the flag. You know, we put our mark here in the UAE that we are here, and it was a very validating experience for us. The next slide. Unfortunately, we did not win. The prize went to Trinidad and Tobago, and I think they had an equally beautiful presentation as well. But what is the benefit of being a participant of this competition is that we got connected with the federal government of the UAE. And as soon as the borders are open to Abu Dhabi, we will all troop down there to make a courtesy visit and to reintroduce ourselves again and build a good relationship, inshallah, as they say. And what are our next steps? The last slide, please. We're not going to stop because we did not win the competition. Actually, when a door closes, a window opens. After that competition, we immediately got 2 of our sponsors back. And then there's another foundation who got in touch with us and wanted us to participate again. So there are many things to gain in applying for a grant, I think. Everybody wants, of course, to have that prize, which was actually $25,000 US. But it's not just the money that motivated us to participate. It's like we just wanted to make sure that the government knows that we are still here. And even though there's COVID-19, we have been continuously raising awareness through webinars, and that we have not stopped working, and that we are here for the long haul. So I think we'll wrap up this presentation with the short video highlights of what happened to us during Ideathon 2020. And actually, I encourage other NGOs and fellow organizations to keep an eye on volunteers.ae, because I think they're going to do this every year, and it would be a good opportunity for you guys to try it out, because for us it was really a learning experience, and we can't wait to do several more applications. So thank you, and I hope you enjoyed the video and stay safe.
Well, amazing. Desiree, the video itself is pretty eye-catching. What did you think, first off, and your group think, after you saw the put-together video, which is very professional and very slick? What did you think?
Well, you know, it just dawned to us like we did really something great. You know, we still have nightmares about it, that we didn't sleep for those 2 nights. Yes, but it's actually really worth it. We also realized that there are lots of gaps in our operations, and it's an eye-opener for us to address those gaps and make sure that the next time it happens that we are more prepared.
Well, even though you didn't win the big prize of $25,000, it sounds like you really won in many other ways. Sponsors
Yes.
came back, other people came back during this whole process, and you and the group really learned a lot about making a pitch, doing that kind of thing. Those, the valuable lessons you learned there, you'll keep for a long time, won't you?
Yes, absolutely. We were actually surprised when the 2 of our sponsors came back knocking at our door, because we thought that it's over, you know, they're not going to support us anymore. But actually, they were pretty aware what we were doing. And like they said, hey, Forget Me Not has what it takes. I mean, we should really support this organization. They have something to say, and we want to be part of that. So that's why we would like to do another attempt, maybe early next year.
Well, will this be with Ideathon next year or some other organization?
Actually, another organization has requested us to participate. And it was very strange because we don't know this foundation ever at all. They just sent us an email saying, hey, Forget Me Not, you know, I think your mission is aligned to what we're doing. And we're trying to select several NGOs like yourself to participate. So, and we'd like you to be part of that. So we believe that they got connected through that volunteers.ae, because we're now part of that network.
Mhm. What's your best advice to any of our members, particularly some of the smaller ones who are understaffed and underfunded? What's your best advice about getting together and putting together the application? What are some of the things that you should remember? Advice you can give to some of your fellow members?
Well, maybe the best advice we can give is do not underestimate yourself. You know that we lack in a lot of resources, including human capital and financial capital. But that was not an impediment to us because we've been operating for such a long time. And you know, we actually, if you do a risk assessment in participating in a grant, it's very valuable because you get exposed to other potential donors and potential foundations who are on the lookout for legitimate organizations to support. And that's why you'll never know until you try. And that's what we did. We were never on the lookout for a grant. We were just curious, so we tried it. And our team is just waiting to do the next round of application, and that's why it keeps us going, you know. And it's very, I think if we didn't participate, we would have regretted it a lot.
Well, this sounds like absolutely great news, and it is for you and the organization, and for the people that you serve in your organization. Yes. It's certainly good news for them too.
Yes, they're very happy that we were included in that competition, and there was just a small setback because the border to Abu Dhabi is still we're not allowed to go there yet, because that's where the headquarters of volunteers.ae, and that's on our next agenda. Once the border is open, we can physically go there to have this courtesy visit, because it's important to have a face-to-face discussion with them versus emails and Zoom calls. We are in the Middle East, so face-to-face is very important.
And that could lead, maybe, to be hopeful, that could lead to some funding.
Well, inshallah, that's what we want. If not, you know, we can do it step by step. Patronage of support is very important for us as well, to have them align with our events. That would spell many good things. Like the private sector always love to align with an organization who's very close to the public sector. So that is one strategy that we'd like to do. And yes, we're very hopeful that they haven't forgotten about Forget Me Not, because I'm sure they haven't. We are going to go straight forward to Abu Dhabi as soon as, you know, the vaccination is, yeah.
Desiree, thank you very much for joining us and telling us all about this. It's a wonderful story, and you and your people should be congratulated.
Most welcome, and thank you for having us, and looking forward.
Absolutely, absolutely. Thanks very much.
All right.
From the Isle of Man, we're creating a suite of apps to delight and engage the elderly, those that are self-isolating, as well as dementia patients and carers. We turn memories into games.
Hi, my name is Peter Quayle. I'm the Chief Operating Officer of Memory Lane Games. I used to be a computer scientist, but now I look after the finance and governance of the company.
Hi, I'm Tom, and I'm developing an AI platform to deliver the best games based on cognition level.
Hi, I'm Karis, and I'm a researcher and game designer for Memory Lane Games. I'm also in charge of our social media pages and customer liaison.
I'm excited about launching our clinical trials and showing that this app has the ability to improve the outcomes for both patients and their carers, clinically and in their quality of life. This is an app for the elderly.
Good morning, good afternoon, good evening, everyone. Thank you so much for being with us here today, and welcome to our session where we will be focusing on dementia innovation readiness and the index that the Global Coalition on Aging and ADI and the Lean Foundation published just a little bit earlier this fall. We're very excited to bring a group of panelists to you today to talk about their expert perspectives on this idea of innovation readiness and the local level responses. And I'll kick it off by saying, we'd planned to have an event in person with many of you in Singapore back in March, and we are just very thankful that everyone that's here with us today, everyone is safe, and that we're able to get together in such an exciting and interactive way. Today, we aim for this to be an interactive discussion with our panelists, but also a town hall style so that participants who are listening to us today can type in their questions, can also type in their best practices, and we want to hear from you as well as these experts, because you are the ones who are on the ground really helping make change happen at a country level as well as at a city level. So, let's see, can we go to the next slide? Nope. So I'd really like to thanks so much to ADI, as I said, and the Lean Foundation, Paola Barberino and Chris Lynch. Your team has been wonderful to work with, both in the creation of the city's index, as well as we really appreciate the work that you did to originally create the conference that was scheduled to be in Singapore, and then to pivot to be able to have a virtual gathering such as this. We're really pleased to be part of it. Global Coalition on Aging is a group of business leaders who are really focused on how we turn some of the challenges of population aging into real opportunities. And of course, Alzheimer's dementia is a critical area in which we know that if we prepare better and if we make sure that we have cross-stakeholder approaches, cross-geographical approaches, we're going to be better prepared to ensure that we tackle this issue in the best way possible. So I'm going to just let you know who we have with us today. We'll turn over to our speakers very soon. Chris Lynch, of course, with ADI, will be joining us and telling us a little bit about his perspectives on the index. And we have just an impressive star-studded panel of experts who will all introduce themselves as well. Dr. Ricardo Allegri, who we've had with us at the launch of the 2018 index of G20 countries from Argentina. We also have Dr. Hanadi Al-Hamad, who comes to us from Doha. We have Prem Kumar Raja, who is with the Alzheimer's and Related Disorders Society of India in the Bangalore chapter. There's some interesting findings out of India, so we're really excited to have you with us, Prem Kumar. Unfortunately, Kate Swaffer from South Australia, who is such a wonderful advocate for people living with dementia. She had an emergency, family emergency, and had to attend to that. So we wish her the best, and we will talk to her soon. We also have George Bradenberg, who is the convener of the Global CEOI Initiative on Alzheimer's disease, who can give us a wonderful perspective on health system preparedness. And finally, Dr. Huali Wang, who is the chair of clinical research and director of Dementia Care and Research Center out of Beijing. We're so pleased to have all of you here with us today for what will be a very interesting session. Okay. So I just want to start off by talking a little bit about what dementia innovation readiness is to us. We worked really closely with ADI and other experts really across the global stage to help inform what this concept is. We define it as the level to which a city is prepared to innovate in terms of novel approaches, systems, or processes that would have an impact on prevention, treatment, and care of dementia. And when we thought about looking at cities, it was really important to us to narrow down what our categories should be. So we look at strategy and commitment. How does a national level strategy and commitment actually filter down into local levels? And that's what we evaluated. Early detection and diagnosis, which of course is very critical to making sure that people get the resources and the care and the access that they need. And then that goes directly into access to care. How are health systems prepared to tackle the issues around Alzheimer's and dementia? Community support on a local level is of course critical, from Alzheimer's societies and associations to other local level leaders who are building dementia-friendly cities. All of these have such an important role to play at a local level, which actually filters up to a national level. And then finally, the business environment. How are we ensuring that business leaders, like many of us represent represented at the Global Coalition on Aging are part of those conversations. And so we used a lot of different data sources. We talked to these experts, we talked to other experts, we did a lot of desk research, and so we have the report for you. I'm not going to go through all of the findings of the report here today. We had a launch event back in October, and I encourage you to go to GCOA's website, to go to ADI's website where you can access that content as well as the index itself. But I do want to talk a little bit to say that when we looked at these categories, we really had these 5 categories. We had 26 indicators, and we were asking the questions: where is innovation in dementia currently occurring? What are the enablers of innovation? And what are the barriers to innovation? So that's the lens I think I'd like to ask our panelists to sort of take as we are ensuing upon this conversation today. So the question that will come up is why, cities. This was the first time we looked at cities. We had 2 previous iterations before where we looked at G7 and G20 countries. We found that cities they're major hubs for innovation, and they have the capacity to be the epicenter of implementable solutions and very action-oriented policies. And the 30 cities that we evaluated, they represent a range of geographies, population economy sizes, healthcare and policy systems. They include major metropolitan centers as well as smaller municipalities that warrant investigation due to specific enablers or barriers to innovation readiness. So our goal in investigating on the local level really is to inspire collaboration and action on the ground, to marshal support for productive policies, and ultimately to improve outcomes for people living with dementia, their loved ones, and communities around the world. So before we sort of get into all the details and we start having a really rich discussion, I just wanted you to get a snapshot of the overall scores. And I'm really excited about the session because you'll see some of the top performers across the 5 categories, Glasgow, Manchester, Amsterdam, Vancouver at the top. And we did find that best performing cities are really actively thinking about preparing for and addressing barriers to and enablers of innovation. And in many of these cases, they have an older population, so they're sort of forced to think about this a little bit earlier than some of the younger countries. But I'm really excited that we do have some of the younger countries participating in this panel today, and those that performed in the middle and in the lower parts of the index, because I hope that means that the index has inspired these countries to step out. I mean, these city representatives and country representatives to step out and talk about some of the great innovations that they have going on in their homes and how they are reviewing local roles to advance dementia innovation. So with that, that's my brief introduction to the session and to the index itself. I'm going to turn it over to Chris Lynch, who has been our wonderful partner, of course, the Deputy CEO and Director of Policy Communications and Publications, basically everything at Alzheimer's Disease International. In our partnership, we really got to think about this concept and work together. And I'm going to ask him, particularly for our audience, how we think about advocacy organizations working to hold national and local governments to account when promoting dementia innovation and pushing for that. And I also want to ask Chris, what lessons does he think can be learned from the innovation in response to COVID-19 in relation to dementia? Because we've certainly seen that there are parallels and impacts there. So Chris, I'm going to turn it to you for an introduction on your side before we get to the panel.
Thank you so much, Melissa. Delighted to be co-hosting and joining you all today. It's been an absolute pleasure to work with you and Mike Hodin and the team at Global Coalition on the 3 indexes we've done so far, but particularly this one of 30 cities, which was supported by the End Foundation. And if I can I give a shout out to Sam Savin, who was our number cruncher throughout the whole process. He did an absolutely fantastic job. And I'd also like to extend my welcome to the panel today for the town hall, all who have been involved in and actively involved in this, often in an advisory role on the index. So welcome to you all. I think this year more than ever, COVID has thrown into sharp relief the need for innovation and for preparedness, with the realization that with global need, the world can come together and innovate, as we have seen in response to the pandemic. And it should do so again for what is the pandemic of dementia, galvanizing the global dementia community and finding innovative ways to tackle the broad ranges of challenges we face, now from risk reduction through to diagnosis, drug development, and post-diagnostic care. But to get into this session, let me tackle those initial questions that Melissa posed for us. The first one around advocacy organizations and how at national and local level they can hold governments to account in promoting dementia innovation. I think genuinely this has to start with the development of national dementia plans and then the interpretation of that at city level. And advocacy organizations have been the driving force behind the initial development of pretty much all of the current 34 national dementia plans that exist. And they should remain integral partners, obviously, as that goes forward. 194 WHO member states have signed up to the Global Action Plan on Dementia. And the creation of a national plan is the best tools that those governments have available. It starts with scoping and a situational analysis, but it's such a solid foundation. And I think advocacy organizations, often representing the patient voice, must continue to create the movement and momentum to help governments to start that process. It can be quite intimidating for governments when they see the scope and scale from it, but it has to come. And what this cities index has shown us is the importance of translating those national plans to, I think, city level strategy. And few cities so far have developed specific plans or strategies, but they absolutely should be engaged with national government on the delivery of the national strategies. And if I can, I'm going to move on to the second question, Melissa, that you posed. And I've talked about COVID a little bit already, but what lessons have been learned from the innovation response to COVID-19 in terms of the dementia space? I think the global response to innovation around COVID-19 has proved that we have the capacity to galvanize and to come together and to innovate and to find solutions. There is now global awareness, I think, of drug development pipelines, which should and will translate to pressure on dementia treatment development process as well. We've also learned how vulnerable people with dementia are during this crisis. The mortality rates are absolutely heartbreaking. 26% of all COVID-related deaths in the UK were dementia-related, over 20% in Italy, 41% in Australia, and in Canada, 85% of all COVID deaths took place in long-term care facilities, where 2/3 of residents have dementia. However, we've seen some absolutely truly amazing innovation, finding ways to deliver care and support, using technology to connect people, exponentially progressing video connectivity, including hosting events like our own conference today. And of course, the incredibly rapid development of vaccines, which this week have started to be deployed here in the UK. This might need some expectation management, I think, in terms of dementia treatment development. With global expectation now on speed, and it's been proven that it can be achieved. But that pressure is a good pressure to have, I think. So Melissa, with that, I'm going to hand back to you.
Thanks so much, Chris. That's a wonderful perspective to think about because we have seen so much innovation come through during the COVID pandemic. And you're right, it shows that we can do it. And because Alzheimer's and dementia is the next big pandemic that we're just now realizing, I think, as a global community. I think we all have known that for some time, but that it puts it fresh in the spotlight for global leaders. So I'm going to turn it over to our panelists. I am going to kick off each with an introductory softball question, if you will. But I'd like for each of the respondents to perhaps keep their opening remarks to about 3 minutes or so. And then all the participants on the line, I really encourage you to listen, to ask questions, to share your innovations that you're implementing on the ground as you're reviewing all of this. And it's nice to see everyone here. So again, our goal here is to provide some tools for our colleagues to take home with them as we all aim to see progress at local level. So I'm going to start sort of at a high level. I'm going to start with George Vredenberg. Last week was the Lausanne Dialogues, which I know are very rich in discussion. There was a big focus health system preparedness. And I think it's exactly, Chris, what you're talking about. How do we innovate and get ready for what's ahead of us? So for George, my question for you is and I think you've got one slide here, what role should city leaders have in ensuring that they can avoid capacity issues as numbers of those with dementia increase, and with imminent treatment and diagnostic breakthroughs? What does that look like from a health system preparedness point of view?
Well, if you just put up my slide, I'll give you just a sense of the context. This is a slide developed by the Ministry of Economy, Trade and Industry of Japan, suggesting that in the 20th century, we basically were dealing with populations with a very slim sliver of people over 65. And as a consequence, we were dealing with health issues of younger people and medium-aged people, shall we say. But in the 21st century, we're dealing much more with problems of chronic diseases of aging. Now, what does that require? That requires a change in health systems from one in which we're trying to fix an immediate problem and to treat it, to one in where we try to identify those that are at risk for chronic diseases of aging and then try and prevent them. So as we go into decades of healthy aging initiatives at the international level, that's going to require us to be able to identify those at risk of later life diseases and to be able to detect and diagnose and then to intervene before those diseases occur by reducing the risk or by treating through vaccines or other preventive therapeutic investments. With respect to Alzheimer's, which is perhaps one of the most prevalent and lethal of these chronic diseases of aging, and one which has such enormous economic and social consequence to families and to governments, this requires us to begin to think about how to develop the tests in order to detect the biological progression of this disease, which we now know through imaging technologies begins 20 to 30 years before symptoms, and intervene either through risk reduction strategies or therapeutic interventions which slow or stop the progression of the underlying pathology. So I think cities are critical to this because mayors, certainly in the United States and I think around the world, are people who have to get things done. And so what is so important to me in the index that has been created is that we begin to see that if we could begin to link cities, either through sister city movements, through the age-friendly movements that involve sister cities, if we can get mayors to begin, or the mayor equivalents, to begin to link their efforts, to innovate in terms of the tests, and then to integrate early detection tests into their health systems, we can deal with this problem and make drugs affordable and accessible. At the moment, the tests are extraordinarily expensive. The imaging technology needed to detect this disease is not extensive beyond the very, very wealthy countries, and it's not geographically extensive or accessible because it's based upon nuclear materials which have a very short shelf life. So there's a very limited distribution of those technologies. But blood-based biomarkers, digital biomarkers can begin to help us identify through blood the early pathological processes of Alzheimer's, and digital by enabling us to see the early symptomatic representation of cognitive decline. We can, through innovative tests, which could be developed with multiple cities contributing to a smallish fund to invest in these innovations, and then to get some grant support either from their home countries or through a new initiative that we've been starting with the Global CEOI and the World Economic Forum. We call the Davos Alzheimer's Collaborative, grant funding from that mechanism to actually innovate those tests and integrate them into their health systems.
Thank you, George. That's a great setup, a good way to kick us off. And I think thinking about what you guys are starting out with the Davos Alzheimer's Collaborative, really pulling together stakeholders in this space to work together, that's a critical piece. And this is talking about, pulling together funds so that we can make changes where we need to. And I know that health system preparedness working group that I've been involved in as well, we're really beginning to figure out what that's going to look like because there are a lot of challenges to be addressed. With that, I think I'm going to, talking about sort of national government approaches and how that can filter to cities and mayors, I'm going to next turn it to Huali Wang, and please introduce yourself briefly, as well as give us a sense, Huali, on, we know that China is really looking at the national government approach to promoting healthy aging. You know, we have to do that. The sheer numbers in China require it. So what does that look like for local governments and cities? And from a Beijing point of view, specifically, how are you seeing Beijing as responding?
Yeah, thank you, Melissa. And also, it's my great honor to be invited to this session. Yeah, as you mentioned, that promoting health aging is one of the priorities in our country, because there are more and more people living in old age. Actually, the dementia care is one of the key projects involved in the health aging project in the government announcement. Within that framework, improving the awareness of dementia and also related depression is one of the keys. And also within the framework, we are encouraged to support cognitive screening in the communities. And then the other achievement this year, that our government has officially released the National Dementia Strategic Plan. So this plan has encouraged us to do to promote dementia care in a more comprehensive way, including raising the awareness of dementia in the public, and trying to create dementia-friendly social atmosphere, and also try to build a multidisciplinary team to support dementia care and increase or support the capacity building of those service providers. So this is very important, actually. So improving mental health and cognitive health actually is one of the objective within different policy documents. So as I mentioned, that raising public awareness is very important. So specifically, I would like to highlight the achievement in Beijing. At city level, communities are encouraged to provide brief cognitive checkup through mobile devices. So since last year and this year, there are more than 10,000 people have been screened. And at the district level, where I'm working and also I live, that's Haidian district. Haidian district actually implemented community-based dementia care, including training community health workers, social workers, community staff, and provide public education in the communities. Also integrate cognitive screening with their physical checkup. And some communities also set up memory clinics to support the checkup for the people who are suspected of dementia. And also, these communities try to organize caregiver support groups and provide cognitive training for those who have mild cognitive impairment. So I think that these are all the activities that are currently happening in Beijing, especially in Haidian district. And in recent years, this work has been transferred to other cities. So these are the achievements that I would like to highlight. Thank you, Melissa.
Yeah. Thank you, Huali. That's a wonderful example, because you're seeing, again, how national strategy trickles down. We're seeing action being taken, focusing on awareness, prevention, early detection, which is so critical, and then sharing that innovation. And I think using technology is an interesting piece as well, because when you think about innovation, often technology is the first thing that comes to people's minds, and it's really good to see how you can use technology in a way that is enabling and meets all of the goals that we're seeking. So thanks so much, Huali, for that perspective, and congratulations on that work. I'm going to go now to Ricardo Allegri. You've been instrumental in helping inform our indexes, both the cities index as well as our previous one where we looked at Argentina. And you shared with us that Argentina's national government doesn't have a strong focus on Alzheimer's, but there is actually a good deal of local level support in Buenos Aires. So how can other cities that aren't getting the national support that they need, and hopefully they're pushing for it. But how can they help activate a local response to dementia based on your experience in Buenos Aires?
First, I'd like to thank to Melissa and Chris for the invitation. Argentina, the second large country in South America with a population of 40 million, 80% European descent, have globally 12% of a population over 65. National government doesn't have focus in dementia. As example, the authority of the Minister of Health doesn't send information to WHO Dementia Observatory. Buenos Aires, with a population of 50 million inhabitants, more than 30% of all the country, and the life expectancy is higher than the rest of the country, 50% over 65. Regarding the health system, Argentina concentrates all the high-quality research, education, healthcare, etc. in Buenos Aires. So, most of the dementia specialists and the memory clinic are located here. Early diagnosis is another challenge. The availability of AD biomarkers is limited to one neurological center, Fleming, in Buenos Aires. This is also true for Latin America, that are very few centers with AD biomarker. Buenos Aires is prepared to innovate. Our problem is the rest of the country. As developing country, we have 40% of the population living below the poverty line. This social disparity remains a problem in health policies. I believe, for Argentina, I believe that the key to activate local response to dementia in other cities would be working with PAMI, the Argentine Global Medical Institute for Elderly, and ALMA, the Alzheimer Association from Argentina. Argentina has traditionally been involved in caring for the elderly. In 1971, the national government created the Institute for the Elderly to take care of the social and medical needs of retired people with the program PAMI. PAMI, from the Spanish, Programa de Atención Médica Integral, Program of Global Medical Assistance. It is a state-run institution. The institute provides care for approximately 17% of individuals over 60 and 90% of those over 75. It includes almost all the elderly population in the country. Nowadays, PAMI has approximately 4 million of affiliated, 10% of the global population. This institute not only provides healthcare, but also tourism, entertainment, and social club for all his affiliated around the country. But it is run by politicians that sometimes use the fund for other convenience, and that's the big problem of the institute. I believe that we need to work with PAMI, with ALMA, in order to improve and develop better and innovate program in other cities from Argentina, as long as the institute is coordinated by an independent system to supervise the fund. Thank you very much again for the invitation.
Thank you so much, Ricardo. I think that's, again, some really good examples of sort of how you have to come together, and you need to have the associations that are bringing in the priority, right? You can take lots of actions, but you need to make sure that it's prioritized at different levels. So I think those are wonderful insights. So looking at, continuing on looking at some of our younger countries that we have represented today, I'm going to go next to Prem Kumar Raja. You've let us know that government really has committed to a national dementia strategy, but with little progress so far, and I think it's still quite early. But what innovative initiatives and efforts in Bangalore specifically do you think could later align with the national dementia plan? What does that look like, and what actions are taking place?
Thank you, Melissa. I'm really honored to be part of this panel. And as you know, India is one of the largest countries in the world. And presently we have about 1.37 billion. And out of that, about 5.3 million people are with the dementia. Here, 1/3 of Indians are below poverty line. Compared to other countries, India is very much lagging behind in providing appropriate support to people with dementia. There are several challenges, though there are very good organizations working with passion to improve the quality of living of elders with dementia. But unfortunately, in our country, we have several challenges. Government is yet to recognize dementia has a healthcare priority. We have limited resources, but the population is huge. So we need to be innovative to come out with possible solutions to address this emerging epidemic. Alzheimer's and Related Disorders Society of India has taken the initiative to draft and submit the country plan a couple of years back to the then health minister. And since then, they have been following it up quite effectively. Even they have met the present health minister of Government of India to follow it up. But country like India, it's going to take a very long time, and we need to be patient, but we have to consistently take a lot of efforts to make this happen. But we are very sure it will happen with the leadership of the Alzheimer's Society of India. Well, now to talk about the initiatives, the innovative initiatives from Bangalore. First, let me talk about our effort to make quality dementia care affordable and accessible across the country. As I told you, it's a huge country, and the facilities that we have presently are very much inadequate, and the resources are limited. So we have to look at an affordable solution for this problem. So from Bangalore, what we have done is we have come out with a hub. So we thought we need to get into a hub and spokes model. The hub has been set up in Bangalore by an NGO, Nightingale's Medical Trust. So here we have an experts, and for the past 10 years, we have been running it successfully. It is a 100-bed facility, and experts are here. So they, through a multi-pronged approach, so they, and also non-pharmacological approach, we try to make the life of our residents better, and we have been quite successful. But the cost of care in a place like Bangalore would be huge, so we have to make it more affordable. So we have now set up a pilot project. It's about in a place about 60 kilometers from here. It's a very small place. There we don't have experts, but we manage with caregivers. But for that, we have developed a special software, and using the software, we manage the patients quite effectively without compromising on the quality. This has enabled us to come down, maybe bring down the cost by 40%. So this project now is proved successful, and but it needs to be replicated. Our idea is to see that it's replicated across the country, so that quality dementia care becomes affordable and accessible, throughout the country. This is what we are looking at it. Second one, dementia risk reduction in coordination or in association with the Thinking Fit UK. So we have started a pilot project in Bangalore. It's called Active Aging Program. So we do evaluation at different points and keeping elders active physically, socially, and cognitively. So this has again proved quite successful. And this particular model now we are taking to nursing homes. In Bangalore, we have about 150 nursing homes. So same concept through mobile approach, we are taking to the places. So where when people cannot come out, the conditions of nursing homes, I'm talking about old age homes in India, we call, they are different and the conditions are quite pathetic. So we take this concept to these places so that the residents there have better quality of life. And support and guidance, well, we have developed a unique app It's called DEM Connect app. This app enables people to have self-assessment, because in India we have a lot of stigma attached to this, and we don't have that many memory clinics. So this app enables people to do assessments at home without coming and meeting the psychiatrist. Plus, they can get support and guidance from experts. There's a community through which, they come together. This is an innovative thing that we have started, and we have online support services for home-based patients, like who don't want to come. So our specialists from here, when we try to give online support, and also we run support group meetings through online periodically. And also, we are involved in training the community in dementia care skills. It is again the initiative of Alzheimer's Disease International through Alzheimer's Society of India. We got trained, and we are leveraging technology and see how through online we could train more people, in this important program. For creating awareness and friendliness. But what I'm talking about, they're all in line with the plan, or maybe the country plan, that what Alzheimer's Society drafted and presented to the government of India. So we observe Alzheimer's Month through various meaningful programs, and our approach will be quite innovative. For instance, recently we had quiz for doctors, the medical students. Because here it's not medical students, even they are not aware of dementia and the management, through which we try to do that. And we have Dementia Friends program. So that is youngsters going to education institutions and making them aware of dementia and the management. So for about 10 institutions we covered, and about 2,000 students have been trained. We also involve media and celebrities, to these events, so that this will be the policymakers pay more attention to it. We also come out with a very ambitious plan of making Bangalore a dementia-friendly city by 2025. There are various things under that. These are various things we have initiated, but still we have to go a long way. Once again, thank you so much, Melissa.
That's great. Thank you, Premkumar. That's a number of examples I think that we can learn from. And I want to make sure to remind folks to please submit your questions or comments. Tell us what you're doing. We'd love to be able to report on that during this session. But I'm going to go ahead and make sure that our last speaker, you have a moment to tell us what you're thinking as well. So to Dr. Hanadi, I'm really excited that you're here representing DOHA, which we took a look at in the index, because we felt that there were lessons to be learned, of course, from younger countries and in areas that are just sort of coming online in terms of recognizing the challenges of Alzheimer's and dementia. Tell us your perspectives in terms of how DOHA and really larger Qatar is proactively preparing for an eventual aging population, and that wave of dementia that will likely come with it. And specifically in terms of post-diagnostic care and support, what are you forecasting in DOHA?
Yeah, so thank you for the invitation. I'm very honored to be with all excellent panelists today. And I want to highlight that our population in Qatar, around 2.7 million, and elderly 60 years and above, 6.5 of the total population. United Nations project increased number of elderly in state of Qatar by 2030 to be 12% of population. So as a country, we prepare ourselves by drafting our national health strategy 2018-2022, and it is 7 population, and 7 population healthy aging was one of the 7 population. Under healthy aging, many initiatives to prepare the country for aging. Of course, increase the health literacy, increase the awareness, empower the elderly themselves to improve their knowledge and information. Here in Qatar, I don't have baseline strong data for elderly social and demographic data. So data survey, it was my initiative. Easy access to the system and increase mobility. For under healthy aging and the stigma, most of the Arabic country, a cognitive decline and national dementia plan it came under healthy aging to reduce the stigma. So we launched our national dementia plan 2018 with corporate with WHO and the Alzheimer Disease International, which during our journey they support me too much. We have a lot of context under National Dementia Plan. We have 7 action area. One of them, of course, risk reduction, and this is part of preparedness for the country of aging. I'm starting my program by age of 50. If we follow decade of healthy aging, especially Qatar, we consider 60 years is the retirement age, and 10 years before, so 50, we start all my awareness campaign. And for post-diagnosis, we have many initiatives. Of course, we have helpline, national helpline, easy for elderly and for Alzheimer patient or new diagnosis. And especially, as I mentioned, due to stigma, many of family, they want to hide behind the line and call. So we have more diagnosis with the helpline. We have easy access for dementia patients. We have dedicated daycare for them to come for subacute cases, especially delirious cases and behavioral agitation. I don't have here in Qatar daycare specific for Alzheimer, but there is business case submitted. I'm working on that one. We have many campaign of awareness associated with the ADI during all the year, and of course during Alzheimer month. This, of course, education. Dr. D.Y. Sahari from Indonesian, she came in Qatar 4 years and start caregiver education. In addition, we have the special program with ADI collaboration for nursing education. We have social support, of course, for caregiver free from the country, formal and informal caregiver support. So as I mentioned, the missing is daycare, and inshallah will be there. Thank you.
Thank you so much. It's wonderful to hear so much action being taken on the ground level. We've got a number of questions coming in. You mentioned stigma, and I kind of want to address that first because it's on my mind. I've been listening to everyone. Stigma is a challenge, right? Making sure there's detection and early diagnosis, fear of being diagnosed, uncertainty of what's ahead. And knowing that populations, and we found this in the index, different local areas have different types of populations, have different expectations that have different perceptions and ages of their populations. How can stigma and encouraging people to learn about dementia, to seek a diagnosis, how is and can that be addressed at local levels? I'm going to throw it out to anyone.
Well, let me try. I'll start. We have been changing our language into language of brain health, and the notion that other panelists have raised about the possibility of screening ongoing cognitive assessments starting at age 40 or 50, and basically emphasizing how you can improve your brain health number. So that if you get a brain health number that I'm 100, but if in fact I diet, I exercise, I sleep better, I cognitively train, socially engage, my number can go to 110 or 120. So that rather than thinking of this as an inevitability, at the end of which is definitely dying, there is a way to begin to think about how it is we think earlier, think about brain health, think about cognitive training. And your panelists here have given some excellent examples of that. So we're trying to change the language and the perception to this is a midlife issue. You ought to start thinking about your brain health in your 40s and 50s.
Wonderful. Yeah. Thanks, George.
Yes,
Doctor. Sorry.
Yeah, thank you. Just quick thought following up from what George was saying. I think it's a really important point, that this condition, this disease, isn't just focused on the older population. The wider breadth of population you can get involved, even right down at intergenerational level, changing the conversation, changing the language. The stigma doesn't tend to exist in the younger population. They haven't developed a stigma around it themselves, and their language can help us change it. I think campaigns like World Alzheimer's Month and a myriad of campaigns that take place across the world every year, they're really useful, but the language of them also needs to change. Let's move it away from some of the negativity. Let's move it into proactive language about brain health, about being able to do something about it, not just about diagnosis and managing symptoms. And I think a proactivity approach to it can really help with the stigma.
Great. Thanks, Chris. I think Dr. Oh, go ahead. Sorry. Let's go ahead. Just go to Prem Kumar. And then Huali.
Yeah, a couple of things that we have tried out from our country. One is maybe specific to our city, involving celebrities. So celebrities who had family members with dementia, making them openly come and say that sort of it can come to anybody. So that in India, that has a huge impact on the population when celebrities come and accept and make a statement that dementia can affect anybody, that it has a huge impact on it. Second one that I was talking about, that app. So when there's a lot of stigma and people are not taking medical help on time. So when I was talking about this almost 3 million Indians with dementia, but the sad part is 90% of the people are not, they don't get diagnosed at all. And if at all they get diagnosed, it's very, very late stage. So this app, in the sense because going to psychiatrist in India, nobody likes to go to a psychiatrist, so this app, it's a very, very user-friendly, senior-friendly self-assessment. So by answering few questions, they would know whether they have the symptoms of signs of dementia, where they could go and take that. So somehow makes people, to get diagnosed early, as well as take medical help faster.
So, Prem Kumar, can you share that app with other cities? Can we see it? Can others use it?
I couldn't hear.
I said, could you share your app with others?
Yes, this is
Would
called
others be able to see it and use it?
Dem Connect app. They want to see that. Yeah, I'll just show you, Dem Connect app.
Oh, you. Great. No, we'd love to see it.
Yeah, can I type it?
No, that's fine. We'll share it with everyone.
Yeah.
I just want to make sure everyone can see it. I didn't know if it was publicly available for others to access.
Yeah, it's available in
Wonderful.
both the platforms. Yeah, I'll just type DEM KONNECT. Yeah.
Thank you.
Thank you.
Well, I'm going to go to Huali and then Dr. Hanadi and then to Ricardo, because I think everyone wanted to chime in on this question.
Yeah, I just want to add on Dr. Ha regarding that. We actually, if we could educate the society with positive images of dementia or like quality care, for example, we can educate the public that if the caregivers is well supported, if the caregivers could provide a certain type of support for the people living with dementia, then the quality of their life will be improved dramatically. So since we had experiences in supporting caregivers for 20 years, so we have seen a lot of positive family stories. So these stories are shared and they serve a very good education for the society to reduce the stigma. And the other type of positive image of dementia is trying to provide early detection of dementia. Since when we promote cognitive screening, that can help us to identify the suspected of dementia in early stage. So if the people is diagnosed with dementia in early stage, or even if they are suspected of mild cognitive impairment, they can be treated timely or be trained appropriately. Then, of course, we also follow them up. In that, in the long term, we can observe the cognitive function is stable, and the quality of life of people remained quite well. So such positive stories could be shared, and then to educate the population not to be feared of early screening, but no matter when you would like to seek support, you will be supported appropriately, and the quality of life will be maintained or will be improved. So I think that educate with positive stories will be a good way to reduce stigma. Yeah, thank you, Melissa.
Thank you. Yeah, no, I think you're right. I think the connection to the stories, but connecting that to actually having access to care. You've got hope. That's your theme, right? You get hope that as we learn about this condition and individually, that there's going to be care and possibilities for improvement of health. Dr. Hamadi, please.
Yeah, so I echo my colleague, the panelist, changing the theme, brain disease is very important. I'm never using dementia in my awareness, either brain disease or cognitive impairment. Then I start to use Alzheimer, which acceptable in our country. Other point I want to highlight, many of program in TV, they call themselves dementic talk or informed talk, labeling the program as dementia, which we communicate with the media department because they label this program as dementia. So if you are talking incoherent, so it means dementia. So this is another important point, and echo my team panelists exactly what they said.
Great. And Ricardo, do you have anything to add on the stigma point?
Yes. Stigma is a big problem in our population because we are Latin people. We are descent from Italian and Spanish descent, no? And we have a big problem in the society with the stigma. ALMA, our Alzheimer Association, work a lot with the diffusion, work a lot with all the campaign of prevention or all the campaign to be know the disease and to know that we need to, we have a lot of things to do in the middle life to prevent or to delay the beginning of the disease. And ALMA work a lot with the diffusion. I believe that it's very, very important that the society recognize the disease. We have not possibility to have celebrities with Alzheimer's disease because the celebrity deny, the family deny that the celebrity had Alzheimer's disease. And this is a big problem because we need to work with this idea at the society. And ALMA, the role of ALMA is very, very important.
Thanks so much. There are a number of questions coming in. They're a lot, a little bit overlapped. I want to hit on a question about the connection to the pandemic. We had a question come in that says, has the pandemic highlighted countries that are less prepared to support people with dementia than we thought? Are there any that are more prepared than we thought? I'm going to turn that to Chris because I know you guys have been really exploring this, and then see if everyone wants to chime in before we close it up with the last question.
Yeah, thank you, Melissa. Can I say something controversial and say that probably about 18 months ago, the UK and the US both topped a chart in terms of global preparedness for a pandemic. And both those countries are probably, or could be accused of being the worst in terms of being prepared in terms of responses. It's really hard to analyse in terms of the 30 cities we looked at the index. Because so far it's been global responses, but in terms of preparedness, when you think about the impact, and even in those countries, genuinely where the preparedness was workshopped, in advance for something like an infectious disease, a pandemic like this, the impact that it's had on the health and care systems is absolutely incredible. And a really simplistic example, which we know has led to the inflated mortality figures in care homes. So the discharging of people from hospitals without testing because of this emergency need to vacate beds. Now that's put an unprecedented pressure on healthcare systems and particularly on care homes. And I think in terms of preparedness, that's the kind of thing that those working or the workshops in preparation should really be tackling. And I think we've fallen well short of the expected limit for that. And I think we absolutely need to learn the lessons of this. And cities particularly, because of the high densities of population and the extreme pressure that it will put on their health and care systems.
Anyone else have anything to add? Yes. Chime in. Dr. Mike.
So I will start. Thank you. During one negative impact, the positive impact was opportunity to open a lot of things during COVID, and it was difficult, not during the pandemic. Number one, I managed to open the national helpline for a dementia patient or Alzheimer. I managed to open elderly helpline. We managed to deliver medication, which is still continuous even after COVID or a declining number of COVID cases. So medication delivery for the elderly. Easy access through dedicating easy access system. As they are not fit to go to the emergency to come to this area. Virtual memory assessment and using blind mocha for the assessment. Outreach for crisis cases. The negative impact of the COVID, more cognitive cases. We are finding more cases, they are coming to us. From reduced socialization and reducing mobility, maybe not control their chronic disease. So more cases MCI, my observation this year referred to memory clinic. Thank you.
Great, Ricardo.
Yes, in Argentina we had two big problems. One was the pandemic, but the second one was the quarantine. We had the quarantine, the longest quarantine in the world, more than 200 days. And the isolation of the patient was terrible for the patient and for the caregiver. The isolation, because the government said, you don't need to have contact with the patient. You must not contact the patient. You must not contact, and the isolation was a big problem. Most of our patients had been deteriorated in the time of the pandemic. The quarantine was terrible for Argentina.
Yeah, you see that. There's the social isolation, there's the misdiagnoses for any number of conditions. So it's very important to point that out. I think, Wally, you had a remark. If you can make it about 1 minute, and then I have one final question I want everyone to close on, please.
Okay, thank you, Melissa. Actually, I want to echo Chris to be prepared anytime. Because here, just to share a brief story. Last year, we had a collaboration with a nursing home. We trained their staff how to provide non-pharmacological support for people living with dementia in their facilities. So during the pandemic, the facility was fully locked down. But their staff had to they had to live there. So they go home, they had to stay with their residents. So usually, originally they feel bored and they feel worried. And through the telecommunication, I told them that you should, because you already been prepared to support the people here, so you should support them and also support yourself. Then they started to be vibrant. They do a lot of exercise, they do music, they do group training, and then this helped them to get relieved. The stress was reduced. So I think that to be prepared anytime for quality care for people living with dementia will support us to be prepared for any disaster in the future.
Thank you, Wally. So with only a couple minutes to go, we're going to have 30 seconds of closing remarks to respond to the question that we've seen a couple of times today. How can cities engage in mutual learning to ensure best practices and principles for dementia innovation are implemented regionally and internationally? So what's the sharing mechanism? How does that look? I'm going to give 30 seconds. I'm going to start with Prem Kumar, go to Dr. Hamadi, then go to Ricardo, Wally, George, and close with Chris. So Prem Kumar, you're up.
Good. See, for this, national organizations like Alzheimer's Society of India, so they have to obviously take a lead because they are the ones who network with various service providers across the country, and they obviously know the best practices. So what are happening in different parts? Because India is huge. Like, I mean, what is maybe working in South India may not work in North. It's a very diverse country. But organization like Alzheimer's Society of India, they really play a major role. They're already doing it. They're already doing it. They are bringing people together. They are organizing various programs like workshops to make others learn. Like, I mean, where the success stories are there, and they need to be documented. Like, I mean, the success stories or best practices need to be documented, published, and it should be available on the websites, and people
I think
can
we might get
see
cut off,
in different.
Prem Kumar.
Yeah.
So we're going to have to go 20 seconds to everyone. Really appreciate that. You're right. Documentation is critical. Dr. Armati.
So totally agree. I think through other association, any country, and having national dementia plan with contribution of different ministry, and identifying focal points leading the country in the progress, because monitoring and following the progress is very important.
Thank you. Ricardo.
I believe that for us, the network, the network is very, very important. Our experience is that we can promote and we can work better with a good network around the world. Around the world.
Thanks, Ricardo. Wally.
I think that multi-sector collaboration is important to help us to build multi-faceted service for the people living with dementia. So I would encourage that all the government should prioritize dementia care in their agenda and help us to build more multi-sector collaboration. Thank you very much.
Thanks, Wally. George.
I take up on what Wally just said, multi-sector, but also linking it to a city network around the world. So the age-friendly network among cities across the world is a very strong one. I think we ought to build into it, but I also think they need some independent financing and focus. And as Wally has said, multiple sectors involved in that effort so that we have an age-friendly, dementia-friendly city network, which is multi-sectoral.
Thanks, George. Chris, any final thoughts before I sign off?
Yeah, final thought is we would absolutely love to do more cities, but until we get to such a point, I think there's a really interesting exercise in mapping some of these cities to like-minded cities in terms of scale, location, etc. in other parts of the world, and we'll certainly work with Global Coalition to do that.
No, we're excited for the future partnerships. We're looking to do another index that we're actually going to look at countries in Europe coming out in the spring. So we're looking forward to that, and we'll keep you all updated. But just congratulations on the work that's being done. Thank you to ADI, to ADA for everything that everyone's doing here. Congratulations, Chris, on a wonderful conference, and we look forward to continuing these conversations. Thanks, everyone, for joining.
Thank you.
Bye-bye.
Hello everyone and welcome. I hope you're enjoying the second day of the conference so far. My name is Laura Davas and I am ADI's Membership Manager and Membership Development Program Lead. I'm absolutely delighted to introduce you to this next session, which features some of the amazing work from 3 of our member associations. We have Alzheimer's Scotland, Alzheimer's Association Lebanon, and the Alzheimer's Association in the US. We will also end the session with a lovely slideshow with pictures from our member associations all around the world, so please stay with us until the end. Before we start, I'd like to remind you to use the Q&A box to post your questions. There will be a live Q&A throughout this session. I'll probably ask 1 or 2 questions to each speaker following their presentations, depending on the time. But first up, we have Joyce Gray, Deputy Director of Development, and Fiona Corner, Dementia Dog Project Manager at Alzheimer's Scotland. And they will tell us a little bit more about the Dementia Dog Project, which is a collaboration formed from the key founding charities, which are Dogs for Good and Alzheimer's Scotland. So Joyce and Fiona, over to you.
Thank you, Laura. Good afternoon, everybody from Scotland. This is a real pleasure to get to speak to everybody. I don't fly, so getting to international conferences is a rare treat. So I'm really excited to be here. I'm peppered with a wee bit of excitement from speaking from home when you've got dogs, a teenager, and a husband working in another room. So hopefully we can get through this without any interruption. I'd just like to start by describing the roots of the project. We worked with a group of students from Glasgow School of Art who were doing service design. And this project was probably the first true project that we worked on that had its principles in service design. We always, the voice of our users is the heart of everything we do, but we hadn't actually adopted the service design principles. So the students worked with us for about 6 weeks and they came up with probably about 9 different service options. And Dementia Dog, actually from the beginning, you can see at the bottom right-hand corner when we were talking about animal interventions and like the kinds of things that we could do, it's showing out as something that we would really like to explore a bit more. People with other conditions have assistance dogs, so why not people living with dementia? And we really wanted the opportunity to sort of look at that a bit further. So probably it took us maybe about a year and we managed to get some funding together. The first lot of funding that we got was from a design challenge with the Design Council, and that gave us money to actually produce a full blueprint. This was the first service of its kind in the world, so there was no blueprint for us. We then started to partner with Dogs for Good, and they have, you know, like absolutely world-leading expertise in assistance dogs, but they themselves haven't worked with people living with dementia either. So that gave us the opportunity to develop the blueprint, really look at all the, you know, the issues, you know, what might work for us, what might not work, and we decided that we would, you know, we had enough information in our blueprint to give this a really good shot. So 2012, we introduced our first beautiful assistance dogs to our families, and there, from left to right, we have Oscar, Casper, and Alex. Now, these dogs have been amazing team members and ambassadors for Alzheimer's Scotland and Dogs for Good, and they're all still well. Oscar and Alex are just about to enter into the retirement phase. And it's like, hopefully that will be long and happy for them. And Casper, who's in the middle there with Glynis and Ken, is still working really hard with his family, and hopefully that partnership will last for some time yet, because it's been enormously beneficial for the family and for us to see it. It's just been absolutely amazing. These were the benefits, the expected benefits and the unexpected benefits. These were the things that when we were developing our blueprint that we thought that we might see and that we might see evidence of those. So the expected benefits were the anchoring, exercise, routine, reminders, social interactions. And then the person with dementia and carers with family just getting joy. But we have to say that some of the unexpected benefits were, they shone out even more than the expected benefits. Motivation for people to start routines or to try new routines. Go on holiday, do things that they might have had no motivation for. A sense of self. People starting to feel themselves, in their own lives, in their partnerships, in their relationships. And postponement of formal care. Alex and Oscar and Caspar, their families, and that's like all those years that Caspar has been with Ken. There has been no other formal supports, which for us is like absolutely astounding, and doesn't form this a normal pattern. Communication being enhanced. Sorry, my clicker is just frozen on me because I spoke too long on that one. It's just going about to reconnect. On to my next slide. Oh, sorry, click twice. Yep, so that was the benefits that we've seen. And then in 2016, the benefits, as I say, they were absolutely astounding. That we knew that we had something, absolutely unique and very special. And we were fortunate then to get more funding from Life Changes Trust. So the pilot services that we've been running since 2016 to date, through the income that we have, we're matching more assistance dogs, trialling community dogs, and having more dog days in our dementia resource centres and other places that people living with dementia might go. So I think that's my slides, and as I say at the end, I'm very happy to take more questions, and I'm going to now pass over to Fiona.
Thank you, Joyce. So here's a picture of our dementia dog team. We're quite a small team, but we also have an integrated dementia specialist who works very closely with our specialist dog handlers to really ensure we can provide timely, holistic and meaningful support for families. So I'm just going to talk to you a bit more about our assistance dog, community dog and dog day pilots. So here we have some of the families in Scotland who've gone on to receive some of our dementia assistance dogs. We have a total of 10 families currently, and once the dog is matched successfully with a family and placed in their home, they're there for the rest of their life. So we continue to tailor and provide ongoing support for those families throughout that time. And most of these families received their dog in the last couple of years, but also there you can see Glenys and Ken with their dog Caspar, who's still with them 8 years on. So here are some examples of the practical skills we train up with our dementia assistance dogs. So from emotional skills such as a comforting headrest on your lap, which can really help reduce anxiety, to fetching the paper in the morning. Our dogs absolutely love to work and to retrieve different items. The dogs are also trained to help dress and undress people, and in some cases they help wake people up in the morning and to get up and get dressed. So one of the big skills we train our assistance dogs with is to respond to an alarm, and at the sound of the alarm they'll go and fetch the medication pouch and bring it to their owner to prompt them their medication. And we also see how this can lift a huge amount of strain every day off carers' shoulders too. So when out and about, the dogs are trained to walk on a double lead, which means that both people can really enjoy going outdoors together and taking the dog for a walk, and also all the social interaction, the new social interaction that this brings as people stop and want to hear about their wonderful dog. And the last picture in the bottom right hand corner is one of our dogs, Webb, rolling out a physio mat. And it's just an example of how we really tailor the support of each dog for the individual needs of the family. So just to now talk about our community dog programme. This works really well for people we perhaps can't support with assistance dogs. They might live on their own, they might be a bit more progressed in their diagnosis, and these are goal-driven therapy interventions that are delivered by our trained team of handler and dog who work alongside a healthcare professional. And they're a brilliant stepping stone as an 8-week intervention to really help boost someone's confidence, give them new skills and reconnect them back into activities in their local community. And the beauty of it is the dog acts as a natural motivator to really help people engage and enjoy the sessions to achieve a goal. So our Dog Day events, these are lovely group events that we've been piloting in Scotland and England, where we can welcome people who are at any stage of their diagnosis, just to really enjoy lovely gentle interaction with trained pet dogs and volunteer handlers. And this is a great way for us to be able to support people who are more advanced or progressed with dementia. So I'm just going to play you 2 short videos now, because like everybody, we've had to radically change the way we can support people during 2020. And we've translated elements of our face-to-face support into trialling virtual dog therapy sessions. So hopefully these videos will work and we can share with you what we've been up to during 2020.
This is Georgie. Georgie's a 3-year-old golden retriever and she's a community dog. Together we work with people that have a formal diagnosis of dementia and we work alongside a healthcare professional to work on specific goals. Those goals could range from reducing social isolation, working on motivation, to increasing confidence around using public transport. At the moment, unfortunately, we are unable to work with people face to face, so we've tried to come up with different ways to still engage with clients, make sure that people still have the opportunity to engage with the dog, and also make sure that they still feel like they're part of the wider community. So we developed Doggy Bingo. Doggy Bingo is very straightforward, and all you need is a bingo card and a dabber or pen. We then link in with already existing dementia support groups, and Georgie will go and fetch a ball with a random number on it. Sometimes she will change her mind at the last second and drop the number and pick a different one, which is always very entertaining, especially when it gets towards the end of the game and people get very, very competitive. Number 16, sweet 16.
You've got a line. You've got a line, Kathy. Well done.
The feedback so far has been nothing but positive. They can't wait for the next session. They want to know when it is. They love the fact that it's the dogs that are picking the bingo balls. They're quite a competitive bunch, and they're really enjoying the banter and things like that online as well, because we've really enjoyed it. It's a highlight for them and it's a highlight for us, and it's just that boost of positivity in the day.
It's been really lovely to witness those individuals who were really quite anxious about being on screen and have them grow confidence in coming on. In fact, one of the regular ladies who attends actually remembered that she was online to see the dog for bingo, which I really think speaks volumes as to how the interaction has affected her.
And one further video.
The walks are designed to be super fun and to restore some routine back into people's daily lives, therefore helping them with motivation to exercise and just bringing them the joy that dogs bring. Billy is a 4-year-old Labrador Cross Golden Retriever, and he has been specially trained to work as a community dog with people with dementia. So Billy and I would normally work face to face with a person living with a diagnosis of dementia, and that would be with the support of their health or social care practitioner or their family. Our sessions are designed to help promote personal development goals such as motivation, working on social connections, building confidence, or self-reliance. Because we're all staying home more at the moment, we've found that some of our clients are finding the lack of daily routine and cognitive stimulation a real struggle. And this is where the virtual dog walk comes in. The virtual dog walks work by connecting myself and my community dog Billy with the person with dementia and their carer using a secure video link via NHS Attend Anywhere. All people need to take part is a smartphone or tablet. The client and their carer can walk in their local area or around their garden, while Billy and I walk in our local area. The video link allows us to have conversations and share experiences while on our walks. It also allows the client to interact with the dog and cue him to do certain things, such as sit at the road.
Billy, sit.
Good boy, Billy.
And this allows the call to be much more interactive for the client, so they're not a passive watcher of the walk, they are truly involved with the dog, and it also gives them a sense of responsibility for the dog during the walk.
Bye, Billy.
Bye.
So since creating those videos, we're now actually connected in with over 70 Alzheimer's Scotland local groups, supporting people right across the country. And just to share our future vision for Dementia Dog, we're really excited. We think there's huge potential, and really building on that strong collaboration between Alzheimer's Scotland and Dogs for Good to provide a very tailored and flexible model of delivery to respond to the needs of the families that approach us. And one of the building blocks of this will be building on our international collaborations that we've enjoyed to date. So thank you very much for listening, and we welcome any questions. Thank you.
Oh, that put a huge smile on my face. Thank you so much to both of you for telling us more about this fantastic project. And I'm sure all the dog lovers out there will find this absolutely wonderful. I'm definitely one of them. And I tweeted earlier, actually, all the ADI dogs want to get involved as well. So thank you so much. I don't know if we have time for Q&A, so we'll probably wait until the end of the session. If we have some spare time, we'll definitely come back to you. But maybe you can start answering the questions in the chat box if you don't mind. But thank you so much for joining us. We'll now hear from Dr. George Karam, President of Alzheimer's Association Lebanon, who will talk about the Beirut Marathon and the association's collaboration with the Angami music streaming platform, if I'm not mistaken. So George, over to you. Thank you so much.
Thank you. Thank you, Laura. Thank you, everyone, for attending. And just wait.
Can we have George's slide?
Okay, here we are. Okay. So thank you, everyone, as I said, for attending. And I'll be talking about two initiatives, in fact, that we've done at the Alzheimer's Association in Lebanon. My slides are not moving. Sorry about that. Okay, here we are. So very quickly, just to tell you that Alzheimer's Association Lebanon was established in 2004, and our mission is to improve the quality of life of people with dementia and their caretakers, and we really put a big emphasis on that. And the primary objective is to raise public awareness throughout Lebanon and the Middle East. Now, as we are a small association, and Lebanon is relatively a small country without much resources, and all of the work that we do is purely voluntary without much support from the government, we really had to come up with creative ideas on how to reach our mission by fundraising, but at the same time by raising public awareness about our association, but about dementia in general. So I'm going to talk about two initiatives that we've done in the last few years to showcase, how we've been successful in raising funds and raising awareness about dementia. The first one that I'm going to talk about is the Beirut Marathon. Okay. So the Beirut Marathon is a marathon that started in Lebanon 16 or 17 years ago. And it is the biggest sports event in Lebanon that happens usually the first Sunday of November. And we have thousands of participants, be it runners or be it people that are just standing, on the sidelines and watching and cheering up. So it's a huge opportunity for us to showcase Alzheimer's Association and to talk about dementia, because in the same event, you have close to 50,000 people being there. So we took the opportunity of that, and around 10 years ago, we started encouraging people to just register and to run or walk a fun 10K run for us. And we used to print T-shirts for them and then carry balloons and stuff so they can be walking in the streets and people will recognize that Alzheimer's Association is present. And then we would have flyers that we will distribute as we are walking. And things were working out well, but it reached a point where I felt that we need to do something more serious than that. So in 2017, we decided to really take things more seriously. And at that time, we had a small campaign on social media before the marathon to try to recruit runners. And we had 266 people that wore the T-shirts of the Alzheimer's Association and started walking as a group. So for the first time, we really had a big group working together, and it was really interesting. But at the same time, we had 4 people that decided to run the full marathon, so the full 42 kilometers. 2 of them because their parents had dementia, and 2 people who work as caregivers for people that have dementia. So we had 4 runners run the full marathon, and it was really very interesting. And in fact, I'm going to show you a video summarizing what we did in 2017. I'm having issues with my clicker, it seems. Okay, so here's the video.
Alzheimer is a disease. Since there is no cure, there should be more awareness about how to treat this person.
وقت واحد يبلش ينسى لازم انه نشوف حكيم، لازم نشوف اخصائي لنتاكد اذا هذا النسيان هو من وراء مرض الالزهايمر او من وراء غير امراض.
بيفتكروا انه يمكن الانسان انه شوي يمكن مجنون، بس بنقدر نعالجه كيف بدنا نتعامل معه للمريض.
كثير مهم انه ما ننسى العائله تبع مريض الالزهايمر، لانه هذا المرض هو بيسبب ثقل على العائله قد ما بيسبب ثقل على المريض بحد ذاته.
انت بتكون بتعرف هذا الشخص اللي هو امك او بيك بصحته الكامله وبعقله الكامل، فجاه بتصير تشوفه شخص ثاني. من هون اهميه وجود جمعيه بتقدر تساعد اهل هذا الشخص لحتى ترشدهم كيفيه التعامل مع هذه الحاله.
الجمعيه هي تاسست بال 2004 وهي هدفها الاساسي الاهتمام بمرض الالزهايمر والاهتمام بعائلتهم. هدفنا ندعم جمعيه الالزهايمر، ندعم مرضى الالزهايمر يلي هن ببيتهم ما بيعرفوا شو عم بيصير حواليهم، كثير بهمني يعرفوا انه في ناس بتفكر فيهم.
لو شخص واحد بس بهذا الماراثون كله بيعرف حدا عنده الزهايمر وقدر يفوت على الفيسبوك او على الويب سايت او يتواصل مع الجمعيه ويساعدوه، بعتقد بنكون حققنا شيء.
كل اجدادنا اللي احنا بنحبهم معرضين هم يتعرضوا للمرض ده، فاحنا محتاجين نبذل مجهود اكتر علشان نوعي باهميه علاج هذا المرض والاهتمام بيه.
مريض الالزهايمر بده عنايه مثل ولد صغير، ونحن شعارنا اللي دائما بنستعمله حتى لو نسيونا نحن ما بننسيهم.
So Following that, in fact, the same like a week after the marathon was over, I decided to invite the runners, especially those that ran the full marathon, and decided to invite them to dinner to thank them, for putting themselves through that grueling event and running all 42 kilometers for the Alzheimer's Association. And something happened during that dinner where I was dragged and for me to run the full marathon in 2018. So I don't know who was behind that, but somehow they were able to convince me that I should be running the full marathon. And I did take things seriously. And in 2018, I decided to start training myself. And here we really stepped up our game even further, where we were able to recruit 780 people compared to 266 the year before, with 60 people running the full marathon. So we jumped from 4 to 60, and I was one of the 60. And it was really fun, and I do have some quick pictures showing you me running the marathon. But I don't know why there's a delay in the clicker for some reason. I'm really sorry about that. Okay, so this is me. So we had a booth during the course, and people could come and cheer, and that picture was of me training during the marathon printed. And then here's me on the right running the marathon, and then on the left at the finish line was a person, one of the 60 that were running with me. And then you have another picture at the finish line with my family. You can see I'm all white, but I did it, and it was fun. So it was really a fun activity. And if you've never ran, especially a marathon, I advise you to train for it. It's an unbelievable experience. And in fact, in 2018, we were voted to be the most active NGO in the Beirut Marathon. And I would like to point out that in the Beirut Marathon, you have more than 300 NGOs that participate. And so being recognized as the most active NGO was really something very important for us. And it was a great recognition for all the efforts that we were doing. Now, after that, in 2019, also we were participating in the marathon, but unfortunately the Lebanese revolution started just a month before the marathon, and the marathon had to be canceled. So unfortunately, I was training again to run the marathon in 2019, but I could not do so because it was canceled. So what we did was a second initiative that we did with an app called Anghami. Anghami is one of the largest streaming music apps in Lebanon and the Middle East. So it is the equivalent of Spotify, if you want, but it is a local app, and now it became really throughout the Middle East. So we came up with an initiative with them, and I'm going to show you a video that will summarize the initiative.
For many, these are memories they no longer recall. In a country beset by financial difficulties and with families barely able to afford medical care, Alzheimer's disease affects tens of thousands of elderly Lebanese, making them forget who they are, living in anxiety with their surroundings and even their loved ones. Although the effects of Alzheimer's disease are irreversible, studies show that areas in the brain linked to music memory remain largely undamaged by the disease. The Alzheimer's Association Lebanon stepped in to raise awareness that the symptoms can be improved with music. So we simply reached out to the families and caregivers through the same thing that's been central to every generation: music. We partnered with the Arab region's free and biggest music streaming app, Anghami, and turned it into an Alzheimer's disease awareness tool by launching the Dhikrayat playlist, an intuitive and automated feature that allowed family members and caregivers to generate the right playlist for their ailing loved ones. Every user in Lebanon was exposed to the Dhikrayat playlist initiative on their Anghami app home screen. All they had to do was write the patient's date of birth, and the Dhikrayat playlist was generated. containing the most popular songs from the patient's youth, making it easier to predict the relevant songs that could trigger happy memories for each person. Relying only on the app's interface and own channels, and with zero media spend, we achieved 206,283 user impressions over 2 weeks, and over 30% conversion rate. Fikrayat playlist managed to provide patients and families with precious moments that were once thought lost, spent with less anxiety and more happiness, while raising awareness to the constant power of music, making time shared together truly unforgettable.
So again, that activity was really successful, and we generated quite a buzz in Lebanon and in the region. And it was really cool, and the caregivers and people suffering from dementia really enjoyed it. So as you saw in the video, all you had to do was to put the date of birth of the person with dementia, and then the app automatically will generate the list of songs that that are from the era that the patient remembers, and that's how we were able to stimulate the memories. So I think having initiatives like that are helpful, very helpful. They are free, they are easy to do. You just have to connect with other organizations. And so, for example, like Anghami or the Beirut Marathon, they always love to connect with NGOs and to showcase some illnesses or certain activities. So I would advise you, in your own countries to do so. Just connect with maybe bigger organizations, and you can really raise awareness about dementia. And with that, I would like to thank you for listening.
A huge thank you, George, for taking the time to share these amazing initiatives. It's very inspiring, and I'm hoping it will inspire a lot of others to replicate the same initiatives in their countries. And great videos, by the way, as well, very professional and amazing. So I'll just check the questions, but I think the first one would be, do you think other associations in the world can do activities like the ones you presented today, and are these activities sustainable?
Yes, I really think that they can do it, because all they have to do is to be a little bit creative, think about outside the box, and there's plenty of companies out there that would like to give back, and part of their social responsibility. And if you present your case and that you want to raise awareness about dementia, and we all know that dementia is becoming, it's increasing all over the world. And people, you ask them what they are the most scared of, and they will tell you, I'm really scared of losing my mind when I grow up. So companies would like to associate and raise awareness about this disease. And I think it's very doable. And we did all those with $0 spent. And this is, the most important thing, that you can do amazing work without spending money. And we are a tiny organization. Now, is it sustainable, you're saying? Well, it is sustainable if you are working with a bigger company, and you become part of their CSR. So, for example, we had a bank here in Lebanon, and over the last 5 years, we've been working with them, and we became one of their partners for their CSR programs. Now, unfortunately, everything changed in 2019, 2020. We had the revolution in Lebanon. We had a huge financial crisis in Lebanon, obviously COVID. So everything's changed, but we're hoping that in 2021, things will become better, and we can have such initiatives again.
Yes, I know it's been a very, very difficult year for you all, and we're all thinking of you. Thank you so much, George, and hello to the whole team. But I will now hand over to our next speaker. Thanks, George. Our next speaker, Carlos Londono, Community Health and Outreach Specialist at the Alzheimer's Association Northern California, and Northern Nevada chapter. And his presentation will focus specifically on the Latino programs under the Diversity and Inclusion Department, talking about their successes, opportunities, and challenges. So thanks, Carlos, for being with us today. And
thank you, Laura. Good morning. Well, I would say good early morning. It's really 6 a.m. here in California, and I'm thrilled to be presenting. here at the Alzheimer's Disease International Conference. This is my first time and amazing experience. So I'm working in Northern California and Northern Nevada, so I will not be talking about the whole United States, but I will be focusing on California, especially the north part. And I'm very fortunate to work under the Diversity and Inclusion Department. So let me tell you about our vision. This is nationwide. We think and we believe and we dream in a world without Alzheimer's and all other dementia. And our mission encompasses three big components. It's research, as you know. It's also now strongly promoting risk reduction and early detection, and also quality of care. This has been like a stamp in our organization, how to provide quality care and support to all the constituents in the United States. So we are a team. It's very hard for one person to do everything. So we have a team under Iri Yao, the Director of Diversity and Inclusion. She has been with the organization for 20 years, a vocal voice about inclusion, diversity, and how to reach the hard-to-reach populations. And we work with Liliana, Sandra, and Patricia, a manager, family care specialists, and outreach workers. And with our volunteers, we are also a volunteer-driven organization, so it's very important to keep identifying, recruiting, coaching, mentoring, training volunteers so that we can deliver our core programs and follow our mission. I am in California, West Coast. We are 40 million people living in California, so it's really a huge, big state. I would say maybe the population of Argentina, the population of Canada, just in California. So for programmatic activities, we divide the state into Northern California, where I am, and there's another component in Southern California. We are 15 million Latinos in California. So it's also, we are the fastest growing ethnic group. We almost, this is a statistic for 2014, but we almost now surpassed the Caucasian population in California. Latinos represent almost 39 to 40% of the total population. So it has a huge impact in our programs and in the future, because also we are Latino, we are 1.5 times more likely to develop Alzheimer's disease than Caucasian. So this implies a lot of effort and a lot of planning, and really try to tackle brain health, risk reduction, quality care, health system, advocacy, how to deal with the disease. So let me talk about our program. This is our Spanish-speaking program to reach Latinos across the Bay Area, Fresno, San Jose, Monterrey, and really trying to reach the hard-to-reach population. So we break it into 4 components. It's engagement, health education, big events, and support. And it's mainly awareness, outreach, and health education. It's really always seeking to bring new people into different topics about brain health, risk reduction, about early detection, knowing the 10 signs, and also about connecting people to support services, to our family care specialists, so that we can help them in their journey. In the engagement component, for us, as we know, as a nonprofit, it's very, very important, the volunteers. So it's always every week, every month, identifying those community leaders, grassroots leaders that really have a meaningful connection with the disease, so that we can coach, train, and empower them to conduct the outreach, and to especially to get into their local communities. And in this model, I'm going to talk later about the Promotoras de Salud. It's a best practice, health promoters, strong community leaders who are really instrumental in delivering the message in their local communities. We strongly believe in partnership and coalitions, so we are also proactively participating in different activities, partnerships, and coalitions. And now we had the challenge this year, as we all know, when the pandemic hit at the beginning of the year. We were almost freaking out, and I can say is how we were going to deliver our services. If you see the top slide, the two pictures, this is before the pandemic. We were able to reach adult schools, churches, libraries, community centers, and different places in the community with our volunteers, with those community leaders. But when the pandemic hit, we had to move fastly into the digital world. And we know that technological gap with our Spanish-speaking community. But we are very, very fortunate because we then began meeting with the community. Let's do some coffee chats. Let's keep the engagement. Let's begin to learn about technology. Let's begin to give our support into these difficult times. Let's brainstorm how can we still reach families affected by the disease. So we are meeting now every week in our coffee chats with community leaders, promotoras, different organizations, so that we can bring the word about Alzheimer and risk reduction and connecting families to services. And we have been also successful with social media during the pandemic. So even before the pandemic, the social media use was very low amongst our constituents. And when the pandemic hit, we were able to improve our Facebook page. Then we designed a monthly e-newsletter, everything in Spanish. And now we are going to redesign the web page because we are now seeing that people are connecting and speeding the knowledge in technology to be there. Our strongest component is health education. So we have now ongoing online classes with three main topics. Healthy living is about brain health, health promotion, risk reduction, risk factors. We have a second component, and it's about knowing the 10 signs, early detection, those memory changes, and really breaking the stigma and the myths in our community. And we have another couple of classes that is about Alzheimer, understanding Alzheimer, and then behaviors, and another one about communication. And we have big events. So every 2 or 3 months, we really set up with our partners big events. And let me mention someone that I'm going to talk, and it's about the International Latino Conference. We also have a partnership with the ADI, and on September we host the Let's Talk About Dementia. We also have other big events with Living with Alzheimer and Caregiver Conversations. Usually we have between 100 to 300 and 400 Spanish-speaking people attending these events. And we have the support. We are also very strong with support. We have a helpline 24/7. And we have a support group. Now the support group is by phone, but all of these services are in Spanish. So let me talk about the International Latino Alzheimer's Conference, because before the pandemic, we used to have a big conference in San Jose. It's 30 minutes out of San Francisco. And we used to have also another conference in San Francisco. And we were able to attract between 50, 100, 150, even 300 Spanish-speaking people attending our conference. But when the pandemic hit, we moved virtually. So we partnered with UCSF, the Memory and Aging Center. They have a strong brain health global initiative. And we went virtual. And we were surprised to increase our participants from 300 presential before the pandemic to 900 people connecting to listen to the different topics about caregiver, brain health, and even research. These are two examples of our educational materials. To the left, we have the flyer. This is in Spanish. We have bilingual English and Spanish, but we send it out to all across Northern California, and these are for ongoing online classes about the different topics. We usually have 1 or 2 classes every week. Everyone can connect, and we have a very friendly registration based on a Google form. And to the right, this is the new event coming on January. We're going to have a Alzheimer's Promotores Conference. This will be a big conference for Promotores de Salud in Northern California, so that they can be more confident, so that promotores can improve their knowledge about brain health, risk factors, risk reduction, about early detection, and especially to understand Alzheimer and dementia, and then how to connect families in their local communities to the Alzheimer Association or other entities across Northern California. So finally, I want to share some successes, challenges, and opportunities. And the successes this year was the virtual and the social media work. Again, we still have the challenge to reach almost 14 million Latinos in California. And let's say just in the San Francisco Bay Area, where I'm specifically working, we have 1.2 million Latinos. So it's an ongoing effort, but we were very fortunately to speed the process with social media, with technology, with online classes, and people are connecting. We have these challenges because in our Spanish-speaking community, there's a lot of stigma. Families really do not want to disclose the diagnosis. Spanish-speaking people we really get late to get that diagnosis. We have to advocate for the system. So we still have challenges to reach more and more Spanish-speaking just in Northern California. And then we see a lot of opportunities, and it's really about keeping engaged with partners, building coalitions, training our volunteers so that they can deliver the messages in the community. And now the Alzheimer Association was awarded a big grant to be a center of excellence in risk reduction. So we really also want to move, not just to see Alzheimer with the disease component, but it's also how can we get into our communities with risk reduction and prevention messages. So thank you. Again, I'm Carlos Londoño with the Alzheimer Association Northern California chapter, and my function is to provide awareness and to reach Spanish-speaking people, to connect them to services, to prevention, and to keep people engaged.
Thank you so much, Carlos, and thanks to your team as well for all your hard work and engaging with all these different communities. So I think we've got a bit of time for questions. I'm just looking right now. I see one which is post-pandemic, are you going back to presential outreach and health education, or are you going to continue online?
So we have been finding, we have been finding a lot of success with virtual. So I think it has been like a speed process. Again, we were very afraid of our literacy, knowledge, literacy capacity, and there's definitely some barriers or some gaps that even our kids are facing in the schools without access to internet, without access to computers. But we have been seeing a good response in getting even triplicating our numbers, people in registering virtually. So I would say we will keep both. We will host ongoing online classes for those hard to reach community, maybe far away, people with transportation. And we need to go back to personal Spanish speaking. We really want that close face-to-face contact, that hug, being in the communities, listening to the community, and really participating in the front line. So that's something that is part of our culture, being there.
100%. It's really interesting you say that, because having spoken to a lot of our members, especially in Latin America, they actually realize that through internet and through these virtual sessions, they've been able to reach out to people they hadn't even imagined that they would be able to reach out to. So is definitely working, but I do agree that you have to do both. So best of luck for 2021, and we'll obviously keep in touch with you and find out what's happening. Thank you so much, Carlos. Thank you. And finally, we will now hear from Chris Lynch, our ADI Deputy CEO and Director of Policy, Communications and Publications. And Chris will introduce a little slideshow, which is quite exciting, showcasing the buildings lit up in purple around the world for World Alzheimer's Month over the past few years. So Chris, over to you.
Thanks so much, Laura. Hi, everyone. Really good to see you. Great to be part of this conference, day 2. A couple of quick hellos. Fiona and Joyce, hopefully still on the line. Very nice to see you both. I worked with Fiona and Joyce in Scotland a few years ago, and I'm a huge fan of the Dementia Dog Project. I think Doggy Bingo is totally inspired. George, you've made me feel incredibly lazy, and I should consider getting training for a marathon, I think. But there's a really nice link there that the guys in Scotland also have a Playlist for Life campaign and project on the go as well. So you guys should talk about the 2 playlists. And Carlos, thank you for my geography lesson. I had no idea that California had a bigger population than Canada. That's an incredible statistic. So if I can, I'm going to very briefly introduce a short kind of montage of the amazing illuminated buildings around the world. I think this initiative started a number of years ago, and the idea was predominantly in purple, but whatever the lead color for your organization is to light buildings up. Now, during World Alzheimer's Month and on World Alzheimer's Day, to bring attention to those buildings, but also to the cause. So we're going to have a look at the video, but I also wanted to kind of underline it with a call to action. It's amazing having the buildings lit up themselves, but I'd really encourage you to take it to the next level as well, now to engage the media and to get them involved in the conversation as well. Why is the building lit up? What is it that you're trying to communicate? It's a really nice opportunity. And of course, the media love it because it's so visual. But if we can we run the slide deck with the examples on it? Thank you so much for running that. What a great montage of examples from all around the world. And I suppose in a year when we've been dealing with COVID and our travel has been so reduced, it's almost like an inspiration, desire to be able to get out and to start to see some of those places again. I thought the picture in Tokyo, the Tokyo Tower, is beautiful in the orange of the association there. And I'm completely intrigued by Science World in Canada. I think that has to be on my visit list for the future as well. But let me, if I can, take a few minutes of your time just to talk about World Alzheimer Month over the last couple of years, but also what we're planning to do in terms of working with you for 2021 as well. So, in 2019, we started the Let's Talk About Dementia campaign for World Alzheimer's Month, and it was working really well. It translates so well into so many different languages, and we had decided to keep that going again for 2020. And obviously, COVID came along and completely changed the way that we operate and everything that you do on a day-to-day basis. So instead of changing the campaign, we decided to evolve it. So we retained Let's Talk About Dementia. But from all the assets and the materials and the posters and the social media cards that we generated, we added a huge number of additions to that helps you depict the revolution in technology and video conferencing and social distancing and all those inventive and innovative ways of people being able to communicate with each other. And of course, in terms of the masterclasses and the toolkits that we generated as well, they took on board the restrictions of COVID. And I'm absolutely stunned at how many events still took place globally. And have to say 99% of them were virtual events. But it's still wonderful, in terms of awareness raising and challenging stigma and giving profile to the World Alzheimer's Month and to the day itself. Now, for 2021, we often tie World Alzheimer's Month into our World Alzheimer Report theme. And we're going to do that again in 2021. And Paola revealed in the opening plenary on Monday that the theme is diagnosis. I followed that up in the awareness plenary as well yesterday, if you caught any of that. It's such a poignant moment in terms of diagnosis. We know diagnosis globally is still incredibly difficult. The numbers that are being diagnosed, also the amount of people that are not being measured. Health and care systems are not measuring properly. They're not recording, and we need that to change. But we know that we've got some imminent breakthroughs. We certainly feel like we're on the cusp of a treatment breakthrough, a drug breakthrough for dementia, certainly for Alzheimer's disease. And it looks like we're going to have some diagnostic breakthroughs as well. Potential blood biomarkers that could be administered by GPs and doctors, rather than having to go through the full invasive either spinal fluid or PET scans, which is both difficult, it's costly, it can be uncomfortable. So to choose diagnosis was really important for us. It is a particularly key moment. And I think in terms of how that will reflect in the World Alzheimer Month campaign, we can look back to a regional campaign we did in Middle and Southern America last year, the PAHO region. And we really did look at how you could have those initial difficult conversations about dementia, but look at things like the warning signs and really start to bring those to life. And we'll do that with the diagnosis theme as well. Obviously, we're going to engage with you all, come out and talk to you about it, get your ideas and your inspirations as well, and make sure that it works really well for you. But effectively, we've got a nice foundation to work from that PAHO campaign, and we should generate some really, really great materials that you can work with. Aiming to get the first batch of those out early next year, probably kind of April, May time. And then, in line with the report itself, the World Alzheimer Report will come out on World Alzheimer's Day on the 21st of September. We'll do some additional materials that you can use, infographics that relate to the report and some of the headlines from the report as well. And obviously support that with some media training and social media training as well around the launch itself. So really looking forward to it. Hopefully we will be back in a world where in-person events, face-to-face events can start to take place again. Let's get this vaccine rolling out right across the world so we can get back to some kind of normality. So thank you very much.
Thank you so much, Chris. I actually saw a quick question in the chat box about engaging with media. Just to touch on that, there is a campaign guide available for World Alzheimer's Month with a section on media with a press release, template, etc. So please do check that out. I'm not sure if we have time for questions, unfortunately, Chris, but thank you for this summary of World Alzheimer's Month. And we do obviously want to get even more landmarks and buildings lit up over the next few years. So please do help us in achieving that. This is one of my missions for Lyon in France, actually, for next year. But I'll now wrap up this session by saying another huge thank you to all of our speakers and thank you to all the participants for attending this session. I hope you have found it as inspiring as I have. Such wonderful projects, initiatives, and as I've said in a previous session, this is only a tiny part of what all our members do all around the world. So enjoy the rest of your day and I will see you soon. Bye everyone.
Thanks, Laura.
Welcome. Whatever your time zone, thank you for joining us for this ADI symposium sponsored by Biogen. Our topic is exploring cross-cultural approaches to informal care, value, burden, and bright spots. My name is Meryl Comer, chair of the Global Alliance on Women's Brain Health and a co-founder of Us Against Alzheimer's. I'm also here as a 24-year at-home caregiver for both husband and mother with Alzheimer's disease. The term informal care is an economic catch-all for what all of us do across cultures out of a range of emotion like love of family, honor, filial duty, friendship, or empathy. When we give regular ongoing assistance to any person, be it a family member, friend, a neighbor, without payment for the care given. One might argue that it is the years on the job that define you as a caregiver. As you look at this slide, consider it's the tip of the iceberg as we define value, quantified as proportionate burden, and the quality of life impact on informal caregivers to dementia worldwide. Now let's meet our panel. I've asked them each to self-introduce. You will have the opportunity to submit your questions using the chat function on this platform. We begin with Professor Martin Prince of King's College London. Martin?
Hello, I'm very pleased to be here indeed from the 1066 Dementia Research Group, King's College Health Institute.
Up next, Melissa Mitchell.
Yes, Melissa Mitchell. I'm the Executive Director of the Global Coalition on Aging, and we are a consortium of global businesses who look to find and move forward on the opportunities that come with the unprecedented aging of our society.
And our third and final panelist, Sue Peshin.
Hi, Meryl. Thank you so much for having me. Hi, everybody. I'm Sue Peshin, and I serve as President and CEO of the Alliance for Aging Research. We're based in Washington, D.C. in the U.S., and our mission is to promote research as a way to enhance aging and health.
Thank you all for joining us. These are not normal times, and the classic Alzheimer's patient caregiver life of isolation, financial hardship, lack of support, the fear of the unknown is the life, quite frankly, that all of us are living right now. So my first question to each of you before your presentation is, what systemic issues has the global pandemic unmasked when it comes to informal care? Let's start with Martin.
Yeah, so we're actually doing an opportunistic study in several Latin American countries and China off the back of our last surveys that we conducted. COVID arrived. And so this was an opportunity to identify people with needs for care and to go in and check with their families how they were doing and the experiences that they've been having. So it's clear that this has been very, very difficult. But I think a big problem around the world has been the issue of low diagnosis and low engagement with services. So these people who are vulnerable in the communities, particularly in low and middle income countries, are unlikely to have been identified in such a way that you can reach out to them and offer support at a time like this when they particularly need it.
Melissa, let's look at the workplace, because women around the world have multitasked in ways I think that they had not factored in before. Can you address the issues as it relates to the dementia community?
Yeah, oh goodness, that's a big question. I think I can sort of combine sort of what we're seeing out of COVID and how that affects informal caregivers and sort of overlay that with the workforce. I think we can build that into a big discussion. First of all, I do want to address your initial question, Meryl, in terms of caregiving. Clearly, for our aging society is one of these major issues that's really been illuminated through the COVID-19 pandemic, and we see that a lot, and I'll have that in my remarks in terms of how that it impacts the workforce. When I think of what informal caregiver is, frankly, Meryl, I've been admiring you for so long, and I would like to think that informal caregivers have the resolve and the strength that you have in that. But I think what we know that caregivers, of course, come in every shape and size, every race and every age across all societies. And when we talk about caregiving for older adults, it is typically a family member, and what's universal or someone who frankly wasn't prepared, for those responsibilities. I think what is universal about informal caregiving is the sacrifice. And you see that across the workplace. Informal caregivers may be foregoing educational or career opportunities because they have these caregiving responsibilities placed on them. Like you said, they're very happy to perform those, but it can be very challenging. And particularly in the workforce, to your question, is these caregivers won't self-identify. They may not know it because they may think they're being a good son or a good daughter or a good family member, but also the stigma around sort of calling yourself out as, maybe missing a little bit of work, have to leave early to go pick up mom's groceries. And I think that's a real challenge. So I think what we've seen in the pandemic is we've been able to use technology in a smarter way, but we need to have that human component of caregiving. And the challenges we're really stretched. We're really stretched in all the work that has to be done for representing informal caregivers.
I think we have a lot to unpack in that conversation later on in the program. Sue, that whole issue of this unmasking of some of the bigger issues that have been very present but under the radar screen for too many years, probably. What is your take on that?
I think it's a great question. I think that the pandemic has really revealed the way that we value different groups of people in society, particularly our oldest old, people that have chronic conditions and disabilities that are at high risk for COVID, and then people who are already experiencing health disparities but didn't get, as much focus as the pandemic is sort of forcing us all to see. From the very start of the pandemic, there have been discussions about rationing of healthcare, like who deserves the last ventilator. And health economists rushed to create ethical frameworks that usually left the oldest, sickest, and those with disabilities at the bottom. Access to PPE was focused on hospitals, and while nursing homes and folks who were providing that informal care and services in the home and in the community were basically left to fend for themselves. Unpaid family caregivers, which is what I think we mean a lot of times when we talk about informal caregiving, had to also deal with a lot of unemployment. There's massive unemployment going on due to the pandemic, so they're already not getting paid for the caregiving that they're providing. And then on top of it, many of them have lost their jobs. There's also, to Melissa's point, a lot of folks doing it for the first time. And they're also adapting to school or work closures like telework, and that can amplify everything. It's really hard to not have that separation going on. Home health aides have become more scarce, and fewer people are able to provide care when a primary caregiver gets COVID or has other types of issues going on. And then there's the whole issue of long distance caregiving. They can't travel to see their loved ones. And then families who supplement care or, with adult day or with long-term care options haven't been able to visit. And oftentimes they really do help the long-term care setting workers with eating issues, medication adherence, and other types of issues. So there's some pretty significant things going on here with the pandemic.
I think that this whole era of the bubbles that families created for themselves, especially when they had a loved one with dementia at home, also shone a light on the intensity of care and how families are really testing the limits of their own relationships in managing it. It is hard to be up close and personal in that environment 24/7. So I think people are beginning to see how many caregivers have lived traditionally. Martin, let's move now to your presentation about some of the current trends in informal care across the globe and how they tend to differ across geographies. It's always a fascinating exercise to see what other people do and how it's defined.
Okay, so thanks very much. So I'm trying to kind of focus here on a little bit of general background. And I thought it would be good, first of all, to look at the extent of the problem at the moment and its distribution. So here at King's College London, we've been working with ADI and WHO over the last 10 years or so to estimate numbers of people living with dementia worldwide. And in 2017, when we last looked at this figure was 50 million, with most people living with dementia actually in the poorer countries in the global south. But if we scroll forwards now to 2050, you can see that these numbers actually treble, reaching ultimately 152 million. But the rate of increase is actually much more rapid in developing countries. In fact, numbers double in high-income countries in the global north, but they treble in Asia and quadruple in Latin America and Africa. Now, obviously, not all of these people need care, but most, if not all, will at some stage in their journey with dementia. Our research with the 1066 Dementia Research Group has revealed that in most or many low-resource countries, most people living with dementia haven't received a diagnosis. And most importantly, they and their families are unlikely to be receiving appropriate medical care, and there are almost no formal social care services that could support, supplement, or in the most extreme needs, substitute for the informal family care. Now, I'm sure we're going to discuss this later, and it's certainly true that care arrangements around the world are strongly influenced by cultural norms. But I really wanted to refer at the moment to some of the aspects that are absolutely universal. So the first is that the family are the first and last bastion of support on which older people can rely. And for dementia care, it's been referred to already. This is particularly likely to lead to strain, practical strain, psychological and economic strain and hardship. So unfortunately, in low-resource countries, this is all too often a journey without maps. And that phrase is actually a quote from a carer in one of our 1066 studies, actually in a rural community in China, a journey without maps. So I think looking at the bright spots, there's a huge amount that's been achieved in the last 10 years. We're all now using a single set of figures. And what that means is that everyone essentially acknowledges the scale of the current and the future problem. And these future trends are, I'm afraid, all too predictable, since all of those who may develop dementia by 2050 have already been born. So dementia has now been acknowledged explicitly as a global public health priority, not least recently through the ratification of the WHO Dementia Action Plan by governments worldwide. And I think a really important component of that is a shift from the original focus, and it was a really sort of unique focus on finding a cure, to a recognition that we need action now on care. We can't wait for that, and we can't be like ostriches with our heads in the sand, ignoring the potential, the actual future that we're all going to be facing. So the problem really has been that action on care has been very slow to develop and advance. And I think what this needs now is much more commitment and focus from governments. It needs essentially health and social care systems that are adapted to actually meet the needs of older people. And this isn't the case in most low-resource countries around the world where this hasn't been a priority. And then finally, and again, an absolutely crucial element of all of this is national conversations. What are the aspirations within a particular country for what we would want for our care arrangements in the future, what we would want for our parents now, what we would want for our children in the future, and to have these informed by cultural values and preferences. This is why the national conversations are needed. And then the planning, the costs to be calculated, and the consideration of how those costs should be met. So these conversations above all need to address the issue, I think, of equity ensuring that nobody is left behind, and that access to essential care services is going to be based on need, not ability to pay, which is certainly the case in most low resource settings at the moment.
Professor, when you look across cultures, is it typically left to the adult female child to take care of their parents?
Yes, I mean, we find even higher proportions of main carers are identified as women, usually a daughter or a daughter-in-law, often with very little support and understanding. So they have limited understanding, actually, of the problem that they're dealing with. But that's even more the case for the rest of the family. And I think this lack of knowledge and understanding about dementia creates what we've identified as being a real problem of stigma, not necessarily attaching to the older person themselves, but to the carer, who is essentially blamed for neglecting, not looking after properly, or even harming or abusing the older person. Because how else do you understand and explain to other people the changes in their behavior, their agitation, and their distress?
What are the trend lines that you see?
Sorry, I was going to say, but the care arrangements are very interesting. We did a kind of really detailed study on this, involving diverse countries in Latin America and in China, and we found and Nigeria, in fact, and we found very particular arrangements in the China setting, which was Beijing and a rural community outside of Beijing, Daxin, with a huge amount of ingenuity, creating a kind of comprehensive care system that shared the caring roles amongst different family members and different households. So probably the slightly adverse aspect to this was that the person with dementia was moving around to spend, the winter months with one family member and then to move to another son or a daughter-in-law for other aspects of their care. So one has to be extraordinarily resourceful under these circumstances, because advice, and in particular material assistance, is not coming from elsewhere. So families need to kind of calibrate their response in order to mitigate the impacts that would otherwise have on household and family incomes in particular, and on their livelihood prospects.
Ironically, 75% of long-term care in the United States is informal care. And as caregivers, we often wondered, what's the government's plan B if we get, just based on the sheer dollar value of informal care in this country? Yeah.
Absolutely. And I think it is this difficulty, this lack of a plan B. And I think in many traditionally orientated societies where notions, as you say, of filial piety in East Asia, of respect for and care for older adults in the Hindu religious scriptures in India, means that there's a kind of an automatic assumption that the family will provide. But of course, this is challenged by trends within society. So children are much more likely now to move away or migrate within country to cities or internationally. And while they can provide financial support through remittances, they're often no longer available to actually provide hands-on care. And the other thing is that fertility has been falling for years in many of these countries. So people actually have fewer children. That's obviously particularly marked for the coming generation of older people in China as a result of the one-child policy. So I think the idea that families are available and will provide seamless care in all the circumstances, it plainly isn't true at the moment. And it increasingly isn't going to be true in the future. But families, but governments, mindful of the fiscal implications of all of this, want to bolster that care approach without actually doing much effectively to support it materially.
Thank you. Melissa, your Global Coalition on Aging really focuses on innovation. And let's move to your presentation that really looks at how innovation disrupts disrupt the delivery of informal care across the globe and how we prepare for what's coming our way.
Thank you, Meryl. Yeah, let's pop that up. So I want to touch on the point that you and Martin were just speaking of about just sort of the sustainability of care overall. Because it's connected to lower birth rates. And so in the EU, there's a sharp decline in birth rates from 12.9 per thousand to 9.3 per thousand. That's just between 1985 and 2030. And that the projections are that the total numbers of family carers will need to increase by up to 50% by 2050 to maintain the current ratio of family caregivers to elder care recipients. So we're seeing that we need innovations in who's going to provide the care, what technologies are going to provide that care, how do they work in consultation to each other, because it's not sustainable for family caregivers to carry this whole burden. And that's part of what we've been looking at, particularly coming out of COVID, and I'll hit on this topic first. The pandemic really is now this lens through which we are looking at innovations for an aging population. In the spring, the Global Coalition on Aging held a dialogue series amongst our members and our advisors to explore areas for learning that we see that are emerging from the pandemic. And here are just a few of our main points in terms of what we learned. They all touch on caregiving, so I think it's really interesting to see that, and actually not terribly surprising. First, through vaccines, therapies, telehealth, and telemedicine, we've seen incredible examples of expedited innovation. We need to make sure we learn from those, and we need to make sure that we can push those forward in other areas of healthcare and beyond that. That gets to the second point, work itself. It's obvious that work, how and where we work, for so many of us, it's forever changed. And caregiving responsibilities have a big piece of that. How a workplace provides benefits for those with those responsibilities is really critical. Third, we've seen these unintended consequences from lockdowns, from staying at home, from quarantines. There's been social isolation, there are misdiagnoses, late diagnoses, challenges in medication adherence, and this requires more creativity in overall healthcare delivery, where the home is preferred and safer for delivering care. Fourth is just the simple fact that caregiving is essential. Whether a family member or a professional caregiver, human caregiving cannot be foregone, even in a pandemic and when we have to stay farther away from each other. The fifth point is that older people have been viewed, unfortunately, as dispensable during the pandemic. And this ageism in healthcare and across society is just terribly dangerous. There's a point that Gisela Dolan, one of our members from Home Instead, says during COVID, and I don't know if you guys can't see it, but I can't see it very well. It says she says during COVID, many of us have experienced intense social isolation for the very first time. But for so many older adults, this is what they experience every single day. So the human connections that caregivers provide is sometimes their only lifeline. So it's very important to make sure that we have that human connection, even though we've seen the benefits of technologies. So what we also did is we talked to our members. 44% of our members surveyed said that COVID is increasing the workplace generational divide. And so this is a real challenge with respect to an aging workforce that, of course, is going to have growing elder care responsibilities. Ageism, sadly, is the last acceptable form of discrimination in the workforce, even though it's illegal in the United States, at least at the ripe old age of 40. But this is the age when you see there's more caregiving for kids, caregiving for older adults, and all that really kicks in. And so again, it's back to that stigma. So we also asked about the sandwich generation, those who are balancing their childcare and elder care responsibilities with work. And they said that these lines are clearly increasingly blurred during the pandemic, while workers were also more likely to share their own caregiving and home responsibilities during the pandemic, which opens up really important lines of communications. So 88% of our members said that we have to make sure we're elevating this conversation at work, and it's okay to talk about caregiving because these challenges aren't going away. We're going to see more and more. So, kind of part of this, is how we address it specifically, Alzheimer's and dementia care within the Global Coalition on Aging. We have worked for the past several years in partnership with Alzheimer's Disease International, and this year we were supported by the Lian Foundation of Singapore in our Dementia Innovation Readiness Index. In the past, we looked at countries to see how prepared they were to innovate in Alzheimer's and dementia treatment, prevention, and care. This year, we zoomed in on cities. We said, why cities? Because we see that they're major hubs for innovation, and they have the capacity to be the epicenter of implementable solutions and action-oriented policies. So we looked at 30 global cities across the spectrum at different levels of developing their policies. And I hope that you guys will all check that out after this session. Our goal was to make sure that we were inspiring collaboration. We just had a session on this about an hour ago, and I think that was the clear sense, is that we need to make sure we're collaborating across cities, across countries, across sectors. We need to share those best practices, because in that we can marshal support for productive policies and ultimately improve outcomes for people living with dementia, their caregivers, and communities around the world. So some of the findings, and again, I'm seeing it kind of grainy, but we had a section on access to care and being sure that we could provide care for people living with dementia is critical. And it's clear that people living with dementia need help, and their caregivers need help navigating the care pathway. They need infrastructure to ensure proper training for formal and informal care. We all need to recognize the tireless work and the indispensable value that caregivers provide. And we need a movement towards making sure that care can be provided in the home as much as possible, as much as can be supplemented by innovations like technologies. We can dig into that a little bit later as well. But I'm going to pause there for sort of these opening remarks in terms of how we are thinking about the pandemic response and how that relates to how we can provide better care for people living with dementia moving forward.
Thank you. Sue, let's look at how informal care factors into value assessments and quality of life. You've been looking at that extensively.
Yes, thank you, Meryl. So the short answer to that question is that informal caregiving is not really factored into most cost-effective analyses for new treatments, and when it is included, it's usually not done very well. But I'm going to back up a moment and first just give a brief background on what it is meant by value assessments for those who might not know. And I know for a lot of people, this just makes your eyeballs go back into your head because it's boring. But I will say that a lot of times, the infrastructure type things that can be the most boring can also be insidious. So it's important to understand them. And a cost effectiveness analysis estimates the costs and health gains of alternative interventions. And in many countries that have single payer systems, cost effectiveness analyses help governments prioritize the allocation of resources by identifying health interventions that have the potential to yield the greatest improvement in health for the least amount of resources. So many countries outside the US use what are called QALY-based cost effectiveness analysis. And the QALY, or the Quality Adjusted Life Year, is a health economics measure that represents the degree to which a drug or a treatment extends life and improves quality of life. And the QALY assigns a value to a human's life on a scale between 0, which is death, and 1, which is perfect health. And QALYs gained widespread use in 1960s by the British government when they were looking for ways to ration healthcare for the National Health Service. And this was when organ transplant and other higher priced technologies were starting to take off. This type of rationing in many European countries can sometimes, result in access issues. We tend to get access to newer treatments much quicker in the United States. And in some cases, it also translates to higher mortality rates for chronic diseases, particularly with regard to cancer compared to the United States. So overall, QALYs tend to distort our ethical instincts by placing a lower value on people's lives when they have less life years ahead of them or less perfect health ahead of them. So Alzheimer's disease patients present a moral quandary when it comes to QALYs, since the majority of people with Alzheimer's disease are the oldest old. And Alzheimer's Association in their facts and figures shows that of those with Alzheimer's over age 65, 80% are 75 or older, and more than a third are 85 or older. And in addition to that, a lot of folks have multiple chronic conditions, which further rates you downward. So if you have congestive heart failure, chronic kidney disease, diabetes, things that are commonly associated with Alzheimer's, it makes the threshold for treatment to be cost effective a little bit higher. And Alzheimer's disease often includes a lot of other symptoms that for which there are treatments like psychosis, agitation, that are in clinical development, along with disease-modifying medications that are also being worked on right now. But QALYs don't value symptomatic treatments that might only improve quality of life but don't lengthen life as valuable as disease-modifying treatments. So it's another sort of downside. And history is a good teacher of this, because if you look at, in Britain in 2005, the National Institute for Health and Clinical Excellence, which is known as NICE for short, proposed that cholinesterase inhibitor drugs for the treatment of dementia, like Aricept, be banned to National Health Service patients on the grounds that their cost was too high and, quote, outside the range of cost effectiveness that might be considered appropriate for the NHS. And that was despite the admission by NICE that the drugs were effective in the treatment of Alzheimer's, and they had approved even more expensive treatments. And the effect was that thousands of patients would have been denied the only treatment available. Now that was reversed because there was a lot of activism in the patient community by the developers, and things changed over time, but it took a little while. And to the question of the significant burden on family caregivers and society, QALY models tend not to do that. There are some that do it a little bit, but they tend not to do it as comprehensively as needed. And so then they're not recognizing the value of treatments that may help alleviate the burden on family caregivers and society. So I'm going to show you in my next slide. Let's see if oh, thank you guys. Oh, actually, can you click one more time? Thank you. So I mentioned that cost effectiveness analysis often doesn't include the impact of Alzheimer's or related dementias on family caregivers. And there was a study in 2019 from Tufts that looked at 63 Alzheimer's or related dementia cost effectiveness analysis and found that while most of them considered some components of informal care costs, they largely ignore how a new intervention might affect caregiver health-related quality of life, which can often be valued higher than if you were thinking about like an hourly rate for the actual caregiving. So in the analyses where caregiver health effects are included, they tend to lead to more favorable cost effectiveness estimates, or even consider the intervention cost savings. So why is it important to include the impact of health effects on caregivers? Family caregivers of people with AD or related dementias are more likely than non-dementia family caregivers to help with patients' emotional or mental health problems and challenging behavioral issues. And as a result, AD and dementia-related caregivers have an increased risk of anxiety, depression, sleep disorders. There's also a higher risk of economic hardship as a result of lost work and care expenses and adverse health consequences that come along with that. National survey data shows that employed AD and dementia-related caregivers were more likely to need to go in late or leave early, reduce their work hours because of care responsibilities, or give up working entirely compared with non-dementia caregivers. And Meryl, I know that was an impact on your experience. So studies that are conducted from a societal perspective should really incorporate all costs and health effects, regardless of who they affect, with the person around that patient, and regardless of whether the costs and health effects are within or outside of the health sector. And in practice, cost effectiveness studies across all diseases typically just focus on outcomes of the patient alone, because broader impacts related to caregiver burden can be challenging to measure and incorporate into these analyses, and as a result are often left out. And that penalizes Alzheimer's related cost effectiveness studies in particular, and we really need to change it.
Thank you, Sue. It is really quite striking. I mean, we are a desperate patient population. And are there useful alternatives to the QALY when you're measuring the effect of Alzheimer's treatments?
There are some, I should say, that are in development. There are no sort of standard accepted ones. There's multi-criteria decision analysis is being looked at, both with QALYs and without QALYs. There's also value-based arrangements that are being considered that actually take out QALY-based assessments and focus more on health outcomes. And we would be much more in favor of those. I would like to see the patient and sort of sizing up the individuals taken out of the equation. We don't do this for other consumer products. And there's no reason why we do it, for healthcare other than to just, put people into different buckets of who deserves and who doesn't.
Thank you. We have some interesting questions coming in. Martin, I'd like you to take this one. It says carers are sometimes accused of elder abuse or neglect when in fact the carer themselves isn't receiving adequate care. Can the panelists comment on that gray area of unprepared carers and how that might contribute to a major concern for elder populations of abuse and neglect?
Yes, I mean, I'm often concerned actually around, the way in which abuse or neglect is categorized, but in particular identified. And I think we need to be very cautious about this around the world, actually. We do need to be very mindful of the extreme levels of strain and difficulty that can be involved for the caregiver and in the relationship that the person with dementia has with their carer, and the way in which a lack of clear knowledge, understanding, advice, support, and training actually can transform the situation in which care is being provided in order to improve the quality of that care, improve the well-being of the person with dementia, improve the well-being of the carer. And we've spoken already about the fact that it's usually one carer who doesn't receive a lot of support sometimes from the more extended family network and whose role is not well understood. So again, the potential importance of respite and sharing care. So, probably amongst the most effective and most consistently demonstrated effective interventions in the field of dementia are caregiver education, training, and support interventions. In a high-income country like mine, what proportion of even those people with a diagnosis of dementia, have their families and their informal carers actually receive the benefit of a structured intervention? How often do their care needs get reassessed and further support and changes to the care arrangements are being suggested? And as we've discussed before, in low resource settings, even though, kind of 8 or 9 years ago, we developed with Alzheimer's Disease International something called the Helping Carers to Care intervention, which was a kind of modification of quite sophisticated high-income country interventions delivered by occupational therapists or psychologists, designed to be administered by lay health workers. And we found actually that the effect sizes on not only the quality of life of the carer, but actually the quality of life of the person with dementia were somewhat larger than were typically seen in high-income countries. Our hypothesis around that being that it's like, the drops of water in the desert, really, that where there's been absolutely nothing, and then suddenly something arrives that puts this in context for you, gives you a framework within which to work. It can have dramatic effects. So, I'm really enthusiastic about the World Health Organization's integrative care for older people package of care guidelines, because this is not about dementia specifically, but it's not about stroke, it's not about Parkinson's disease, it's not about heart disease, it's about older people and their healthcare. And it addresses cognition and low mood and continence issues and mobility in a really holistic way. But a core component of it is a package around assessment of care needs and support for caregivers. This could be delivered in low-income countries, but the thing that worries me is that even in high-resource countries, we haven't made a great fist of that yet.
I would like to bring up the whole. Yes, go ahead, Sue.
I just wanted to add, I thought Martin gave a very good comprehensive answer, but I did want to add the issue of neuropsychiatric symptoms. And, we focus a lot in dementia care on cognition and on activities of daily living, and the issues related to agitation, aggression, dementia-related psychosis, depression, apathy. Those types of issues tend to be quiet. We just don't discuss them openly as much as we should, yet they're incredibly common. And they tend to be the most challenging, along with continence issues, in dementia care. And I think that's a real area for education, both formal caregivers as well as informal caregivers. And I think there's also a lot of stigma around intervention and treatment of them. And oftentimes there is this overcorrection. And I agree with Martin, you have to be careful. But there is this kind of overcorrection attitude that people are just abusing people with dementia when they're trying to intervene in a way that can improve quality of life. So it's really important that we just have more open discussion about neuropsychiatric aspects of the disease.
I think that is such a statement. I would love if the team can bring up a slide, because we all have stories to tell. And if you have it up, unfortunately, I am operating in the blind. I can't see our panelists. But if you see the picture of my husband and myself, I spent 20 years trying to get inside his head, trying to be his co-pilot, advanced team. But if you look at the photo, what is missed is the grasp on my wrist. If I had moved my wrist and tried to get away suddenly, he would have crushed it. And I think that whole current that you've brought up, Sue, is so critical. We are bringing loved ones dignity, and behaviors are really the first that force you to withdraw and isolate with a loved one. And it's really all about dignity. And I think the carer is silenced because if you were to describe it to your adult child, they might say, well, it's time to put your loved one away, or take away the autonomy you have as someone who is caring for a loved one. So it is a very tricky space to be in. My husband was misdiagnosed for four times, too young, too smart. So that whole area, to me, is another area that I would love us to explore, which is the early diagnostic area, because it sets up a dynamic, Melissa, in your group, because people are juggling work, trying to juggle behaviors they begin to see in a loved one. Not what it is, 50% of people go undiagnosed. whole area of the diagnostics getting better, and where does the caregiver come in? And it was striking to me coming out of Lausanne 7 that there were reports by several researchers, both qualitative and quantitative, on the fact that the informal care comes in much earlier, not in stage 3 or 4 of a disease, but much earlier when you're running interference. And I think that is an area that does deserve much more attention. Melissa, can you address that issue and the dynamics it sets up both in the workplace and in the home environment?
Described, Meryl, it's just challenging all around. And I think exactly what you're talking about from balancing all of this, the nature of a caregiver is someone who takes care of everyone else's health and well-being ahead of their own. So the really critical piece of this is that caregivers themselves need support. So there are what we've seen, respite, clearly they need to have respite from some of these care responsibilities. We're seeing home care is becoming more and more prevalent and accessible to people so that they can have a break, so that they can make sure that they remain productive in the workforce. And there's special training for Alzheimer's and dementia caregivers to make sure that that type of support is provided. And what we're also seeing in the workforce is that employers recognize the increasing and growing burden of those who are caring for aging loved ones and providing benefits and supports. They're providing affinity groups, they're providing referrals, they're providing resources to ensure that there is support for these working caregivers. And I think pointing back to the abuse and fraud question with older people, we've done a lot in the financial services space with a number of our financial services companies, and Bank of America has looked into this issue, and we know that financial acuity is one of the sort of skills that sort of declines soonest. So if family members, if financial planners can have a sense of what that looks like, that's a way of caregiving. That's a way of looking out and detecting as early as we possibly can. And at Bank of America, they have a gerontologist on staff. They have training for their financial advisors and their clients and their employees, so that we can start to detect some of these issues a little bit earlier, and so that we can make sure that people are then able to get the care and support that they need. So I think it's both, of course, on the care recipient side. We need the support and the right support, but that can't happen unless we have the right people in the care ecosystem having their eyes and ears open for these signs of cognitive decline.
I don't know the global numbers, but in the US, 50% of support services in the US aren't used. So you have to begin to wonder, why not begin to track both the patient and the caregiver dyad to intervene before the caregiver becomes that second potential patient, which is hanging out there now because of the cumulative stress and intensity of care over years. Martin, that whole issue of stigma, we're much more aware of Alzheimer's as a disease, and yet for many people it's still viewed as a normal part of aging. When you have earlier diagnosis globally, do you feel that the stigma is just moving younger? And what are the implications?
So this is a really difficult one, because I remember when we started off with the 1066 Dementia Research Group, which was actually way back in 1998. And I can remember, discussions, even with, medical colleagues and neurologists, for example, who would say things like, well, of course we have dementia in India, but we don't call it by anything. And you don't come here with your Alzheimer word, because that's only going to frighten people. The German names, and there's no need to put a label on it, they would say. And essentially, I think what they were concerned about was the medicalization of something that they felt was satisfactorily accommodated within society as, if you like, a normal part of aging. But of course, in the Alzheimer movement, in Alzheimer's Disease International, a tenet for a long time has been that it has been important to name this, to identify it, to ensure access to support and help and more effective treatments as and when they become available. So I think I can see, to an extent still, some benefits on both sides. In China, for example, when we were trying to do our diagnoses through surveys, the Chinese colleagues, when we visited, would say, we're having a bit of a problem because the survey tool is coming up with a probable clinical diagnosis of dementia, and the family say, there's nothing wrong. And you would go and visit into, a small farmhouse with an extended family and a grandmother sitting in the corner, plucking away at, a towel that she had on her lap. And you'd kind of talk through things, and you realize after a bit of really detailed questioning that actually there was severe cognitive impairment. But the point is, what would an old be expected to do in that society at that time? They're not expected to shop. They're not expected to manage budgets. They're not expected to cook. Their clothes are laid out for them with a bowl of water to bathe with in the morning. And so as far as the family was concerned, they probably actually hadn't really noticed much practical difference. So in all the usual sorts of questions you ask, so that having been said, why are we identifying a problem here? I think the virtue of the dementia diagnosis, which I'm very pleased to see ADI is going to be prioritizing as the theme for their report next year. We last looked at this, I think, in 2011. Is its predictive validity. Otherwise, at the moment, there's no point in doing it. But it allows everyone to prepare, services to prepare, families to prepare, older people anyone who attracts that diagnosis to prepare. And even though we don't have a lot of interventions that make a difference to the course of this process at the time, I think there is immense benefit in that. And amongst those benefits is the destigmatization of the problem, because everyone kind of knows what to expect. And when something crops up, they know which box to put that in. That's the dementia talking. And it can just radically alter the circumstances.
It's striking that the cloudy nomenclature around early stages of dementia makes a diagnosis even more confounding. And you're trying to, what is MCI versus early stage Alzheimer's? And I think it adds to confusion among those receiving the diagnosis about, so what's next? That journey you said without a map that you referenced earlier. But I think this is an area, because labels are limiting, and as we know, a disservice to us all. I mean, many, probably across cultures, but you're the expert, Martin, reject the term caregiver. I'm a mother, I'm a daughter, I'm a grandparent. That whole labeling, is there any way we can come up with a new nomenclature? I know we try, and it doesn't change what we do for loved ones. But how do we manage this going forward? Because it's going to continue to get messier and messier.
Yeah, I don't know. I mean, people have looked at kind of pejorative terms in national languages, like, for example, in Japan, where they created a less stigmatizing phrase to describe dementia itself. But it's very interesting, this one around caregiver, because of course all of us have caring responsibilities for somebody pretty much throughout our life course. And I think what's almost unique in dementia is the kind of concentrated nature of that care and the way in which the demands progressively increase over time in a somewhat predictable way. But essentially naming somebody as a caregiver, I think, does a disservice, because it's that we want to get beyond the idea that it must be you, that there's no one else, that there's no one else's support available, that you are irreplaceable, and to make it something that's much more of a shared effort within the full family network, because the impacts are going to impact upon the entire family network. There's no doubt about that. And one in which the state or agencies that are supported by the state can then come in and provide additional support when it's needed, and to ensure that those services are as high quality as any family and any older person would have the right to expect.
I'd like to add into that. I think, can I add into this, Meryl? The point on sort of the perception of a caregiver, we're doing some work in this space to look at professional caregivers as well as informal caregivers. And clearly on the professional caregiver side, we have a dearth of professional caregivers. There are shortages around the world. There will continue to be with the growing aging population. As we've already talked about, there is a shortage of informal family caregivers. And so we need to see that this supply-demand issue that we have actually should encourage us to recognize the incredible value that a caregiver plays. So I think there is a societal shift in recognizing the value that this role, the value that this caregiving as a profession also plays across society. And we're clearly not there yet, but these are critical roles. I mean, we think about who we want to care for our family members, and if we can't do it, we certainly want someone that we trust. We want someone that is well trained. We want someone that is happy with the work that they are doing and proud of the work that they are doing. And we need to bolster this as a field. And I think the impacts are on the profession itself, but also on informal caregivers.
Melissa, it's been very striking to me that the caregiver is the ability to validate what the caregiver does in their space. That we would be great data collectors for in-between visits. I mean, you're in the space of innovation. Arm us with the technologies. Don't take our word for it. And that has always been the issue about self-reports. It's too subjective. But arm us. What might we do that makes us part of the team that helps accelerate the research or in between times? Because we need caregivers to get our loved ones into the clinical space and trials, and that will be even trickier as we move earlier in the disease space. So this is where innovation, to me, has a tremendous role to play, and not just robotics replacing us. I can never forget that Wall Street Journal article that had from Japan showing how robotics would be replacing the caregivers.
No, we don't believe that's the case at all. The human component of caregiving will always be, the simple touch, that has an impact on, stimulates your brain. And those are very important things. And what we're seeing in our space is that the important thing is to make sure that older people, their caregivers, are involved in things like technology innovation, right? So if you're going to monitor someone, don't just throw a piece of technology at them. You can walk into a house, you see an iPad is not used because it wasn't developed in a way that the tactile senses of an older person's skin may not really work for the iPad. But there are new technologies out there that are able to do that. We worked with one of our members, Aegon, and they had a pitch competition called Silver Starters. And the winner was an 83-year-old man who had spent a large part of his career at IBM. And he said, I love when my son, checks on me, but I don't want him invading my privacy. So he invented an app that checks his energy uses throughout the day. If something's awry, then his son can come and check on him. But if it's not, then everything is okay. And I think we're getting to the point where if we're devising some of these tech solutions that can help monitor and even use AI in the future, but we have to do that, in collaboration with the people who need to use the technology. And I think that's the struggle that we've had up until now.
One thing we can't change is time, and time is so finite. This session has really gone by. We have time for a quick final question. Sue, I'd like to lead off with you with what most urgently needs to change in how we are responding to informal care.
Yeah, I mean, to me, one of the things I think that we can most take away from the crisis of this pandemic that can teach us a lot is that we can change things. And it doesn't have to take 10 years, but it can be over an afternoon. We, kind of turn things around quickly to respond to this virus. And, quality-based health economics is outdated. It doesn't respect people based on their age or their disease that they're experiencing. We need new models. Let's throw out the bad traditions out the window. Let's diagnose people better. And let's be much more ambitious about how we want to live.
Thank you. Sue, you got the last word. Thank you all for joining us. We could definitely continue this conversation. In closing, I thought I would reach out to Atul Gawande's. In Being Mortal, he writes that betrayal of body and mind that threatens to erase our character and memory remains among our most awful tortures. So the battle of being mortal is the battle to maintain the integrity of one's life, and that all we all ask is to be allowed to remain the writers of our own story for as long as we can. Thank you so much for joining us. I'm Meryl Comer. I hope this session has been valuable.